Northern Secretary, Dr. Kumar, past state teacher, higher education, Dr. Ajit Pastor, state secretary, PEPS, Dr. Vinci, organizing secretary, Cgpcon 2020, Dr. Niti, chairman, Kozhikode committee, will be joining us shortly. We will begin with the flag salutation. Silent prayer. Flag salutation.
We, the members of the Civil Association, stand here to salute our national flag. Its honor and glorifies our identity and its source of our We pledge our allegiance and realize our responsibilities as an accredited members of the national organization. We say we will dedicate everything in our power to see it righted in the community of nations. Jai Hind.
All please. Welcome Mrs. Dr. Kumar, organizing chairperson, Cgpcon 2020.
Good morning, respected President Dr. Venu, our Chief Guest Dr. our principal, the work of the last year. We have not still seen the next principal and the respected dignitaries on the dais, our secretary, Dr. Sandhya, and our beloved Dr. Ajita, joint secretary, and all time IIS support and the dais, Dr. Kozhikode and Dr. Ajit Pastor, and my secretary, and also the distinguished members of IIS. And I am really privileged and honored to stand before you, and my duty is to welcome for the Cgpcon to be organized today, and it's an all-day academic event. And after we have entered into Cgpcon, there are continuous academic activities going on, and as we all think, we have to go to personalized management and personalized care and team approach as we always portray in the today's world of treatment. And I think this CGP has a great role to play to adapt together and to learn about what is happening in the medical practice and other specialties. And I'm going to move on to my duty. I welcome Dr. Anil Putri is very soon will be joining us, Chairman, Kozhikode District Committee, and I extend a warm welcome to him. And also next I welcome our beloved Principal of Cgpcon, Sir has kindly consented to inaugurate the function. Thank you, sir, for being here for the inaugural function, and I extend a very warm welcome on behalf of all of us down here today. And I also extend my sincere gratitude and welcome because they were the key persons in crafting the program. You can see it's an excellent academic program in the galaxy of teachers and chairpersons. Excellent, very happy welcome to Dr. Venu, our President, and Dr. Sandhya, our Secretary of Kozhikode IIM. And we are all very privileged to have Dr. Ajita PN, North Zone Joint Secretary. Very soon we will be seeing her as the wife of the Parliament. Raskar, our past president, as well as currently State Secretary, perhaps extending a warm welcome to all. And
always Ranjit is there with me in supporting and doing, because most of the work is being done by Ranjit only. Welcome, Ani. And you can see all the beloved faculty and chairperson who have invited has agreed unconditionally, and I am very thankful, and most of them will be joining us very soon. But I am extending my warm welcome, our beloved speakers, Tulasidaran sir, former HOD of medicine of our own institution, and Binoy Paul sir, and the chairpersons, Dr. Sushama and Dr. Jayendran has already joined, and all others will be joining soon. I extend a warm welcome to all the speakers and faculty chairpersons, and a very hearty welcome to all the dignitaries of IMA Kozhikode who has joined so early on a Sunday morning for this academic program. Welcome to all. Thank you so much.
Thank you, madam. Next, we have the presidential address by Dr. Anin Kuti, Chairman, Kozhikode District Committee.
Respected Chief Guest of the day, Dr. E.V. Gopi sir, President of IMA Kozhikode, Dr. Venu, Secretary Sandhya, Dr. VGP, Ajit sir, Ajita madam, Chandni madam, Ranjit, senior faculty members and dear friends. It's a great opportunity to interact with the youngsters through an academic program, and I congratulate Venu and Sandhya to bring up this new concept of district CGP meeting, and for organizing it under the Kozhikode district. I think we have a lot of venues in IMA, the cultural, the academic, everything. But we see very less of youngsters coming in. We have a lot of members here still. So I think this stage has to be taken for an interaction on how the youngsters want IMA to work, or what programs we should come up with to bring up more youngsters to IMA, because IMA stands for all the medical professionals, and you have seen in the last month, we have dealt with a sorry incident for an young doctor, upcoming doctor, and no other organization other than IMA had stood for the noble cause. So I think it's high time all the doctors join IMA and work for the unity of the health professionals, modern medicine health professionals of Kerala and India. And I think earlier the older generation had their own views of doing it. We all had. But youngsters are in a new techie era, and I don't know what, I have interacted with so many, but we have not found out the mantra which we can crack with the youngsters. So I think we should take this opportunity to interact with them in the evening to bring up more people also. And I wish all the success for the academic program. Thank you.
Thank you, Anin sir. Ladies and gentlemen, yesterday we lost a brother and sister to suicide for reasons best known to them. Let us remember these two souls. A short prayer, please. Time for introspection. Thank you. Inaugural session. I call upon Dr. E.V. Gopi, former Principal, Government Medical College, Kozhikode, to come forth and light the lamp.
A warm good morning to everybody. I would thank the President IMA, Venu, Secretary Sandhya, and Anian Gutti, Ajit Bhaskar, and VGP, and other dignitaries of the lives, and my respected teacher, Regindranath, while I was a student, he was my teacher, medical guest, and other great personalities. As we were invited to inaugurate the session, I thought still I am in the halo of the principalship. I just out of throne as a principal Calicut Medical College. But once more, thank you Venu for inviting me, and also Chandini. She was a very active department, emergency department, everywhere she was very active. IMA also, I think she is so. And I was IMA president for 5 times of IMA Tamiracheri branch. Largest branch after Calicut, IMA Tamiracheri is the largest branch. And so, on the behalf of that branch also, I have expressed my gratitude towards inviting me to inaugurate this session. Today morning, വളരെ വിഷമിപ്പിക്കുന്ന ഒരു വാർത്തയാണ് മനോരമയിൽ കണ്ടത്. അത് 70 വയസ്സായ ഡോക്ടർ ദമ്പതിമാർ, അവർക്ക് എല്ലാം ഉണ്ട്, പണമുണ്ട്, എല്ലാം ഉണ്ട്, വീടുണ്ട്, പക്ഷേ കമ്മിറ്റഡ് സൂയിസൈഡ്. IMAക്ക് അത് എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ? ആലുവയിൽ എനിക്ക് വായിച്ച് മനസ്സിലായ ഒരു ഓൾഡ് ഹോമിലായിരുന്നു, അതിനുശേഷം ഇവിടെ. അപ്പോൾ അവർക്ക് മനസ്സിൽ സന്തോഷം കിട്ടിയിട്ടില്ല എന്ന് നമുക്ക് ഇതിൽ നിന്ന് മനസ്സിലാക്കാം. അപ്പോൾ ഈ IMA പോലെയുള്ള അസോസിയേഷൻ നമ്മളിപ്പോൾ ഇനി റിട്ടയർ ലൈഫിലേക്ക് പ്രായമായിക്കൊണ്ടിരിക്കുകയാണ്. അപ്പോൾ IMAക്ക് ഒരു ഓൾഡ് ഹോം സ്റ്റാർട്ട് ചെയ്താൽ വളരെ നന്നായിരിക്കും തോന്നുന്നു. എല്ലാവർക്കും ആവശ്യമുണ്ട്. നമ്മൾ വിചാരിക്കും മക്കളുണ്ട്, എല്ലാവരും ഉണ്ട്, പക്ഷേ പറയാൻ പറ്റില്ല എന്താ സംഭവിക്കുന്നത്. പ്രായമാകുമ്പോൾ ഒരു ഓൾഡ് ഹോം IMAക്ക് ഉണ്ടെങ്കിൽ അവിടെ നിന്ന് വായിക്കാനും ചിന്തിക്കാനും പ്രാർത്ഥിക്കാനും ഒരു ആശ്രമം പോലെ ഒരു അഭയകേന്ദ്രം ഉണ്ടെങ്കിൽ നമുക്കൊരു ഒന്നുകൂടെ റിട്ടയർ ലൈഫ് ഒന്നുകൂടെ ഭാവി സുഖകരമായിരിക്കുമെന്ന് ഞാൻ ആലോചിക്കുകയാണ്. അത് IMAയുടെ ഭാരവാഹികൾക്ക് ആ തരത്തിലൊന്ന് ഈ അവസരത്തിൽ ഒന്ന് ചിന്തിക്കുന്നത് നന്നായിരിക്കും. അത് കാലിക്കറ്റ് IMA ആയിരിക്കട്ടെ, അതിന് മുന്നോട്ട് വരേണ്ടതെന്ന് ഞാൻ ആശംസിക്കുകയാണ്. അപ്പോൾ ഈ CME അതായത് പ്രോഗ്രാമിന് CGP ഡിസ്ട്രിക്ട് കോൺഫറൻസ് ഞാൻ എല്ലാവിധ ആശംസകൾ നേരുന്നു. അത് ഉദ്ഘാടനം ചെയ്തതായിട്ട് പ്രഖ്യാപിക്കുന്നു. എല്ലാവർക്കും എൻ്റെ നന്ദി, നമസ്കാരം.
Thank you, Gopi sir. I request Chandni madam, the organizing chairperson of this conference, to hand over a small memento to EV Gopi sir. Thank you. Next, we have the address by the branch president, Dr. B. Venugopalan.
ഇന്നത്തെ ഈ പരിപാടിയുടെ അധ്യക്ഷൻ ഡോക്ടർ അനിയൻ കുട്ടി, നമ്മുടെ ഈ പ്രോഗ്രാം ഇനോഗ്രേറ്റ് ചെയ്ത ബഹുമാന്യ പ്രിൻസിപ്പൽ ഗോപി സാർ, വേദിയിലും സദസ്സിലും ഇരിക്കുന്ന പ്രമുഖ വ്യക്തിത്വങ്ങളെ, വളരെയധികം വിഷമത്തോടും അതേസമയം സന്തോഷത്തോടു കൂടിയാണ് ഇന്നത്തെ ഈ ദിവസം ഞങ്ങൾ തുടങ്ങുന്നത്. കാരണം ഇന്നലത്തെ വളരെ ദാരുണമായൊരു സംഭവത്തിൻ്റെ പശ്ചാത്തലത്തിൽ നമ്മളെ സംബന്ധിച്ചിടത്തോളം ഈ ഒരു അക്കാഡമിക് പ്രോഗ്രാം ക്യാൻസൽ ചെയ്യാൻ പറ്റാതെ ഒരു അവസ്ഥയിലേക്ക് ആയിപ്പോയി. അത്രയും അഡ്വാൻസ് ആയതുകൊണ്ട് മാത്രമാണ് നമ്മളിത് കണ്ടിന്യൂ ചെയ്യാൻ ആഗ്രഹിക്കുന്നത്. കാരണം ഇന്നലെ രാവിലെ ഉണ്ടായിരുന്ന കൺഫ്യൂഷൻ, റാമനോഹർ എന്ന പേരുണ്ടാക്കിയ കൺഫ്യൂഷനും നമ്മളെ സംബന്ധിച്ചിടത്തോളം നമ്മുടെ തൃപ്രയാർ IMA ഫൗണ്ടർ സെക്രട്ടറി കൂടിയായ ഒരു കപ്പിൾ നമ്മുടെ കണ്ണിൻ്റെ മുമ്പിൽ വെച്ച് ജീവിതം അവസാനിപ്പിക്കേണ്ടി വന്നൊരു വളരെ വിഷമകരമായ ഒരു സാഹചര്യമായിരുന്നു. ഈ ഒരു അവസ്ഥയിൽ തന്നെയാണ് നമ്മൾ കോഴിക്കോട് IMA പ്ലാൻ ചെയ്തിരിക്കുന്ന ഫ്ലാറ്റ് പ്രോജക്റ്റ്, അതിൻ്റെ സ്റ്റാറ്റ്യൂട്ടറി പേപ്പേഴ്സൊക്കെ മുന്നോട്ട് നീങ്ങിക്കൊണ്ടിരിക്കുകയാണ്. അതിലൊരു സീനിയർ സിറ്റിസൺ ഫ്രണ്ട്ലി എന്നുള്ളൊരു കൺസെപ്റ്റ് കൂടി ആഡ് ചെയ്തുകൊണ്ട് തന്നെയാണ് നമ്മൾ മുന്നോട്ട് നീങ്ങിയിരിക്കുന്നത്. അപ്പോൾ അതൊക്കെ മുന്നോട്ട് വന്നു കഴിഞ്ഞാൽ, അത് പ്രാവർത്തികമായി കഴിഞ്ഞാൽ ഇങ്ങനെയുള്ള ഒറ്റപ്പെടുന്ന അവസ്ഥകൾ മാറുമെന്നും ഡോക്ടർ സമൂഹത്തിന് ആവശ്യമായ സപ്പോർട്ടുകൾ കൊടുക്കാൻ വേണ്ടി ഏതൊരു IMAയും പോലെ IMA കോഴിക്കോടിനും പറ്റുമെന്നും ആഗ്രഹിക്കുകയാണ്. മാത്രവുമല്ല, ഈ ഒരു ഇന്നത്തെ ഈ കോൺഫറൻസിനെ പറ്റി പറയുകയാണെങ്കിൽ, IMA എപ്പോഴും സ്പെഷ്യാലിറ്റികളെയും കോർപ്പറേറ്റ് ഹോസ്പിറ്റലുകളെയും പിന്നാലെ പോകുന്നു എന്നുള്ള ഒരു കംപ്ലയിൻറ്റ് പുതിയ തലമുറയ്ക്ക് ഉള്ളതുകൊണ്ട് മാത്രമാണ് നമ്മൾ സ്റ്റുഡൻസിനെയും ഒപ്പം MBBS കഴിഞ്ഞ് പുറത്തിറങ്ങുന്ന ജനറൽ പ്രാക്ടീസിൽ കോൺസെൻട്രേറ്റ് ചെയ്യുന്ന യുവതലമുറയെയും സഹായിക്കുക, അവരെ ഗൈഡ് ചെയ്യുക, അവർക്ക് ആവശ്യമായ സഹായങ്ങൾ ചെയ്യുക എന്നുള്ള നിലയിൽ CGPയുടെ പ്രവർത്തനം ശക്തമായ രീതിയിൽ കൊണ്ടുപോകാൻ തന്നെയാണ് ചാന്ദിനി മേഡവും രഞ്ജിത്തും ഉൾപ്പെടുന്ന CGP ഇപ്രാവശ്യം ശ്രമിച്ചത്. അതിന് ഒരു വ്യക്തമായ സന്തോഷം നൽകുന്ന കാര്യം തന്നെയാണ് ഇത്രയും ആൾക്കാർ ഈ ഞായറാഴ്ച രാവിലെ ഇവിടെ എത്തിച്ചേർന്നിരിക്കുന്നത്. എന്തിനായാലും CGPയുടെ ഉദ്യമത്തിന് സകല ആശംസകളും നേർന്നുകൊണ്ട് ഞാൻ എൻ്റെ വാക്കുകൾ നിർത്തുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir. Next we have the felicitations. Dr. Ajita PN, North Zone Joint Secretary.
Chairperson of this meeting, Dr. Anin Kuti, Chief Guest, Dr. E.V. Gopi, Dr. Chandini, Dr. Ajit Bhaskar, Dr. V.G. Pradeep Kumar, our President, Dr. Venu, Ranjit, Sandhya, other faculties in the audience, and all the delegates and dear friends, a very good morning to all of you. As we know, IMA CGP is the first academic wing of IMA, the oldest academic wing of IMA, formed in 1963. And it aims to provide continuing learning to the general practitioners so that they, to increase their skills and capabilities, because the general practitioners are the backbone of our healthcare system. I would like to congratulate Dr. Venu, Dr. Aningutti, and the vibrant Kozhikode team, Sandhya, Dr. Chandini, and Ranjit, for organizing this first district CGP program in such a wonderful way, with the hall all full of audience. And I think the district team, Kozhikode district itself has organized the first Kalolsavam also in the state. Kudos to Aningutti for the same. CGP is CGP is the College for General Practitioners, has also got many certificate courses and also online programs like family medicine, the certificate courses for diabetology, radiology, and the like, and many such areas where we think the general practitioners need to get the latest information to help them in their practice, because most often they are the first consult doctors, and it is highly essential that they be equipped with the latest in all the fields to fit their clinical practice. The CGP programs in Kozhikode branch, I think under Chandini Madam, is doing a very wonderful job with a lot of very essential topics being included in all the CME programs of CGP. And congratulations, Madam, for that. And I wish this program all the very best. Thank you.
Thank you, Madam. Felicitations, Dr. V.G. Pradeep Kumar, past State President, IMA Kerala State Branch.
Respected Chairperson of this meeting, Dr. Anin Kuti, E.V. Gopi sir, Chief Guest, and esteemed members of Indian Medical Association faculty and dear friends. The two things I would like to mention. One is regarding the new NMC regulation. As per the new regulation, we have to renew our registration every 5 years. Previously, the same thing was proposed by Indian Medical Council, but that time there was a case filed by one organization from Kerala, and from Kerala alone, it was not implemented. But the new regulation by the NMC now is applicable to us because it is Kerala State Medical Council. It is no more Travancore Kochi Medical Council. So I think CMEs, we are going to witness full of attendance the CME hereafter. Secondly, regarding the participation of the medical students, I am happy that Chandini Madam has brought this proposal or the vision of involving medical students, because almost the tune of 34% medical students from India are going abroad after completion of MBBS. That is one statistic which appeared in the Times of India last week. They don't want to practice in India, they want to go abroad. And for getting placement abroad also, they will be evaluating your papers, your participation in conferences, presentation of posters and all. In that aspect also, the CGP conference is an outstanding one. We have offered poster presentation for students as well. So these are two important aspects of things. And just before concluding, regarding the third aspect of the social support system for our own senior members by the professional association. That is something which we have been discussed in the last executive committee meeting also. Many other sections or sectors of the society have the mechanism to support the senior people when they are during ailment. We have got schemes and all, but we don't have the system to give the emotional support. There probably some logistic support. So I think we will start from Calicut itself. We will bring about certain proposals so that our own senior members, teachers, as well as senior fraternity brothers are not, they should not feel that they are not supported. Because many people think that they are becoming a burden to their own family members. That is so tragic that such two young senior members of a profession who has contributed to society all through their life, they are just ending their lives like that. I think all of us should at least sit back, think about it, whether how to take our social as well as professional activity forward. And I'm sure that we will come out with certain definite proposal to support our city. I have witnessed certain things during the last COVID time. Many of our senior people, even within the city, had great difficulty in getting into or reaching the hospital, getting treatment, all those things. So I think this is a high time that we should think about it seriously and we should come out with proposals. I wish this conference all the very best. And once again, I appreciate that the proposal to the vision to involve the medical students is one of the fantastic ones. I congratulate Chandini ma'am and Ranjit for that excellent vision. Thank you. Jai Hind, Jai Hind.
Assistant Director of CGP, my friend Dr. Chandani, Branch President Dr. Venu, Dr. Santya, Dr. Ranjit, and our Honorable Chief Guest, Gobi sir, and speakers, and my dear colleagues and students. Actually, today I stand here with a heavy heart because for the past 1 month we lost one of our sisters who was murdered. I'm not mentioning the name. And that should have opened the eyes of everyone sitting around attached to the medical fraternity that there is something wrong with our system, we are being attacked. Now today morning and yesterday we got the news that 2 of our senior members who has served the society for many years in various specialties, and their daughter is also a dental surgeon. She is also serving the society, living in the same space, but they have taken their own life. That means there is something wrong. It is time. I'm very glad that some of our students, my own students from Malabar Medical College, are also here. So I would like to offer special congratulations to Dr. Aninkutti and the CGP team, because they have managed to bring in not only such a big crowd on such a Sunday, they have also managed to bring in so many junior doctors and students. So that is, there deserve a big round of applause. It's a fantastic thing. And I wish the next time that we organize a conference, there should be a topic on emergency care management of trauma life support. And I think Dr. Anin Kuti also has been trained nationally. He's a trainer in trauma life support. And that is there because we have to think outside the box, practical things. What happens if suddenly some of us, it is not a BLS, it's not a cardiac station alone. And I've been talking and teaching for more than 15, 20 years about pneumothorax. Please do not forget, anybody who comes with acute dyspnea at any age, anywhere, any cause, rule out a pneumothorax, followed by pulmonary embolism and pulmonary edema and things like that. So this thing we are not supposed to forget. And for those younger generation of students here, if one of our senior, your mother or father or a senior doctor feels bad, then there is something wrong with our behavior. I'm very glad to see my own teacher, Rajendra sir here. I'm so happy to see him. You decide that when you go for a meeting or when you go for an IMA meeting, what happens after 20 years? Those who are here 35 years of age will be 55 years. How would you like to be greeted? You like to see the younger generation coming and saying, hello sir, how are you? How do you do? Do you do that? This is what we are supposed to do. Whenever you meet your senior, your parents, you find out what they want. It is not what you want from them. If you don't do that, we are a failure as a doctor and we are a failure as a human being. So respect your parents, give love to them. The life is only for once. So see that they are not unhappy, see that your teachers are not unhappy, and do good to the society. And once more, I congratulate the CGP team for doing this wonderful work. Thank you very much. Have a nice Sunday.
Thank you, Ajit.
Dignitaries on the dais, respected IMA Kozhikode members, respected speakers and chairpersons. On behalf of IMA Kozhikode and CGP Kozhikode and District Committee Kozhikode, I would like to thank Professor E.V. Gobi sir, former Principal James Government Medical College Kozhikode for inaugurating the Cgpcon and his valuable presence. Thank you, sir. And I would like to thank Dr. Vijay Padikumar sir, past State President IMA KSB, and Dr. Ajita P.N. Madam, North Zone Joint Secretary IMA KSB, Dr. Anin V. Kuti sir, Chairperson District Committee, Dr. Ajit Bhaskar sir, Secretary PEPS IMA KSB, for their valuable advices and gracious presence. Thank you. And I would like to thank our vibrant President of Dr. Venugopal sir, Vibrant Secretary Dr. Sandhya Kurup Madam, and my chairperson and teacher Dr. Chandni Madam for meticulously arranging this scientific session and this CME. Thank you, ma'am. And I would like to thank all the esteemed speakers and chairperson for accepting our invitation to be part of this wonderful CME, and all the judges for the e-poster presentations, and all the delegates who joined for the CME and posters. And thank you, our dear Raju Balram sir, our Senior Vice President, who is the Master of Ceremony for the function. Thank you, sir. And our cultural team has arranged a cultural program today evening, Dr. Lakshmi and Dr. Srila. I would like to thank on behalf of this team. And thanking our IME staff, Dr. Sri Biju, and for arranging the program so well, and Mr. Santosh for all the support. Thank you, our sponsors for this CME, the photographers, event team, and the venue for the stage and venue arrangements. And we wish all the delegates a great learning experience today. Thank you. Jai Hind, Jai MA.
to everybody, because here I need not talk too much because he needs no introduction. Sir did his MBBS from Alapi Medical College and MD from Trivandrum Medical College. Then he did FRCP from Edinburgh, and he has 37 years of excellent, he was an excellent teacher for the past 37 years. He worked as the professor and HOD, Department of Medicine, Calicut Medical College. He was heading the endocrinology department of medicine in Calicut Medical College, and now he is working as the HOD, professor and HOD of KMCT Medical College, Kozhikode. And he has so many publications in national and international journals. Then he is still active in research work, and he was the chairperson for the internal medicine update, organizing chairperson for the chairman for the internal medicine update 2016 to 2021. And we know diabetes is a vast subject, and exploring diabetes is just like exploring an ocean. When we go deep and deep into it, still we will not be understanding it completely. And we are waiting to polish our knowledge with Sir's speech. And over to you, sir, for the academic feast.
Thank you, Sushma, for your kind words. First of all, let me congratulate the IMA CGP team, and special thanks to Dr. Sandhya and Chandani for having asked me to present this topic before you. So Chandani asked me to present this title, Newer Oral Drugs and Optimizing Management. As we all know, diabetes is a global issue, very high prevalence, globally around 10 to 11%. And for India, also the recent ICMR study has shown that a prevalence of around 7 to 8%. And pre-diabetes, a step before reaching the set target of diabetes, also has an even higher prevalence. And issue is that more than 53% of the population live with an undiagnosed diabetes. Because if you strengthen the detecting program, you can find out even more number of people who are diagnosed with diabetes. And yet another issue is that diabetes among children and adolescents are also on the rise. So this is the context where we have to talk about the management strategies. And why diabetes to be treated? The answer, of course, I feel that all of you know, diabetes is a cardiovascular risk equivalent. It has its own issues like the microvascular complications and the macrovascular complications. And it has tremendous influence on all other systems, and it will accelerate the other comorbid condition and result in premature cardiovascular death. So there is no doubt that diabetes has to be treated, and treated to the target. One issue that many come across, that if you ask many of the patients, are you taking treatment? Yes, I am taking treatment. But when you check their HbA1c, quite often it is 8, 9, and so they are happy that they are taking treatment. But nobody is bothered about whether they are achieving the target HbA1c. And why treatment goals are set in the form of target HbA1c? Only if the target HbA1c is achieved, the treatment makes means. Otherwise, it's taken for granted that treatment is taken, but it is far from the targets. So its target is important, treatment is important. Now, these are the set targets proposed by different professional organizations. An HbA1c less than 7, or a preprandial less than 130 milligram, or a postprandial less than 180 milligram. If you treat somebody, try to achieve this level and maintain it. It is not enough that you achieve once and leave. It has to be maintained all throughout. Then only the diabetes related complications can be prevented or at least postponed to some extent. And the target is not a hard and fast set point. It has to be individualized, because tighter targets are good among younger, healthier patients, where you can go to a level even 6 to 6.5. On the other hand, if patients are already elderly, who has multiple comorbidities, their lifespan is limited, there you need not worry about the strict, stringent 7 or 6.5. There you can even 7.5 or 8. Now, when you talk about the diabetes management, we all know we have non-pharmacological means and pharmacological means. The non-pharmacological means are the diet and exercise. You see, all other systems other than modern medicine, they stress more on these things. We don't have time. We will just generate a prescription and send them. So that is the reason why many number of patients, even after your consultation, next time they will come with a advice from some other, maybe quacks, maybe tribal medicine, homeo medicine. This is because you don't have time to explain things like them. These people do use their tongue, educate them, stress the need of exercise. That is all they are doing. So diet and exercise is very, very important. Exercise, at least 30 minutes per day for at minimum 5 days of a week. Aerobic exercises that you all know. Diet, again, the cornerstone is the medical nutrition therapy, where you stress on the carbohydrate load. It has to be limited to 50 to 60% of the total calorie intake. And you have the protein, where it has to be around 15%. Fats, limited to less than 30. So you advise and stressed on the importance of medical nutrition therapy. And it's also important to educate them. It's better avoided tobacco smoke, smoking, alcohol, deep fried, salted street foods, night munching and late dinners, stress and unhealthy lifestyle. These are all has to be explained. Every visit of the patient, you utilize stress again and again, so that it will also become part of the management program. And when you come to the drug treatment of diabetes, we have oral hypoglycemic agents, insulin. And the concept of prescribing oral hypoglycemic drugs, or for that matter any anti-diabetic treatment, is based on the pathophysiology of diabetes. Conventionally, the pathophysiology of diabetes has cornered 2 points: the relative insulin deficiency and insulin resistance. But then, as more and more information about the pathophysiology has come into light, several other steps involved in pathophysiology has also been brought into light. There could be relative insulin deficiency and insulin resistance, as I already said. Then there is a concept of incretin deficiency, unregulated lipolysis, increased glucose absorption in the kidneys, dysfunction of gut-brain axis, increased hepatic glucose production, increased glucagon secretion. All of them are now identified as important pathophysiological steps involved in culminating the state of diabetes. This is what is put as the famous omnius octet hypothesis, where you have all these things included, and all of them are responsible in some way or other, or they are acting in complementary to result in the state of diabetes mellitus. Now, look at the molecules available to treat diabetes. This is the timeline of the different anti-diabetic medications available. First came insulin, then came the sulfonylurea, then metformin. Sulfonylurea, initially the old generation like chlorpromide, then there came in the 70s and 80s the glibenclamide and glipizide, and then glitazones came, GLP-1 mimetics, DP4 inhibitors, SGLT2 inhibitors. These are the drugs that came in more or less this timeline. Now, there are certain other molecules also there in the market to treat diabetes, like the orals, semaglutide, I will discuss about that, dopamine 2 agonist, hydroxychloroquine, and the latest molecule like imiglamin. So these are all there in the market. So a lot of molecules are available. So treating physicians should decide which one should be picked up and what combination should be advised to the patient. Now, because sulfonylureas, metformins are already included as all drugs, the talk is limited to the newer drugs. I will concentrate more on the pathophysiological aspects of the modern drugs or newer drugs. Incretin-based therapy, incretins are gut-derived hormones. secreted when you have food in the gastrointestinal tract. So gastrointestinal secreted hormone, they are ingretins. So to understand the therapeutic application of ingretin-based therapy, you should also know what do you mean by ingretin effect. See, when you take glucose or you administer glucose to a patient, both intravenously and by oral means, same amount of glucose. And if you measure the insulin secreted, it is found that the insulin secreted following an orally intaken glucose is much higher than the insulin secreted following intravenous. This effect is what is called ingretin effect. And this difference is based on some or as a result of some substances secreted from the intestine. These are called the ingretins. You can see on the right side, this ingretin effect is blunted in diabetic patients. So there is a relative ingretin deficiency in diabetes. So all the concept of treatment around the ingretin base is based on this fundamental concept. And this ingretin results in reduced blood glucose by multiple mechanisms. They go and stimulate the insulin secretion. They have a role in peripheral mechanism, and their role in hepatic glucose genesis. So all these results in reduced glucose production. And another important thing is that this ingretin is immediately degraded in minutes by another enzyme again secreted from the endothelium of the gut wall. And that is what is called DPP4. And because of this, this natural ingretin secreted has only very short lifespan. So our therapeutic means are now, ingretin-based therapies are based on two mechanisms. Either you try to get an increased ingretin production or its analog, or you try to degrade the enzyme that destroys the ingretin so that its natural lifespan is prolonged, or ingretin enhances. And this is again summarizing the actions of ingretin. And the first ingretin-based therapy was actually the extentin 4. It is nothing but GLP-1 analog. GLP-1, there are two ingredients, GLP-1 and GIP. GIP is predominantly secreted from the stomach. GLP-1 is on the distal part of the small intestine. So the first one was the GLP-1 analog called extentin 4, which was secreted from the Gila monster lizard saliva, and this was there. And then there came a lot of analogs, liraglutide, semaglutide, dulaglutide, and of latest is dual agonist of the GIP and GLP, and that is called the terzepatide. So that is not available here, but that is the latest edition. Because unfortunate things that all these are or were injectable forms. You have to take by injection, either daily or on a weekly basis. Only recently the semaglutide is available in the oral form. Now, oral semaglutide, actually a GLP-1 receptor agonist, is incorporated with an absorption enhancer, because the problem with the peptide molecules, if you take by oral mouth, it is easily destroyed by the gastric acid. So there were no means to prevent this. Only recently that they came out with a technology where it is incorporated with an absorption enhancer where it overcomes the peptide degradation in the acidic pH of the stomach. The added benefit of this molecule is that up to 5% weight loss in diabetic patients. So this is an ideal choice for an obese diabetic patient. So it has to be taken on an empty stomach, and tablet should not be broken, because if you break the tablet, the technology which enhances absorption is lost. So it has to be taken empty stomach, and it should be swallowed as a whole tablet. Nausea is the most important troubling issue. Otherwise, it's a relatively safe molecule. And DPP4 inhibitors are the other molecules which degrades the, prevents the degrading enzyme, the DPP4. So it's otherwise called an ingretin enhances. It promotes insulin secretion without causing hypoglycemia or weight gain. Preferential effect on the postprandial blood glucose. It can be used as a monotherapy in combination with other agents. Requires dose titration, renal insufficiency. There are a number of molecules under this group where you have sitagliptin, vildagliptin, tenligliptin, saxagliptin, linagliptin. Except for linagliptin, you require dose adjustment, renal failure. Linagliptin can be given at any level of EGFR. Now, another addition of newer molecule is the SGLT2 inhibitors. This is based on the renal handling of the glucose. That is where these molecules act. See the kidney's role in glucose homeostasis. You can see that daily almost 180 gram of glucose is filtered by the glomeruli. Of this, 90% is actually reabsorbed at the proximal convoluted tubule through the SGLT2 inhibitors, sodium glucose co-transporter. So 10% is by the SGLT1. So the predominant reabsorption of the filtered glucose back to the system is through the SGLT2 receptors. We are therapeutically modulating this SGLT2 receptors and blocking them, preventing the glucose absorption, so the glucose is lost through urine. That is the mechanism by which these molecules act. So this is the absorption mechanism. It's absorbed along with from the lumen, it's absorbed along with the sodium. And this, because of this, you have a problem, you can handle both sodium as well as glucose. So that is a added benefit of this molecule. So the additional or the effects of SGLT2 can be increased glucose excretion, resulting reduced fasting and postprandial glycemia, loss of energy and calories, so that at the tune of 0.6 to 1% HbA1c reduction can be achieved, a modest weight reduction of 2 to 3 kg, and again through the increased sodium excretion I mentioned, it can result in a reduction in this BP to the tune of 3 to 5 millimeters per mercury. So multiple benefits, not only the glucose control, weight reduction, and also BP control. So there are several SGLT2 inhibitors available, canagliflozin, empagliflozin, and dapagliflozin, because previously when introduced, these molecules were having higher prices. Now they're taken out of the control and the cost has come down dramatically. And adverse effects of this molecule are generally the genitourinary infections, polyuria, dehydration, ketosis, even glucose level normal, so dysglycemic ketosis. Without hyperglycemia, ketose state can be there. Increased incidence of breast, bladder cancer, peripheral gangrene, but these are all control studies have shown that these are all not much significant. And genital infections, you need to counsel the patients upfront about 10 to 10% risk of mycotic infection, but they can be easily managed. Because of that, you need not stop. Only thing that you have to find out and manage it. And SGLT2 inhibitors better avoid in type 1 diabetes. Prior type 2 diabetes type 2 diabetes with EGFR is less than 30, or prior diabetic ketoacidosis. And it is better not to prescribe this drug when you have active bladder cancer, falls and fracture risk. And in patients with severely low liver function, you have to reduce the dose. Now, this is another molecule that is available in the market, but personally I haven't started using this molecule. This is a Japanese molecule where they claim that it has dual action. It's a mitochondrial oxidative phosphorylation blocker. It amplifies the insulin secretion as well as it has a beta cell preservation. So it, from the mechanism of action, it appears to be a good molecule, but I have no experience, and the professional organizations have not started recommending this. Now, coming back, if you look at the oral molecules available to treat diabetes, you have metformin, thymol molecule, which is a complex molecule, multiple mechanisms of action, the insulin enhancement, insulin resistance, and gut handling. So through different mechanisms, metformin is finding its first place in initiating treatment. It also has a favorable effect on the cardiovascular effect. So it's a molecule where treatment to begin with. And sulfonylureas, of course, you have the glimepiride and glycoside and repaglinate available now. Sulfonylureas, when we talk of sulfonylureas, the old molecules, the glibenclamide, glipizide, they are all shown to have the cardiovascular risk and hypoglycemia. But the modern sulfonylureas, especially in sustained release form, they are proved to have relative safety as far as the cardiovascular aspect concerned, and the hypoglycemic risk is also less. So modern sulfonylureas are relatively safe, but compared to other molecules, it's still having hypoglycemic risk. And thiazolidinediones, where they act through the PPR gamma agonist mechanism, they predominantly focus on the lipid tissue and the insulin resistance part. And alpha glucosidase inhibitors, acarbose, a molecule useful in the the postprandial hyperglycemia is a major issue, especially in Indians, where the carbohydrate content is more. This is a molecule can be used when you have relatively normal fasting glucose and a very high postprandial. This molecule is an option. And there, of course, DP4 inhibitors, oral semaglutide, and other rare molecules I mentioned. So among this basket, you have to pick up the molecules to treat, and this picking up has to be individualized, depending upon the patient in front of you, his characteristics, his duration of diabetes, his age, his weight, his comorbid conditions, and molecule characteristics, complications. Putting all these things, you select a molecule and titrate. And I told you this, what are the factors influencing when you attempt to choose a molecule? Of course, its potency to reduce the HbA1c has to be the prime priority. Then, of course, the side effects profile of the molecule, its pleiotropic benefit. Does it have other effect other than the glucose lowering effect on the cardiovascular risk and effects on weight, risk of hypoglycemia, age and other comorbid conditions, and of course, cost. So these are all factors to be taken into account. And when you summarize, metformin, if you look, HbA1c reduction up to 1 to 2%, effect on weight, it is neutral, hypoglycemia effect very low, side effects, GI symptoms other than it is a relatively safe molecule, cost of course is low, special benefit is a cardiovascular benefit. Sulfonylureas, see, barring insulin, if you ask me which is the molecule which has the highest HbA1c reduction potential, it is sulfonylureas. It's up to 1 to 2%, 2.5%, you know. But its problem is that it's causing weight gain, hypoglycemic potential is high, side effects, again hypoglycemia, cost of course is low, and special benefits none. Thiazolidinediones, again HbA1c reduction modest, is weight gaining, hypoglycemic potential low, edema is side effect. And it has an added benefit when you comorbid condition NFALD. Fatty liver, this is the molecule of choice. Acarbose, when you have a postprandial hyperglycemia. GLP-1 receptor agonist, again relatively high HbA1c reduction, weight loss, that is an added advantage. Hypoglycemia risk low, side effects nausea, cost relatively high. So each molecule has its own merits and demerits. That is what I explained. So you have to choose the molecule depending upon the patient in front of you. Now consider each initiation or dose increase of oral anti-diabetic drugs as a trial. Monitoring the response through glucose monitoring, which could be through PPG or self-monitoring methods. Consider other cardiovascular risks like heart failure, renal and hepatic or NASH, risk other comorbidities while deciding therapy. Now, individualized approach. So because of all these things, when you want to write a prescription, you take an individualized approach, which is put in the form of acronym as A, B, C, D, E, F, G, H, where A stands for age, B for BMI, C for the CKD risk, duration of the diabetes, whether established cardiovascular disease present or not, financial concern of the cost, glycemic status of the patient, what level you want to start treatment, hypoglycemic concern. So this is what is called the ABCD EFGH concept, and these have to be taken into account when you write a prescription. Now, oral anti-diabetes general principles, metformin can be initiated in combination with lifestyle intervention at the time of diagnosis. So that is universally accepted, this one. Other options like sulfonylurea, thiazolidinediones, DPP4, all others are there, can be the second molecule. That selection should be guided by the ABCDH concept I mentioned earlier. So consider when one molecule, metformin, fails or is found to be inadequate, so then you can consider dual therapy if the HbA1c is more than 1.5% above the target. And patient-centered approach is to be followed in selection of the second agent after metformin. Any of the available drug could be selected. The other class of drug, any could be of the second, depending upon the patient's requirement. Now, if glucose targets are not achieved with two agents, start a third agent, which again could be alpha glucose inhibitors, DP4 inhibitor, SGLT2. So other molecules could be added on as a third molecule. And exceptionally, if target HbA1c is not achieved, even with the oral drugs, addition of a fourth agent is complementary with the complementary mode of action to the current OHS may be considered for the glycemic control. So there is no point that one of two molecules fail, you need not jump on insulin. There are wider options. Only thing is that you have to titrate molecule. One molecule, the dose has to be stopped, reduced, another molecule may be added. So these kind of titrations you try to practice. Just don't stop a molecule just because of the concept, there is a one side effect or hypoglycemic episode came. You try to titrate the dose either down regulation or up regulation. And in presence of severe insulin resistance, addition of thiazolidines may be considered along with metformin if not contraindicated. For patients with established or having higher risk of atherosclerotic cardiovascular disease or heart failure or diabetic kidney disease or in need of weight reduction, consider SGLT2 inhibitors or oral GLP-1 agonists. So weight reduction is, if your primary concern, two molecules, either SGLT2 inhibitors or GLP-1 receptor agonists. And for postprandial hyperglycemia, alpha-glucoside inhibitors, glinides, rather repaglinide, or SGLT2 inhibitors may be considered if not contraindicated. In elderly patients with increased risk of hypoglycemia, use a DPP-4 inhibitor as an alternative sulfonylurea. So these are the issues: hypoglycemia, weight, and other complications or comorbidities. So keeping or considering all these parameters, the RSSDA has come out with a therapeutic wheel. And if you understand and start using, it's quite easy. The different colored circles are there. You have to start from inner circle to outward. You use a clockwise direction. And molecules and in the green, any molecule can use. So you look at the innermost part. All lifestyle modification along with metformin. So that is for all patients. And then you go by the A, B, C, D, E, F, G, H. And each one you go clockwise. Advancing age, hypoglycemic risk, HbA1c level, BMI. So you go the clockwise direction. So if you combine all these things, you can get a most ideal drug in a situation. And if that is failing, you go for the next one. So if you can start using this therapeutic wheel, it can guide you in prescribing a drug, generating a reasonable prescription. So while prescribing, you always remember that you don't duplicate. So I have seen prescription where glimepiride and glycoside are given in the same prescription. So please avoid that kind of confusion. You select molecules of different classes with complementary action rather than replicating different brand name of the same class. Now let us take few examples. Here 38-year-old male working in the Middle East, detected to be diabetic. He came back from Gulf as a part of executive checkup. He had all those things, and nowadays there is a habit coming with all results with ASO titer and necessary or unnecessary every big sheet of paper they come up. And in that he noticed that he's asymptomatic. He's found to be diabetic, HbA1c around 6.5 gram percentage, and a fasting blood sugar 90. So what could be an ideal prescription for him? So if you go by that ABCD approach, we see that metformin should be there. But you can see that metformin alone will not be his solution, because metformin at the maximum. So again, one thing you have to remember that when you use these individual molecules, individual HbA1c reducing potential is there, up to 2 to 3%. But when you combine that with metformin, you don't expect that kind of a reduction in individual molecule. So put together, the maximum response can be in the form of 2 to 3, not more than that. It's not a simple addition of individual molecules HbA1c reducing capacity. So here, anyway, metformin alone cannot reduce. So this particular pain, he is a young patient, not much issue of weight, is not obese. So here, along with metformin, you can always safely start sulfonylurea because it's cost effective. HbA1c from 9 is a reasonable degree of HbA1c reduction is required, and metformin alone cannot handle. So again, there is nothing wrong in starting a dual therapy right from the beginning. So initially, there were the concept that you start one molecule, wait add one. So there is not such concept. You should go by the glycemic number of hours where the patient remains in euglycemia. That is also important. And also the legacy effect. Earlier point you get maximum title control, that effect is remembered, the metabolic memory. So taking all these in concept, there is nothing wrong in adding a combination therapy here. So here the ideal prescription would be a combination of metformin and sulfonylurea. Now here, a 48-year-old male with a history of diabetes and hypertension for the last 8 years, currently on metformin 500 milligram and glimepiride 2 milligram. Diabetes, hypertension, and BMI is 26, is obese, HbA1c 7.5 gram, urine albumin more than the microscopic albuminuria has 740 milligrams. So his renal involvement is there, BMI on the higher side, is already on metformin, glimepiride. So what could be the next addition? So we want renal protection, weight reduction. So here SGLT2 inhibitor addition may be useful. So you need not stop glimepiride, because if you stop glimepiride, the HbA1c reduction may not be adequate. So here is an ideal add-on third drug could be SGLT2 inhibitor. The third, a 36-year-old female, diabetic over the last 1 year, on metformin 1 gram twice daily. The BMI is 23, HbA1c 7.8 gram. Ultrasound examination found grade 2 fatty liver and transaminase are elevated. So here, diabetes and NAFLD. But at the same time, you see the BMI is not quite high. But here, thiazolidine may be an option. But thiazolidine issue is that it can result in a modest degree of weight gain because of the edema. But still, since the patient is not morbid obese, the ideal drug could be a combination of pioglitazone along with metformin because of the NAFLD. Now another case where a 67-year-old female, the children are settled abroad, living with her husband who is also 72 years, diabetic for more than 10 years, taking metformin 500 milligram and glycoside 80 milligram daily, getting frequent hypoglycemic episodes, HbA1c 7.5 gram. So what change should be suggested? It's already on metformin and sulfonylurea, hypoglycemic effect, elderly people, living alone. So these patients, DPP-4 inhibitors actually are a better option compared to some. So you stop sulfonylurea and add DPP-4 inhibitors. So elderly people, DPP-4 inhibitors are a good choice because they are relatively the most, but least side effect potential drug is DPP-4 inhibitors. No hypoglycemia. So in this patient, DPP-4 inhibitors may be a better option. Another case scenario where a 62-year-old male with history of diabetes, hypertension, and CAD, recently hospitalized for cardiac failure, not willing to start on insulin. So currently on metformin 1 gram, sitagliptin 100 milligram, HbA1c is still 8, creatinine 1.5. So he has renal involvement, cardiac failure, and here again SGLT2 inhibitor is an add because they have cardiac protection as well as cardiac protection means preserved ejection fraction, reduced ejection fraction, SGLT2 inhibitors are, and weight reduction, renal protection. So because of all these things, SGLT2 inhibitors could be a addition. Now, this is the last case where 35-year-old male, company executive, diabetic, currently on metformin 1 gram twice daily, BMI is 31, HbA1c 7.8, what next? So his company executive is financially well, is morbidly obese, so there is no issue of financial concern. Here, along with metformin, oral semaglutide could be an important option because weight reduction potential is maximum for that drug and is young patient. So this is how you try to select a molecule from a basket of drug that's available to treat the diabetic patients. And with that, let me conclude. If you have any queries, I am happy to answer. Thank you.
Thank you, sir. Thank you for the excellent talk. And any question from the audience?
Thank you, sir. I call upon Dr. Rajinder Nath, Senior Gastroenterologist, to hand Tulsi Dharli.
Yadindra sir was my teacher in Trivandrum Medical College when he was doing DM. I was postgraduate in medicine. Thank you, sir.
Thank you. I request Dr. Rajinder Nath sir to hand over a small memento to the chairperson, Dr. Sushma Anil. Thank you. We will move to the next session. Aches and pains all.
It gives me immense pleasure to introduce one of the greatest speakers we have, and that is Dr. Binoy J. Paul. Dr. Binoy J. Paul was a faculty in Calicut Medical College for more than 20 years and is currently the Chief of Rheumatology and Professor of Medicine at KMCT Medical College. Professor Binoy Paul is a national figure in rheumatology. In fact, he actually started a rheumatology clinic in Calicut Medical College and played a very important leading role in popularizing rheumatology as a specialty in the Kerala as well as in the country. And Professor Binoy Paul has received almost all the academic excellence awards of APA and also IMA. And sir is, in fact, the most important, there are several achievements. The most important thing is he has single-handedly authored 3 books on various aspects of rheumatology. All the books are very, very popular all over the country. And sir is talking on a very important topic for all the practitioners. As you know, aches and pains are common complaints which we come across, every general practitioner will come across in his clinic. And in majority of the cases, these symptoms may be benign, but in a few percentage, it may it may indicate the onset of a serious illness. So it is very important to know how to approach aches and pains when patients come with aches and pains. And I welcome Dr. Binoy Paul to talk on this important topic.
At the outset, I thank IMA CGP Calicut, especially Dr. Sandhya and Dr. Chandini for giving me this opportunity. But the topic allotted me looks little funny when these people gave this topic. But when you look back in your day-to-day practice, whichever be the specialty, people coming with aches and pains all over is a very common problem. If you look at the causes of generalized aches and pains, it may be a very benign problem like a post-viral fatigue myalgia syndrome following a viral fever. Sometimes you may experience muscle pain and fatigue for a few weeks, sometimes even a month. It will subside by its own, we all know. But there are other causes like hypothyroidism, Addison's disease, hyperparathyroidism. They all can present with aches and pains. Hypothyroidism is quite common. Metabolic problems like a vitamin D deficiency or uncommon diseases like hemochromatosis can also present with aches and pains. Chronic infections like HIV, hepatitis C, rarely endocarditis or disseminated tuberculosis, can present with aches and pains. Malignancies are notorious, especially multiple myeloma, bone secondaries, and leukemias. Connective tissue diseases like rheumatoid, SLE, polymyositis, polymyalgia rheumatica, they may all come with arthralgia, arthritis, or myalgia. Fibromyalgia is another very common problem in our day-to-day practice. Psychiatric illness like depression and anxiety disorders. Patients may be taking some of the drugs like statins are well known to cause myalgia. Quinolones can produce tendinitis. And then anti-cancer agents like anastrozole, they can also produce aches and pains, which is aromatase inhibitor given for carcinoma breast, anastrozole. The neurological disorders like multiple sclerosis and small fiber neuropathy, they all can present with pain all over. So how to approach when somebody is coming with pain all over the body? The step one is to exclude any life-threatening or sinister diseases like a malignancy or HIV. Second is to assess any underlying systemic illness like hypothyroidism or vitamin D deficiency. One has to always exclude fibromyalgia or depression, and then we have to plan the investigations, and pharmacotherapy or sometimes conditions like fibromyalgia, reassurance is more important than lot of drugs. So in the history, always ask about the details of the pain, the duration of the pain, the distribution of the pain, the pattern of the development. Is it periodical? Is it aggravated by stresses in life? So these all give important clues. Ask about the weight. If there is a significant weight loss, think about malignancy or chronic infections. If there is a weight gain, think about hypothyroidism. Of course, a history of drug intake is very important, especially statins. Any history of fever that indicate infection or malignancy. Is there any joint swelling or morning stiffness? Think about inflammatory arthritis like rheumatoid arthritis. Is there any features of depression which may be a part of fibromyalgia, or sometimes the patient may have only depression causing this pain. And the physical examination, always look at the appearance. When you see a person who is ill-looking, emaciated with significant anemia, think about malignancy, HIV, or disseminated tuberculosis. Look for any lymph node enlargement, lymphoma, leukemia, or secondaries. Edema or facial puffiness, think about hypothyroidism. Clubbing, carcinoma bronchus or endocarditis. If there is bradycardia, think about hypothyroidism. And in the physical examination, look at the joint. Is there, they are swollen? Look, feel and move the joint and see there any significant arthritis. Is there any organomegaly? Is the tendons reflex are sluggish in hypothyroidism? A neurological deficit in multiple sclerosis? Chest examination is important. So also cardiovascular. Don't forget about the breast, thyroid, and also look for any multiple tender points of the body which is very characteristically seen with fibromyalgia syndrome. Now coming to the investigations, ESR is a very cheap and very important investigation. If you see a patient with very high ESR, aches and pains, look for some underlying definite cause. Don't label it as fibromyalgia. CBC and peripheral smear examination are important to exclude hematological malignancy. Biochemical tests like sugar, renal function, alkaline phosphatase, serum calcium, these are important in metabolic disorders. Thyroid function may be useful in selected cases, and a vitamin D assay will also be useful to confirm the diagnosis of vitamin deficiency as the cause of generalized aches and pains, and X-ray test to exclude malignancy or tuberculosis. Depending on the basic investigations and physical findings, you evaluate further. If you have a suspicion of a malignancy, especially multiple myeloma, a serum protein electrophoresis or X-ray skull may be useful. Mammography, ultrasound abdomen, OGD or colonoscopy, lymph node biopsy or a bone marrow examination may be necessary depending on your physical findings and the basic investigation. Even an isotope bone scan for bone secondaries or osteomalacia. If your suspicion is infection, you have to look for any hidden tuberculosis like urine AFB, transesophageal echo to find out any vegetations in the endocarditis, HIV or HCV, or sometimes even fungal culture. So it all depends on the history, physical examination, and the basic investigation. So whenever you see a patient with aches and pains, there are certain red flags. If it's of a short duration of pain, think about some underlying problem. If there is extreme emaciation, maybe malignancy, HIV, disseminated tuberculosis. Older people, be careful. Fever, maybe infection or a malignancy. Weight loss, the importance I have already told. Past history of malignancy, very high ESR. So when you get some of these, always look for underlying cause. There may be some sinister problem which we are missing. So once you have excluded endocrine, metabolic, malignant and infective cause, then we have two other possibilities. One is polyarthritis and second is fibromyalgia. These are the two common causes of aches and pains in the day-to-day practice. Polyarthritis means involvement of 5 or more joints. And the causes are many. It may be an inflammatory problem like rheumatoid arthritis or degenerative or mechanical joint disease like osteoarthritis. So how to differentiate an inflammatory arthritis from a mechanical arthritis? The important differences are there is significant morning stiffness, more than 1 hour in patient with inflammatory arthritis, which is absent or short-lived in patient with degenerative joint diseases. The course of arthritis or the pain is fluctuating. Some days are good, some are bad in inflammatory arthritis. The course does not fluctuate. In fact, it progressively worsens in degenerative disease. Gentle movement or use of the joints improve the symptoms in inflammatory arthritis. The use of the joint makes them worse in osteoarthritis. Constitutional symptoms are like a fever or fatigue, favors inflammatory arthritis. These are usually absent in degenerative joint disease. And there will not be any signs of inflammation, like other than joint swelling, no redness or tenderness is usually seen in patients with non-inflammatory arthritis. And acute phase reactants like ESR and CRP usually elevated in inflammatory arthritis, which will be normal in degenerative joint disease. Now coming to the mode of onset of arthritis. When you have acute arthritis, think about these problems, especially in children and young adult, rheumatic fever, viral arthritis, gout, septic arthritis. When you get chronic problem, think about the connective tissue disorders. Age also is very, very important. If somebody comes with arthritis before the age of 18, the important causes are rheumatic fever and juvenile idiopathic arthritis, and rarely reactive arthritis also. But acute leukemia, especially in children, can present with arthralgia or arthritis as the initial presentation. 18 to 40, think about seronegative spondyloarthropathy, gout, SLE, systemic sclerosis. Between 20 to 40, rheumatoid arthritis is an important cause. Older people, think about osteoarthritis and malignancies. Gender. A female preponderance is common in most of the connective tissue diseases like rheumatoid arthritis, SLE and systemic sclerosis. But males are more prone to develop ankylosing spondylitis and gout. The pattern of joint involvement is very important. The number of joint that is affected, the location of the joint, the type of arthritis. I will come to each one by one, whether it's a migratory or a fleeting arthritis, whether it's an addictive arthritis or episodic arthritis. Is the arthritis symmetrical? Is there any severe pain where the patient is not allowing you to touch the joint? That occur only in very few conditions, like hemarthrosis, gout, acute rheumatic fever. And these are the few conditions where you get very severe pain. The importance of morning stiffness I have already told. Prolonged morning stiffness is suggestive of inflammatory arthritis. And nocturnal aggravation is common with gout and tuberculous arthritis. Deformities are quite common with rheumatoid. So the size of the joint, when it's a large joint affected in osteoarthritis, large weight-bearing joint, while a small joint is affected in inflammatory arthritis like rheumatoid. Something wrong. So the joint affected in rheumatoid are the proximal interphalangeal joint, metacarpophalangeal joint, temporomandibular joint, sternoclavicular joint. These are joints that are commonly affected in rheumatoid but not in other types of arthritis. Psoriasis typically affect the distal interphalangeal joint. Sacroiliac joint and spine involvement is common with spondyloarthropathy. Gout typically affect the first metatarsophalangeal joint. Look at the temporomandibular joint involvement in rheumatoid, the distal interphalangeal joint involvement in psoriatic arthritis, the metacarpophalangeal joints and the proximal interphalangeal joints on both sides in rheumatoid. Gout classically affect the first metatarsophalangeal joint, and the spine involvement in ankylosing spondylitis. Symmetry is the hallmark of rheumatoid arthritis. Asymmetrical arthritis is common with spondyloarthropathy and rheumatic fever. You can see the symmetrical involvement on either side. The metacarpophalangeal joints on both sides are equally involved. Sorry, there is some problem with this. As I said, when you get a migratory arthritis, that is arthritis affecting one joint, lasting for a few days, after that the pain subsides in that joint and appear in a newer joint. That is commonly seen with rheumatic fever, but can occur in SLE and sometimes even in viral arthritis initially. In episodic arthritis or intermittent, that is characteristically seen with gout and another condition called palindromic rheumatism, where the patient comes with arthritis of one joint or two joints lasting for a few days. He will take some NSAIDs, it will subside completely. The patient will have a normal period. After a few months or year, the patient may present with joint in another joint, same type of swelling. So that is palindromic rheumatism, which is a pre-runner of rheumatoid arthritis. Around 1/3 of these people later develop classical rheumatoid arthritis. Addictive type of arthritis, where one joint is affected first and a second joint is added on without subsiding symptoms in the previous joint, and after some time a third joint is added. That is the addictive type of arthritis, characteristic of rheumatoid, spondyloarthropathy and SLE. Lumbosacral spine involvement is common with spondyloarthropathy. Cervical spine alone is affected in rheumatoid. Sacroiliac joint involvement, think about spondyloarthropathy, infections like tuberculosis and brucellosis, rarely in malignancies. Now, sometimes you may get enthesitis. Enthesis is that part of the tendon or ligament that is attaching to a bone. So the Achilles tendon attaching to the calcaneum, that area is called enthesis. And inflammation of enthesis is called enthesitis. And enthesitis affecting multiple tendons is common with spondyloarthropathy. So this is a patient with a seronegative spondyloarthropathy with Achilles tendinitis. So always look at the soft tissue also and the surrounding areas like nail, the pitting nail you can see. Here you can see the whole digit is swollen. compared to this toe, you can see the third and fourth toe are swollen. It is due to the dactylitis. There is not only synovitis, but there is tendinitis. So this is called a sausage-shaped toe, which is very characteristic of seronegative spondyloarthropathy. This patient is having psoriatic arthritis, and you can see the nail changes also. This is a spindle, classical of rheumatoid, where only the synovium is affected, producing a spindle-shaped appearance of the digit. So this is spindle, that is rheumatoid. This is sausage, that is spondyloarthropathy. Now you can see the skin thickening and the purse-like lips in scleroderma, thickened skin. When you look for pallor, you may see that the facial skin is very thick. This is pseudoxanthoma elasticum, where you get a very lax joints and lax skin. This is the ruptured tendon of the extensor tendon of the little finger and the ring finger. This is a very classical deformity of rheumatoid, the swan neck deformity, and this is called button-ear deformity or buttonhole deformity, where there is fixed flexion at the proximal interphalangeal joints and hyperextension of the distal interphalangeal joint. You can see the limb length discrepancy in a patient with juvenile idiopathic arthritis. So always look at the topography, the size of the joint, the number of joints that are affected, the site of joint involvement, the symmetry, the sequence, the spine or sacroiliac joint involvement, the surrounding areas, and are we missing something more? Maybe a deformity, maybe a muscle atrophy, or all those things. So look at towards the end, look whether we are missing something. The precipitating factors are very, very important, and infection prior to rheumatic fever, a urethritis prior to a gonococcal arthritis or reactive arthritis, any history of trauma, a recent trauma may be causing hemarthrosis, or a trauma years back might have produced some injury to the cartilage and producing premature osteoarthritis. Unusual sexual exposures, HIV, syphilis, gonorrhea, all can present with arthritis. Various drugs like pyrazinamide can produce elevation of the serum uric acid and produce gout-like symptoms. Vaccinations can sometimes produce serum sickness-like reaction. High purine diet can precipitate gout. So always ask for any precipitating factor and any systemic symptoms which we have already mentioned. Fever, malaise, weight loss. Think about underlying serious illness. Diarrhea or GI symptoms prior to reactive arthritis or inflammatory bowel diseases. Urethritis prior to gonococcal arthritis or reactive arthritis. Oral ulcers, I will show you some pictures. Genital ulcers, a variety of eye lesions, and other systemic symptoms which we have already mentioned. So when somebody comes with arthralgia or arthritis, still it may be due to some underlying systemic illness. Past history of rheumatic fever, tuberculosis, and psoriasis are important. Family history is known to all of you. And then you go for the general examination. The appearance, is there any pallor, skin rashes, pigmentation, clubbing, lymphadenopathy, or any nodules. You can see the scleritis in a patient with polyarthritis due to rheumatoid arthritis. The conjunctivitis in retus, the nodular episcleritis again seen in patient with rheumatoid. The dry eyes, this is the Schirmer's test for Sjogren's. The patient came with dry eyes and dry mouth along with arthralgia. This is alkaptonuria. You can see the pigmentation of chronosis. The oral ulcers in SLE. Again, the alopecia of SLE. You can see the short stumpy hair and the malar rash. The diagnosis is SLE only. The diagnosis written on the face, the typical butterfly rash, sparing the nasolabial fold. This is scleroderma, where you get hypopigmented and sometimes hyperpigmented skin lesions. SLE is said to be uncommon in males, but this patient has got the classical malar rash. This is discoid rash, discoid lupus erythematosus. You can see two lesions, the irregular hypopigmented lesions. This is the vasculitic rash of SLE. The same patient, another rash. This is the centrofacial rash. We were very used to this earlier with chikungunya disease. The centrofacial hyperpigmented rash of chikungunya. This is another case of discoid lupus erythematosus. And vasculitic lesions and vasculitic gangrene. This patient has got SLE with antiphospholipid antibody syndrome. This is known to all of you, palpable purpura, most commonly due to Hinoxolin purpura, where it is palpable and the platelet count is normal, you can palpate this purpura. The nasal and the oral lesions of SLE. So you look at any extra articular features, as I said, eyes, oral cavity, scalp, skin, lymph nodes, pallor. Look for any nodules. This is rheumatoid nodule, large nodule, a single nodule, sometimes one or two, suggesting a bad prognosis. Response is not good. Most of them are 100% are rheumatoid factor positive. On the other hand, this is rheumatic nodule. Nowadays, we are not seeing much. They are smaller in size. They appear in crops, lasting for only few days or weeks, suggesting underlying carditis. If there is rheumatic nodule, 100% carditis. So from looking at these small nodules, you can arrive at a lot of conclusions. This is the Heberden's nodes at the distal interphalangeal joint and the Bocard's nodes in the proximal interphalangeal joint. This is hand osteoarthritis. Heberden's nodes and Bocard's nodes. You can see the angry looking red joint, but you can see some smaller nodules also, which are tophi. This is another patient with multiple swellings, and you can see, or the ear, pin of the ear also, you are getting some nodules, and these are the close-up view. You can see multiple nodules, which are uric acid crystal deposition producing tophi. This young man again has got a large tophus. You can see the puncture mark through which the chalky material is aspirated and demonstrating the uric acid crystals. This is sarcinate balanitis and keratoderma blennergica, two skin lesions which you get in Ritter syndrome. This is another common problem in our place, North Malabar, recurrent oral ulcers, genital ulcers and arthritis. This is Behcet syndrome, quite not an uncommon problem in Kerala. This is psoriatic arthritis. You can see the distal interphalangeal joint involvement and the skin lesion. But sometimes psoriasis may be hidden, and the patient may say that it's only dandruff. So you should look for hidden areas like scalp, behind the ear, around the umbilicus, or subtle nail changes with the tenosynovitis of the toes. So again, you can see the onycholysis and the pitting of the nails along with the distal interphalangeal joint involvement. And finally, you have to do the joint examination. You should look at the joint, you should feel the joint and move the joint. In the inspection, look for any symmetry, swelling, deformities, any signs of inflammation, skin over the joint, whether it is dry or moist, or any local muscle wasting. All these things you can make out by inspecting the joint. And the palpation, look for any warmth, any increase in the joint tenderness. Grade 1 to grade 4 is classified. Even in your Hutchison, there is a grading of joint tenderness. Look for the cause of the joint swelling, whether it is due to effusion, is it due to synovial thickening, is it due to a bony enlargement, or any subluxation of the joint. And you have to look for the range of movements and the crepitus, which can be tendon crepitus or joint crepitus. Joint crepitus are creaky sounds when you move the joint. That is usually seen in degenerative joint disease like osteoarthritis. Tendon crepitus is due to the tenosynovitis, which you get in inflammatory arthritis like rheumatoid arthritis. Enthesitis I have already mentioned. And finally, the range of motion, the restriction of the joint mobility, joint stability, you look for any deformities or disabilities. And this is another common problem, benign joint hypermobility. These patients can flex their fingers or toes or other joints much more than the normal counterparts. They don't have any other features of Marfan syndrome or other hyperlaxity syndromes. This is called benign joint hypermobility, and with some undue stress to the joint, the patient may develop swelling of the joint and come to you. And you may think that it is a serious connective tissue disease. So that is the importance of knowing about benign joint hypermobility. It is not uncommon that the patient comes with a lot of symptoms, no signs, and normal investigations. At that time, we have to think about fibromyalgia, but of course, we have to exclude the causes which you have already mentioned. Some of them are easily treatable and curable, some are really dangerous. So fibromyalgia, where the patient presents with widespread musculoskeletal pain, symptoms are classically intermittent, normal joints, no functional loss, investigations are normal, and they have multiple tender points over the body. That is very characteristic of fibromyalgia. And there are many non-articular symptoms like insomnia, fatigue, irritable bowel syndrome, tension headache. These are common accompaniments. And their response to NSAID is very poor. And they may respond transiently to antidepressants. Even though fibromyalgia was earlier considered as a psychosomatic disease, now it is considered as one of the central pain syndrome where there is abnormal pain perception. There is defects in the pathway of pain transmission, decrease in the inhibitory control that regulate the whole body analgesia after a painful stimulus. So after a painful stimulus, the body will have inhibitory control, which is lost in these people, and this results in abnormal pain perception. So fibromyalgia is now considered as a organic disease rather than a psychosomatic illness. There is augmented pain and sensory processing, which is the hallmark of fibromyalgia syndrome, and it is often associated with sleep abnormalities, autonomic dysfunction, and even depression. And it has got a strong familial tendency. So these multiple tender points are very characteristic of fibromyalgia. And these are the people who come to your clinic with a very sad face and with a very thick file containing many investigations, starting from ESR, ASO titer, rheumatoid factor, ANA, some are positive, some are negative. And we may think that they are a nuisance because for many years they are going from pillar to post with this. Even though many drugs are being tried like antidepressants, anticonvulsants, and analgesics, they all give only transient relief. Relaxation techniques like meditation or yoga is sometimes useful in some of these people. So to conclude, I thought I will give some practical points. Generalized musculoskeletal pain is a feature of many medical disorders. Some are dangerous, some are very benign. It is stuck. It is a last slide only. See, my last slide. Last, ഇതിൽ മൂവ് ചെയ്യോ? ഇതിൽ മൂവ് ചെയ്താലും മതി. ഇല്ല, then it's okay. ലാസ്റ്റ് സ്ലൈഡ് മാത്രം എടുത്താൽ മതി. Then it's okay. I think we'll stop here. So generalized musculoskeletal pain is a feature of many medical disorders. Assess the patient fully rather than considering only rheumatological disorders or fibromyalgia. Do not over-investigate chronic problems. This can exacerbate abnormal illness behavior in an anxious patient. Try not to be prejudgmental. The patient is unlikely to be trying to waste your time. There is a problem. Help the patient to solve it. Drugs have only limited role in chronic non-inflammatory musculoskeletal pain. Explanations, reassurance, changes in the lifestyle are more appropriate than polypharmacy in fibromyalgia. Thank you very much.
Thank you, sir, for the very informative talk with a lot of clinical pictures. It was really interesting. And it is a very common topic, and I'm sure there may be some questions. Topic is open for any questions or comments. Many people will be asking, thinking about what are the drugs to be started in patients who come with aches and pains in their clinic as a general practitioner. So you prefer NSAIDs or analgesics? If so, can you enlighten on that?
If there is some inflammation, NSAIDs are best. If the patient is coming to a non-inflammatory pain, analgesics will be sufficient because analgesics are having lesser side effect profile. But it is only temporary and transient because we have to investigate or evaluate to find out the cause. Many of our patients are coming with chronic pain are having fibromyalgia, where even though I discussed all these drugs, in our actual practice, they are all giving only temporary relief. So reassurance and other relaxation techniques are more useful rather than taking duloxetine or pregabalin for a longer period.
If there are no more questions, I think we can close the session.
Thank you, sir. I request the chairperson, Dr. N.V. Jayachandran, to hand over the memento to Professor Dr. Binoy J. Paul. Thank you. We'll move to the next session. Common X-rays, which a general practitioner should not miss. Speaking on this topic is Professor Dr. Rajendran VR, former principal and head of radio diagnosis, MCH, Kozhikode. Welcome, sir.
We should really thank IMA CGP for organizing such a wonderful CME. All the topics are of great interest to the general practitioners. And this topic again is very, very important regarding the common X-rays in general practice. And to talk on that, we have a very eminent speaker. In fact, it's my great privilege to introduce Professor Rajendran sir to this audience. He doesn't require any introduction, but for completion's sake, Rajendran sir was the head of the Department of Radio Diagnosis in Calicut Medical College for several years. And during his time, the department had phenomenal changes with a lot of developments in the department. Later on, sir became the superintendent of Medical College Hospital, and we witnessed great changes in the hospital. And later on, sir became the principal of Calicut Medical College and successfully led the hospital and the college during the Nipah as well as COVID pandemic. Sir is such a simple person with a lot of experience. We all are eager to hear from Professor Rajendran. Over to sir.
For the information of all seated here, this conference is going live online and it's also been recorded on YouTube. We will be sending you the link in the evening. We have a pleasant surprise today. Dr. Ramachandran sir is here in the audience among us. So, IMA CGP Kozhikode branch will be honored if you could also be a part of the chair for this session.
Good morning to all. First, I express my sincere thanks to Dr. Chandini, Dr. Ranjit, and others to give a chance to deliver this talk. The topic is the common exercise which a general practitioner should not miss. We have to remember this person, William Conrad Röntgen, who discovered the X-ray in November 8, 1895. And the first X-ray was taken in December 22nd. That is his wife Bertha's hand with a ring. In the routine practice, we are getting a lot of images like this one from the pediatrics department with suspicion of the mediastinal widening. There is a mediastinal widening, but in the pediatric age group, this should be considered as a normal. And the various signs helps to differentiate this one. This one, you can see a mediastinal widening with a triangular opacity, that is known as the sail sign. There is a mediastinal widening with a notch, forming a notch with the cardiac shadow, that is cardiac notch sign. And this one is the mediastinal widening with a wavy margin, that is the wave sign of the mulvi. If you are getting an X-ray like this one, you can definitely say this is a normal X-ray for the pediatric age group. This is the normal thymus. It is not mediastinal widening of pathological nature. At delivery, the weight of the thymus is around 25 grams. That will increase within 24 hours to 35 grams. Then it is regressing. So in the initial phases, we are getting an X-ray like this one, and usually routinely getting images like this one from the pediatric department for the opinion. I think most of the exercises are seen by the audience, and I think this might be a revision to everyone, because this is a common exercise I am drawing. And while looking at X-ray, it is important to have a look on the technical factors, like whether there is any rotation, whether it is a penetrated film, whether it is properly taken in full inspiration, whether there is any artifact like that. This is an X-ray of a patient with occasional cough. Actually X-ray shows bilateral basal opacities, but this was an expiratory film, and in full inspiration, the same patient, you can see the normal lung, normal X-ray. So always you have to look the X-rays, whether the technical points are clarified or not. So this is an inspiratory film. This X-ray, patient came with a pain neck, and X-ray was taken by a general practitioner. But after seeing the X-ray, she was surprised. You can see the patient have neck pain, and you can see the bilateral cervical rib and rudimentary on the left side. But in addition to this one, you can see the linear opacities with lucencies in between in the neck. So she was surprised to see this X-ray. And as I got the X-ray, you can see this is extending from above downwards. And this is nothing. This is an artifact that is a hair left open. X-ray was taken with the left open the hair, and we are getting an appearance like this one. So always be careful taking the X-ray. And also this one, you can see an opacity in the left upper zone, and which appears to extend into the supraclavicular area and forming a nodular opacity like this one. This is a typical and common to get a ponytail. So always remember the artifact will produce various configurations and thinking as a pathological condition. In the chest X-ray, two signs are very important. One is the air bronchogram, and the second is the silhouette sign. The air bronchogram, when the lung parenchyma surrounding the bronchi are opacified for some reason, then the bronchi will be visualized due to the contrast between the air in the bronchi and the surrounding lung opacity. So air bronchogram is seen in various conditions like consolidation, pneumonia, pulmonary edema, highly membrane disease, lymphoma, alveolar cell carcinoma, ARDS, alveolar proteinosis, sarcoidosis, and infarction. And the second sign that is helped to differentiate is the silhouette sign. That is the intrathoracic lesion, which is anatomical continuity with the borders of the heart. The aorta or diaphragm will obliterate that border in röntgenogram. Example is the left cardiac border is obliterated in the lingular lesions. The aortic knuckle is obliterated in the epico-posterior segment lesions. The right cardiac border may be obliterated in the right middle lobe lesions. The lower lobe lesions obliterate the diaphragmatic border. So this X-ray, you can see an opacity occupying the most of the left hemithorax. This opacity may be due to a lesion in the chest wall, may be a lesion due to the pleural space, or due to a lesion in the lung parenchyma. So applying our science, that is the air bronchogram, silhouette science, we can differentiate this one. That is the importance of the these signs, air bronchogram and the silhouette sign. You can see this opacity is a non-homogeneous, and you can see multiple linear lucencies within this opacity. That is known as the silhouette sign. So if you are seeing a lesion with a, air bronchogram, if you are seeing a lesion with air bronchogram, you can definitely say it is an intraparenchymal lesion, not in the chest wall or the pleural space. Also, here you can see the cardiac border is obliterated, aortic knuckle is obliterated, but not the diaphragmatic border. So this is a consolidation involving the left upper lobe and the lingular segment. This one, this is a non-homogeneous opacity is seen in the right lower zone. But this is non-homogeneous. Why? Because multiple linear lucencies are seen in this one. That is known as the air bronchogram. The cardiac border is obliterated. So the lesion obliterating the right cardiac border, but not obliterating the diaphragmatic border. It is the consolidation involving the right middle lobe. In this X-ray, you can see a mass lesion with a well-defined lateral margin, but it merged to the mediastinum. So a lesion with a well-defined lateral margin, which merged with the mediastinum, is a mediastinal lesion, not a parenchymal lesion. Here also, applying the silhouette sign, the aortic knuckle is not seen. The knuckle is more posterior aspect in anatomically. So aortic knuckle is obliterated. So this is a lesion occupying the posterior mediastinum, confirmed by the lateral view. Here also, you can see lesion is here. This is a patient, 40-year female patient, presented with fever, chills, and left-sided pleuritic chest pain. And the X-ray shows an opacity which is seen, well-defined lateral margin. Aortic knuckle is not seen, but at the same time, few pleural reaction is seen. The blending of a CP angle is there. So suspecting the mass lesion, maybe a lymphoma, maybe a aortic knuckle aneurysm. The CT was taken, which shows that this was a nodular lesion occupying the posterior mediastinum, and this was a case of Castleman's disease. Castleman's disease is a non-clonal lymphoproliferative disorder. Common cause of a non-neoplastic lymphadenopathy, greater mimicker of both benign and malignant abnormalities in the neck, chest and the abdomen and pelvis. This is common X-ray. You can see opacity occupying the right upper zone. But it is almost uniform, but here the opacity is more dense. And this is a minor fissure which is pulled up, and because there is an added opacity, this is a mass lesion occupying the central hilar region, which causes collapse of the upper lobe and producing a uniform opacity because of the collapse of the upper lobe. That is known as the golden S or the reverse S sign. If you are getting an X-ray like this one, I think there's a mass lesion, and you can see a typical pattern of calcification. That is known as the Cgpcon calcification, which is typically seen with the hamartomas. Here you can see a left homogeneous opacity occupying most of the areas with the shift of the mediastinum to the side, blending of the CP angle as well as the diaphragmatic body is obliterated. It is the pleural effusion. This X-ray shows elevation of the dome of the diaphragm, and at the same time the peak is just lateral to the midclavicular line. That is known as the lateral peak sign. It is a diagnostic of the pleural effusion, and the quantity of fluid is 250 ml. This is common to get X-ray like this one, the upper zone opacities. These opacities are non-homogeneous or fine infiltrative lesion seen in the right upper zone as well as the left upper zone is typical for the pulmonary tuberculosis. And also multiple nodular opacities. This is a miliary nodules seen in the both lung fields, more on the upper two-third and less on the lower part. It is a typical miliary tuberculosis. If you are getting a appearance like this one, which involves the lower two-third and sparing the upper one-third, it is usually the metastasis, especially the follicular carcinoma, thyroid metastasis getting a miliary appearance, which occupies the lower two-third, but the tuberculosis, it is the upper two-third. This is a common X-ray getting, you can see a hyperlucency with a collapsed lung, but at the same time, because of the adhesion, it is not completely collapsing. It is a common thing getting in the casualty, that is a pneumothorax with adhesion. And in this X-ray, here also hyperlucency with the collapsed lung, with the shift of the mediastinum, everything to the side. The important thing is always look this area, because in the pneumothorax, there may be no vascular marking. You may get an appearance like this one, even with a skin fold or with other conditions like pollen syndrome or the bulle. You may get a lucency. But look for the vascular marking. If there is no vascular marking, it is definite, it is the pneumothorax. In suspicion, you have to take the aspirated film for confirmation. This X-ray, it is a supine portable X-ray. Patient with respiratory distress, X-ray shows the shift of the mediastinum to the right side and hyperinflated lung here. But in the hyperinflated lung, few linear opacities are seen. But at the same time, in the lower part, this one, you can see the lower part, no vascular marking is seen, and this margin is well defined. So this was in addition to this one, you can see one more finding, that is the air lucencies in the subcutaneous plane, and this was a tension pneumothorax with the surgical emphysema, and the cause was, it was confirmed, the cause was the multiple bulla lesion. This is a 46-year lady, complains of respiratory distress for 2 weeks. X-ray was taken. Grossly appears normal, but there is some cardiomegaly as such. But at the same time, you can see a lucency is passing through this one. So, suspecting any other lesion, CT was done. CT shows this lesion, and it is occupying a mass lesion in the anterior mediastinum that it tend to be a thymic mass lesion. It is interesting to get an image like this one once in a year. And you can see the mediastinum, everything shifted to the right side. The trachea shifted to here. And the right hemithorax is a little small in the size. So after seeing this one, you may get an image like this one once in a while, but you can make a diagnosis. The CT scan shows, in addition to this one vascular structure, something is passing down and it extended down to the abdomen below the diaphragm. CT was done, which shows the small hemithorax, the shift of the mediastinum to this side, and in this left pulmonary artery is clearly seen, but not the right. Right is small in the size, and this vessel, which appears to trace from the midzone extending down to drain into the IVC. This is the hypogenic lung syndrome, pulmonary venolar syndrome, or the Schmitter syndrome. Usually in such a case, the heart lung may be hypoplastic or the aplastic. Schmitter vein can be seen, which drains into the IVC or the portal vein. Small right hilum, because of the partial agenesis of the pulmonary artery. Small right hemithorax with the mediastinal shift. The cardiac juxtaposition may be there, and also there may be rib notching in this condition. This is a 2-year child with the swelling right shoulder and the orbit. This is the X-ray, 2-year child. You can see here there is a lytic lesion is seen. Also lytic lesion is seen in this 4th rib. This is a magnified view which shows a lytic lesion in the upper end of the humerus. CT was done, confirmed there is a lytic lesion, and also there is a lytic lesion in the orbit. So 2-year child with the swelling, excessive crying, suspected in neuroblastoma. So the CT was done, which shows no mass is seen in the adrenal region. So neuroblastoma is out, but at the same time you can see the clue which gives the diagnosis. That is, you can see one vertebra. It is flat. That is the vertebra plana, which is typical for the LCHL, Langerhans histiocytosis. We also get images like one. This is a simple hydropneumothorax, and this is the lung abscess. So, in the how we can differentiate, that is by taking another view, that is the lateral view. In the lung abscess, the shape is round in shape, but other one is the elliptical. In the lung abscess, the fluid level in both views will be equal, but in hydropneumothorax, that fluid level is different. That is the way we have to differentiate the hydropneumothorax and the lung abscess. This is interesting. This is I think it was a early 2000 image. This is a patient came to medicine with fever cough. So suspecting pneumonic consolidation. X-ray was taken, and the finding is this one. Antibiotics started, the patient sent back. Again, after 3 months, the patient came. This is the X-ray. So this X-ray shows right paracardiac opacity with the motile pattern. And also there is an air fluid level. Also the fundal bubble is not seen. This was a case of the achalasia cardia. Barium solo confirmed that was the achalasia cardia. So why the patient is coming is because of the aspiration, getting a pneumonitis and the lung abscess. That is the finding which is getting with the achalasia. That may be the reason patient is coming with a fever and a cough frequently. In the chest X-ray, the lung vascular marking is very important, because usually normally the more vascular marking is seen lower 2/3 and less on the upper 1/3. Also more vascular marking is seen medial 1/3 and less on the lateral 1/3 and in between in the intermediate 1/3. That is the normal vascular pattern. But most of the cardiac disease can change the vascular pattern, and we can make a diagnosis by looking the vascularity as such. In this case, you can see no vascular marking is, these are two different patients, but our vascular marking is not seen in the lower part. Everything is moved upwards. That is the upper zone diversion. And in addition, you can see a double shadow. That is the double shadow, which causes opacity towards the right side, as well as the carina is widened. You can see the left vongus is elevated and pushing backward, producing the compression of the esophagus, and the patient may present with the dysphagia. This is the typical mitral heart. Here, there is a cardiomegaly, but it is difficult to comment which chamber is enlarged. That is a cardiomegaly without a definite chamber enlargement, but at the same time, the margin is well-defined, smooth, etched out, which is a diagnostic of the pericardial effusion. This one, you can see, everyone can see, bow-shaped heart, right side aortic arch, oligemic lung field. You can see the vascular marking is seen only in the medial one-third. It is difficult to see on the lateral part. It is the oligemic lung field, and it is the fallow. This one, you can see the vascular marking is more, and is seen even towards the peripheral part. Cardiomegaly is there. Aortic knuckle is not seen, but the pulmonary is dilated, so it is a left to right shunt ISD. Here also, you can see the plethoric lung field, more vascular marking, and the appearance is the egg on string appearance, getting with the transposition of the great arteries. This is interesting. Actually, I got this image from for the DNB exam at West Command Hospital, Calcutta. This patient was selected and in the training, frequent fall during the parade. This X-ray shows there is a lesion. That is there is a lesion. That is a calcified lesion or the ossified lesion. Things like this is in this one. This so a possibility of the hematoma or a meningioma was suspected, but lateral was taken, which shows this is extending from the frontal to the parieto-occipital region, and also has a motile pattern inside. CT was taken, which shows this is the calcified lesion which compresses the ventricle on that side, and this is calcified, and this was a chronic calcified subdural hematoma. Retrospectively, history asked the person have a history of fall when he was at 4th standard from the cycle, but that is slowly developed. On that time, the subdural developed, and it is slowly getting calcified. Even after the being a military person, they did the surgery after the diagnosis. It is routine to get images in the casualty like this one, more familiar for the ENT patients, and you can see the the prevertebral or the retropharyngeal space widening with an air fluid level. So this is a retropharyngeal abscess. This is a baby with respiratory distress immediately after birth. You can see a hyperlucent area which is shifting everything to the left side. Also, this part, that area of the lower lobe and the upper lobe is compressed. This is a case of the congenital lobar emphysema. It is a comparison. You can see this patient and this patient, you can see multiple lucencies within the chest, but here the lucencies, mediastinum is not widened. Here it is displaced to this side. Also the abdomen found to be, that's empty. So this is the diaphragmatic hernia, and this one is the cystic adenomatoid malformation. Confirmation is by the barium study or the CT scan. So this patient is occasional cough and breathlessness. This is a 70 lady with dyspnea on exertion and occasional cough for 2 years. Blood investigation was normal. As usual, the patchy opacities are seen in the lower zone, but in addition to this one, you can see something is here. This one is here. Suspecting CT was taken, which shows patchy opacities in the both lung field, and the pneumonitis may be diagnosed. But at the same time, the mediastinal window shows the esophageal wall is thickened. Uniform thickening of the esophagus is seen, but the mucosa is patent. So it is even though all the wall thickening is not due to the malignancy, it is only the simple hiatus hernia, which was confirmed by the barium study, and retrospectively you can see it is a retrocardiac opacity is seen in the X-ray also. So esophageal wall thickening is not always due to the malignancy, it can be due to the benign condition like this hernia. This is interesting because the patient underwent the coronary bypass surgery. After the 3-month X-ray was taken, patient as such there was no complaint, but X-ray was taken because of the occasional cough, finding a opacity, non-homogeneous opacity in this area. After 3 months, when the patient came, repeat X-ray was taken, which is persisting. So CT was taken. CT shows lesion here. You can see this lesion in the solid cystic lesion as such, with air bronchus within this one. You can see this is the lesion. That is the lesion with lucencies inside. This was a case of the aseptic fibrous granuloma. It is the gossypioma, but to tide over the medical legal issue, use the word aseptic fibrous granuloma. It was the gossypioma which is occupied in the oblique fissure. And the lateral shows it is filling the oblique fissure. This is the preoperative film of the patient. This patient, I think Tolasaran sir may be remembering this patient. It shows wide mediastinal widening and CT was done. Suspected the as usual lymphoma and any other mass lesion or the aneurysm, everything was suspected. CT was done, which shows aneurysm from the aberrant right subclavian artery. And this was a case, so you can see this is the aberrant right subclavian artery and this is extending into this one. This is the esophagus and the night. We planned for the angiogram. The day before the angiogram, the patient, in the evening, the patient collapsed while walking in the veranda. Postmortem shows it was ruptured into the esophagus. It is, I mentioned about this one. You can see hyperlucency in this area, but it is a definite margin is seen here. This type of image is seen with the mastectomy or a condition that is known as the Poland syndrome. Never suspect the pneumothorax of such a conditions. Always look for the vascular marking in the lucency. That is the easy way to differentiate. Yes, this is the, you can see this one, that is a widened posterior part of the rib with the soft tissues and is typical for the, this one, that is the extramedullary hemopoiesis. It is a common and it is, I think, usually the GP, everyone knows this one because a typical double bubble which is getting with the duodenal double bubble sign which is getting with the duodenal atresia. This X-ray, you can see chest X-ray is normal, but air lucency is seen beneath the dome of the diaphragm is a Kupla sign, that is the pneumoperitoneum. And this is another sign. Here also there is an air under the dome of the diaphragm, but the wall of the bowel is clearly seen because the air is in both sides of the bowel. That is known as the Wriggler sign. This is a baby with the abdominal distension. Supine X-ray shows dilated bowel loops and the erect shows the air fluid level. So diagnosis is easy. Small bowel obstruction, multiple small air lucencies in the central part of the abdomen. Here you can see an opacity in this part, that is the right iliac fossa. So it is causes the intersusception. You always, whenever there is a dilated bowel loops, always look at the inguinal region because the obstructed inguinal hernia, you can see the lucency in this inguinal region. So the cause for the intestinal obstruction can be clearly diagnosed. Nowadays it is difficult to get the patient, X-ray like this one. You can see multiple linear opacities within the left hypochondrium, and this is common to get previously, but nowadays because of the socioeconomic status is improved. So this is a medusa head due to the ascariasis. That is the roundworm infestation caused the tangling of the worms getting appearance like this one, medusa head like appearance. This is you can see elevated dome of the diaphragm with an air fluid level. So is a lung abscess, liver abscess. This is a invertogram. Usually we are taking the invertogram to assess the anorectal malformation, whether it is a high or the low level, because high is associated with other anomalies, low is without anomalies. So we are taking the image like this one, invertogram. So this, if the dimension is more than 1.5, it is the high anomaly, low, this is the low, less than 1.5, it is the low anomaly. But the problem with this one is when the baby cries, this will move up. So the high anomaly becomes low. The one, I think the Andhra person, Narasimha Rao, developed a method, keeping the patient in the prone position. Baby will not cry, and we will get the axial dimension. That is developed by the Andhra pediatric surgeon. We are getting the X-ray like this one in the department. You can see a calcified lesion is here. Also, you can see a lucency is in surrounding this one. So diagnosis is straightforward. It is an ovarian teratoma. Okay. This is a various type of calcification. That is, this one is crossing the midline. It is a pancreatic calcification. This is in the renal area, so it is a renal calcification. And this is the occupying multiple calculus seen in the GB. The way previously to differentiate is taking the lateral view. If you are seeing the lesion anteriorly, it is the GB. If it is seen posteriorly, it is the renal. And if it is in front of the spine, it is the pancreatic. But nowadays it is easy because of the ultrasound. Yes. This is another patient with complaints of cough. X-ray was taken, shows this finding. Suspecting the breakdown consolidation, treated with antibiotics. But this is 1 year back, and this is after 1 year. Same finding is persisting. So, barium and the CT confirmed this was the diaphragmatic hernia. This is an interesting film as such. You can see dilated bowel loops, bowel loop obstruction, small bowel obstruction is there because of the multiple air lucens is there. But in addition, this is the dilated bowel loop. In addition, you can see the air in the biliary system, and also the stone, GB stone is seen here. So it is a case of gallstone ileus. This patient, this baby was brought to OP with multiple swellings around the knee joint. X-ray was taken, which shows the fracture in the metaphyseal region, lucency in the metaphyseal region, soft tissue swelling is there, and also you can see the fracture here, that is known as the corner fracture. So fractures of various stages is there. When the patient was asked history, something is, there is some confusion. So we said, we are calling the patient, we ask the patient, we are calling the police and hand over to the police. And finally it turned to be the battered baby, because the type of fracture is typical. Fracture of various types, and also metaphyseal fracture, also corner fracture. These are typical for the battered baby syndrome. This is, as usual, common rickets. You can see the cupping, spraying, fraying, everything you can see in the wrist as well as the knee joint. But this one, I think, even though we are saying ricketa rosary, this is the widened anterior and is getting appearance like this one. This is the ricketa rosary of the rickets. This, I think Benoit explained. This is a case of the osteoarthritis. You can see asymmetrical narrowing of the joint space, sclerosis of the margin, osteophyte formation, and also lucency, that is the geode or the subarticular cyst is formed. These are the findings getting with the osteoarthritis. Here also you can see cervical spine lateral view. There is a narrowing of the disc space of the C567 with osteophyte and foraminal narrowing. So this cervical spondylosis, the finding, one fancy finding. You can see one more thing, that is the similar to this one, the spinous process. This is the calcified or the ossified ligamentum nuchae. This is a typical X-ray. You can see expansion lesion with the sclerosis and also periosteal reaction, Codman's triangle, sunburst pattern of the periosteal reaction, and the soft tissue is typical for the osteosarcoma of the osteogenic type. This is the important is the site is very important, because usually it is in metaphyseal region or the metadiaphyseal region. But here the lesion is seen in the diaphyseal region with the soft tissue component, periosteal elevation, which has got a onion pin pattern. So it is the E-wings. This is a expansile lesion is seen here, but the cortex is intact, no soft tissue reaction, no periosteal reaction. This was the GCT, and here also expansion without any dissection, but there is a thin septa is seen inside. It was the aneurysmal bone cyst. This you can see patient with a pain on the right hip, but the finding is here. You can see sclerosis with a lucency in the central part is a typical for the osteodosteoma. This one, multiple opacities of uniform size is seen in the shoulder joint, and this is a typical synovial chondromatosis. This is really, you can see enchondroma here, but this is a joke. I think is a positive, a sign is explained, positive Jones-Thomson sign in the right femoral enchondroma. The positive Jones-Thomson sign says if there is pain on the right side, either due to fracture or the enchondroma, the penis will direct it towards that side. That is the positive Jones-Thomson sign, which helps to look for any fracture or the lesion on the right side. That is the positive Jones-Thomson sign. Okay, thank you.
Thank you, sir, for the very informative talk. There may be some questions. Topic is open for discussion. Sir, come in.
മലയാളത്തിൽ പറഞ്ഞോട്ടെ, കുഴപ്പമില്ലല്ലോ. മലയാളം അറിയാത്ത ആരുമില്ല എന്ന് വിചാരിക്കുന്നത്. ഈ ആലപ്പുഴയൊക്കെ ആണെങ്കിൽ ഒരു പ്രശ്നമുണ്ട്. കുട്ടികൾ കുറേ പേര് പുറത്തുനിന്നൊക്കെ വന്നവരായിരിക്കും ഇവിടെ എല്ലാം. അപ്പോൾ രാജേന്ദ്രൻ വലിയൊരു ജോലി ചെയ്തത്. കാരണം ഇത്രയും ചുരുങ്ങിയ സമയത്തിനിടയിൽ എനിക്ക് വന്നാൽ പീഡിയാട്രിക് റേഡിയോളജിയും ബോണും വേണമെങ്കിൽ മാറ്റി വെക്കായിരുന്നു. ബിക്കോസ് ഈ ചെസ്റ്റ് എക്സ്റേ പറ്റി ഞാനൊരു തമാശ പറയാം. രാജേന്ദ്രൻ്റെ സ്റ്റുഡൻറ്റും എൻ്റെയും സ്റ്റുഡൻറ്റും കൂടിയായൊരു മനോജ് മോഹനുണ്ട്, 34th ബാച്ചിൽ, ഇവിടുന്ന് MD ചെയ്തതാണ്. അപ്പോൾ ഇംഗ്ലണ്ടിൽ ഞാൻ വർക്ക് ചെയ്യുന്ന എഡിൻബറോയിലെ ആസ്പത്രിയുടെ കുറച്ചപ്പുറം വേറൊരു ഹോസ്പിറ്റലാണ് വർക്ക് ചെയ്യുന്നത്. അപ്പോൾ മനോജ് കുറച്ച് കാലം ഈ ബ്രസ്റ്റ് റേഡിയോളജി മാത്രം ചെയ്തിരുന്ന ആളാണ് സിംഗപ്പൂർ. അത് മടുത്തിട്ട് അത് വയ്യാന്ന് വെച്ചിട്ട് UK വന്ന ആളാണ്. അപ്പോൾ മനോജിനോടും ചോദിച്ചു, മനോജ് ഈ മാമോഗ്രാഫി, ഞാൻ പണ്ട് കോഴ്സൊക്കെ അറ്റൻഡ് ചെയ്തിട്ടുണ്ട്. അപ്പം മനോജ് പറയാം, സാറേ ഈ വളരെ കുറച്ചേ മനോജ് സംസാരിക്കുള്ളൂ, അറിയാലോ സാറേ, ഈ മാമോഗ്രാഫി ഭയങ്കര ബുദ്ധിമുട്ടാണ്. ചെസ്റ്റ് എക്സ്റേ പോലൊരു സാധനമാണ്. ആലോചിച്ച് നോക്കി. അതായത് മാമോഗ്രാഫിയെ പുള്ളി കമ്പയർ ചെയ്തത് ചെസ്റ്റ് എക്സ്റേയോടാണ്. നമ്മളൊരിക്കലും കണ്ട് തീരാത്ത, അപ്പോൾ ഈ വലിയ ലീഷൻ കാണാൻ പ്രയാസമില്ല, പക്ഷേ ലങ് ക്യാൻസർ മിസ് ചെയ്ത മോശമല്ലേ. നമ്മളിപ്പോൾ അടുത്ത കാലത്തെ ഏറ്റവും അവസാനത്തെ സ്റ്റാറ്റിസ്റ്റിക്സ് അനുസരിച്ച് പോലും ഏറ്റവും കോമൺ ലങ് ക്യാൻസർ തന്നെയാണ്. ക്യാൻസേഴ്സിൻ്റെ ആ സീക്വൻസിൽ 1, 3, 5 സ്ഥാനങ്ങളിൽ മാറ്റമില്ല. 3 കോളോറക്റ്റിലും 5 ഹെപ്പറ്റോ ബിലിയറിയും 1 ലങ്ങുമാണ്. 2 ആണുങ്ങളിൽ പ്രോസ്റ്റേറ്റും പെണ്ണുങ്ങളിൽ ബ്രസ്റ്റും. 4ാമത്തത് 2ലും ഇപ്പോൾ പാങ്ക്രിയാസ് മേലോട്ട് കയറി. അപ്പോൾ പിന്നെ ലങ് ക്യാൻസർ പണ്ടത്തെ പോലെ അല്ലതാനും. അവരൊരുപാട് കാലം ജീവിക്കുന്നു, പലരും കംപ്ലീറ്റ്ലി ക്യൂർ ചെയ്തു പോകുന്നു. അതിന് കാരണം എന്താണെന്ന് വെച്ച് കഴിഞ്ഞാൽ ചെസ്റ്റ് എക്സ്റേയാണ് നേരത്തെ കണ്ടുപിടിക്കുന്നുണ്ട്, 1 സെൻറ്റിമീറ്ററൊക്കെയുള്ളപ്പോൾ കണ്ടുപിടിക്കുന്നുണ്ട്. ന്യൂമോണക്ടമി ഇപ്പോൾ കാർഡിയോതൊറാസിക് സർജൻസ് ചെയ്യാറില്ല, ലോബക്ടമി പോലും ചെയ്യാറില്ല. അവർ മിക്കവാറും റിസക്ഷനാണ് ചെയ്യുന്നത്, സെഗ്മെൻ്റൽ റിസക്ഷനാണ് ചെയ്യുന്നത്, എന്നിട്ട് കംപ്ലീറ്റ് ക്യൂർ ചെയ്യുന്നത്. അപ്പോൾ കാണുന്ന ഒറ്റ വഴിയേ ഉള്ളൂ. പണ്ടൊക്കെ വെച്ചാൽ പേഷ്യൻ്റെ അടുത്ത് പഴയ ചെസ്റ്റ് എക്സ്റേ ഉണ്ടാവാൻ സാധ്യതയില്ല. ഇപ്പോഴങ്ങനെയല്ല, നാട് നിറയെ ആസ്പത്രിയൊക്കെ ഉള്ളതുകൊണ്ട് മിക്കവാറും ആളുകളുടെ അടുത്ത് നേരത്തെ എടുത്ത് എക്സ്റേ ഒക്കെ കാണും. പിന്നെ അവരത് വീട്ടിൽ കൊണ്ടുപോയിട്ട് എന്താ പറയണ്ടേ, ബില്ലൊക്കെ സൂക്ഷിച്ച് നോക്കും പേഷ്യൻ്റ്. പക്ഷേ എക്സ്റേ കഴുകിയിട്ട് സൂര്യഗ്രഹണം നോക്കാനോ അല്ലെങ്കിൽ അടിച്ചു വാരിയ വേസ്റ്റ് കളയാനോ ഒക്കെ ഉപയോഗിക്കും. അങ്ങനെ ചെയ്യരുത്, സൂക്ഷിച്ച് വെക്കണം. ബില്ല് കാണിച്ചു തരും കേട്ടോ, എക്സ്റേ അടിച്ചതിൻ്റെ കൊടുത്തു കഴിഞ്ഞാൽ ആ ഒറ്റ കമ്പാരിസൺ കൊണ്ട് പേഷ്യൻറ്റിന് ഒന്നും ഉണ്ടാവില്ലല്ലോ. ആ ഘട്ടത്തിൽ ലങ് ക്യാൻസറിന് ഇപ്പോൾ പേഷ്യൻറ്റിന് ഇൻഫെക്ഷൻ ഒന്നുമില്ല, ഒരു സാധനം അവിടെ കാണുന്നുണ്ടെങ്കിൽ 99% അത് ലങ് ക്യാൻസർ ആയിരിക്കും. ആ ഒറ്റ കാര്യം കൊണ്ട്, അല്ലാണ്ട് ബാക്കിയുള്ള റയർ സംഗതികളെക്കാളും കൂടുതൽ ആ ഒറ്റ കാര്യം കൊണ്ട് ഒരു ചെസ്റ്റ് എക്സ്റേ നമ്മൾ വീണ്ടും വീണ്ടും നോക്കുന്നതിൽ വളരെ വളരെ ജസ്റ്റിഫൈഡ് ആയ ഒരു സാധനമാണ്. അപ്പോൾ രാജേന്ദ്രൻ ആദ്യം കാണിച്ച കംപ്ലീറ്റ് സീക്വൻസ് ഐ തിങ്ക് യു കവേർഡ് ഓൾമോസ്റ്റ് ഓൾ. എൻ്റെ ഒരു പ്രസൻറ്റേഷൻ ഉണ്ട് യൂട്യൂബിൽ, അതിൽ അക്കലേസിയയില്ല, എനിക്ക് ആ സാധനം വേണം കേട്ടോ. ഞാൻ വിചാരിച്ച നാട്ടിലിപ്പം രജീന്ദ്രനാഥ് അവിടെ ഇരിപ്പുണ്ട്, ഞാൻ വിചാരിച്ച അക്കലേസിയൊക്കെ വളരെ കുറവാണെന്നാണ്. പക്ഷേ എന്നോട് ശ്രീജയൻ പറഞ്ഞത് ഇപ്പോഴും 8 മുതൽ 10 വരെ കേസ് ഒരു കൊല്ലം ചെയ്യാറുണ്ടെന്നാണ്. ഞാൻ കോളേജിൽ ഡിസ്കഷൻ ചെയ്യാൻ പോകാറുണ്ട്. അപ്പോൾ രാവിലെ ഒരു ദിവസം അടുപ്പിച്ച് ഒറ്റ ദിവസം 2 അക്കലേസിയ ഉണ്ട്. അപ്പോൾ ഞാൻ കുറേ കാലം അക്കലേസിയ കണ്ടിട്ട്, അപ്പോൾ അപ്പോഴേ വിളി പറഞ്ഞത് അല്ലല്ല, പേഷ്യൻസ് ഇപ്പോഴും ഉണ്ട്, 8 മുതൽ 10 വരെ കേസ് ഓപ്പറേറ്റ് ചെയ്യാറുണ്ടെന്ന് ഒരു കൊല്ലം കോഴിക്കോട് മെഡിക്കൽ കോളേജിൽ. അപ്പോൾ അതൊഴിച്ച് ബാക്കിയുള്ള എല്ലാ കേസുകളും യു കവേർഡ് ഓൾമോസ്റ്റ് ഓൾ. അപ്പോൾ എന്താ പറയേണ്ടത്, കാറ്ററാക്റ്റൊക്കെ നേരത്തെ ചെയ്തതാണെങ്കിലും ഈ റേഡിയോളജിസ്റ്റും കൂടി ആയതുകൊണ്ട് അടുത്തുള്ളതേ കാണുള്ളൂ. ഒരു മോണിറ്റർ ഡിസ്റ്റൻസ്, ഒരു 1 മീറ്റർ ദൂരത്തിലുള്ളതേ കാണുള്ളൂ. അതുകൊണ്ട് തുളസീധരനെയും ബിനോയിയെ അല്ലാണ്ട് തൊട്ടുപുറകിൽ ചാന്ദിനി എഴുന്നേറ്റ് പോയെന്ന് തോന്നുന്നു. ചാന്ദിനി, പിന്നെ രജീന്ദ്രനാഥ് സാറ്, പിന്നെ മുസ്തഫ, അങ്ങനെ കുറച്ച് പേര് ബാക്കോട്ടുള്ളവരൊന്നും ഇറങ്ങി വന്നാലേ ഐഡൻറ്റിഫൈ ചെയ്യാൻ പറ്റുള്ളൂ. സാരമില്ല, ഇറ്റ് വാസ് നൈസ് ടു ബി ഹിയർ. പോയിട്ട് ആക്സിഡൻറ്റിൽ ഇപ്പോൾ രാജേന്ദ്രൻ സംസാരിക്കുമ്പം ഞാൻ ഇന്നലെ ഉറങ്ങിയിട്ടില്ല, ഇന്ന് രാവിലെ ഒരു 4 മണിക്ക് ഒരു ഫ്ലൈറ്റിന് വന്ന് ഇറങ്ങുമ്പോൾ രാജേന്ദ്രനോട് ഞാൻ പറഞ്ഞു, നിൻ്റെ ടോക്കുള്ളതുകൊണ്ട് ഞാനത് തീരാറാവുമ്പോഴത്തേക്ക് എത്താമെന്ന്. അപ്പോഴത്തേക്ക് കഴിയുമെന്ന് കണക്കാക്കിയിട്ടാണ് ഞാൻ 11 മണിക്ക് വന്നത്. പക്ഷേ അപ്പോഴത്തേക്ക് എത്തിയതുകൊണ്ട് ഇങ്ങനെ ഒരു അവസരം കിട്ടി. ഐ ഹോപ്പ് യു ഓൾ എൻജോയ്ഡ് ദാറ്റ്. കോൺസെൻട്രേറ്റ് ഓൺ യുവർ ചെസ്റ്റ് എക്സസൈസ്. അതൊന്നുമില്ലാന്ന് തോന്നിയാലും പേഷ്യൻറ്റിനോട് ഒരു പറയും, സൂക്ഷിച്ചു വെക്കാൻ പറയും, പിന്നീട് എപ്പോഴെങ്കിലും ഉപകാരപ്പെടുന്നു. അത് ക്യാൻസർ നോക്കാനാണെന്ന് പേഷ്യൻറ്റിനോട് പറയണ്ട. പക്ഷേ മോസ്റ്റ് റിവാർഡിങ് എന്നുള്ളത് പഴയ ചെസ്റ്റ് എക്സ്റേ കമ്പയർ ചെയ്യുന്നതാണ്. അത് കമ്പയർ ചെയ്തിട്ടാണ് പറയുന്നത്. അല്ലാതെ ഈ 0.5 മില്ലിമീറ്ററുള്ള സാധനം സി ടി ചെയ്താൽ ഓഫ് കോഴ്സ് ഇറ്റ് വിൽ ബി പ്രൂവ്ഡ്. പക്ഷേ എല്ലാവരും കയറി സി ടി ചെയ്യാൻ പറ്റില്ലല്ലോ. സോ ദാറ്റ് ഈസ് ദി വാല്യൂ ഓഫ് ദീസ് സോർട്ട് ഓഫ് റീവിസിറ്റിംഗ് ദീസ് സോർട്ട് ഓഫ് ടോപ്പിക്സ് എഗെയിൻ ആൻഡ് എഗെയിൻ. പറഞ്ഞാലും തീരാത്ത ഒരു സാഗരമാണ് എസ്പെഷ്യലി ചെസ്റ്റ് റേഡിയോഗ്രാഫി. താങ്ക് യു.
Thank you, sir.
Thank you, sir. I call upon Dr. P.V. Ramachandran, sir, to hand over the memento to Dr. Rajendran. Thank you, sir. I call upon Dr. C.P. Mustafa to hand over the mementos to the chairpersons, Dr. P.V. Ramachandran and Dr. Jayachandran. Dr. C.P. Mustafa is the past president of IMA Kozhikode, senior general practitioner, Calicut Nursing Home. Thank you. There's an announcement. All those who have come for the poster presentation, please
promptly refer them to the concerned specialty. And similarly, it is challenging because most of them present with subtle signs and symptoms, and even though they are very life-threatening conditions, the initial symptoms may be very subtle. So catching them up at early enough, it is mandatory to have a proper or critical outcome of these patients. To address this interesting topic, we have Nikhil Sridhar. And Nikhil Sridhar is, he has completed his MBBS from Pariyaram Medical College, in which he did his MS ENT from Stanley Medical College, Chennai. And he did a 1 year of senior residency in Vellore Medical College, following which he joined in the medical education in the year 2019. After a short service in Idukki Medical College, now he is there with us, and we are very happy to have Nikhil Sridhar with us. He is a very enthusiastic and dynamic person who is interested in not only in patient care, in teaching, and also in research activities. So, ladies and gentlemen, please welcome Dr. Nikhil Sridhar on the topic chosen is ENT emergencies. Over to you, Nikhil.
Thank you, ma'am. Firstly, I'd like to thank the organizers of Cgpcon, Chandni ma'am and Ranjit sir, and also IMA Calicut, and my HOD, Dr. Sunil Kumar sir, for giving me this opportunity. So today I'll be talking about ENT emergencies. So we won't be able to cover all the emergencies. I've just taken a few. I put it into small case scenarios. So we'll go through as many as time permits. Okay. So when you talk about ENT, the first thing that comes to our mind is foreign bodies. So this is a typical case, a 5-year-old boy comes, and usually these foreign bodies, nose and ear, are in that age group, that 5 to 10, 12 years. So they've put a bead in the ear, or they put something in their nose, and they've come. So the most important thing in attempting these foreign bodies is immobilizing the child. So if you have a child that you can hold down, it's fine. But if you have a moving, screaming child, it becomes a nightmare. Just So this was the foreign body that was removed from the ear, and we couldn't remove it when the father was holding. So then I sat down and I had to hold the child. And after 2 or 3 syringes, the foreign body came out. So after the foreign body, we took a small video. This is how you have to immobilize the child. So your legs should cross and the child's legs should be held between his legs. One hand, the other hand,
മറ്റേ സൈഡ് ഹാൻഡ് മാറ്റുന്നതിന് പകരം ഈ കൈയാകുമ്പോൾ മറ്റേ കൈ ഇങ്ങോട്ട് സിറിഞ്ച്
for maybe 2 minutes, that's all. But after that, I was literally sweating and I was panting. It takes a lot of strength to keep a 5-year-old child down. So don't give the mother or the father, or preferably not the attender, to hold. Get somebody from outside, somebody built so that they can hold it. 5 years, 6 years, they can be very, very strong. Okay. Ear foreign bodies, you can use small crocodile forceps if it's something that you can hold like an insect or a leaf twig. If it's a smooth foreign body which you can't grasp with the forceps, you can try probing, but I would advise against it, because once the foreign body is gone beyond the curvature of the external aortic canal, probing will be very, very difficult in a moving child. Okay, so in that case, you can syringe. Now, if it is a vegetative foreign body which will swell after it comes into contact with water, like a seed, then don't syringe, try and suction. So these are your options for ear foreign bodies. So sometimes the patient comes with you with the live insect. So they'll come, they'll say, yo, endo odunnu, endo, be very anxious. So you tell them, you calm the patient down, tell them to lie down for some time and put some viscous fluid, like liquid paraffin, into the ear and kill the foreign body. So if you don't have liquid paraffin, you can ask the attendant and go and buy parachute oil, coconut oil. ear, fill the ear canal, let the patient lie down for 10 to 15 minutes. Once the insect is dead, then you can attempt removal. Don't try and remove a live moving foreign insect. Okay, so that is about ear and foreign bodies. And if it is already been attempted from outside, somebody is already probed, it's bleeding, the canal is edematous, don't again try removing under local anesthesia, or you have to take the child probably under general anesthesia. So refer those kind of cases. Don't keep on trying one. Okay. On the same note, nasal foreign bodies, same principle. You have to hold the child down and attempt nasal foreign bodies only if you can see them on headlight examination. So you have a headlight or your whatever light source you're going to use, just lift the tip of the nose up, and if you can see the foreign body, only then attempt. Don't, if you have a foreign body in the X-ray, or somebody's done an endoscopy and there is a foreign body, but you can't see it like that, then don't go blind probing. Okay? So attempt only if it is seen, and use a blunt instrument like a nasal foreign body hook. So you hooks, nasal foreign body hooks, which has a blunt end, or if you don't have a nasal foreign body tip, something that does not injure the mucosa. Okay, and this is how you remove. So you have a headlight, you can use a speculum. So you visualize the foreign body, you put the probe above the foreign body. Okay, and then angulate it so that your probe directs to the floor, and then slowly try to tease the foreign body out. Don't put in your instrument, hitch on the floor and drag. So that will cause a tear on the nasal mucosa, it will start bleeding, and then you won't be able to see the foreign body. Be very gentle, go along the septum above the foreign body, and then go down toward the floor, and then slowly tease it out. Okay, so that's the right technique of removal of nasal foreign bodies. Now, in order to visualize, you have very cheap equipments. I think everybody can afford this. Otoscope for the ear and foreign body, you can get it for around 1,000 rupees. Otoscope, but to see foreign bodies, it's more than enough. A better investment would be this camera. You can get this endoscopic camera, you can connect it to your phone, and you can actually show the parents or whoever that, this is the foreign body inside. So these are some things you can use. Okay. Now we come to a foreign body throat. Now foreign body throat, generally it requires general anesthesia to remove. We do a lot of local removals because shortage of GA tables in our institute. But generally it's preferable to remove under GA. This case I'm presenting only because it presented a lot of interesting things about throat foreign bodies. Okay. So this 50-year-old lady, she came with dysphagia just that day morning. And she had no non-veg, or she had no food ingestion. There was nothing. She said she didn't take anything non-veg. So, but she says that dentures 2 days back. So now we were worried because probably it's the denture that is there. So we took an X-ray. X-ray was not showing anything. It was just a prevertebral soft tissue widening, and there was no foreign body. So since there was a prevertebral, probably it's missed on X-ray, so we did a CT neck. CT also, there was no foreign body. Only there was a tear in the posterior pharyngeal wall and this prevertebral soft tissue widening. So then what we thought is probably the denture passed through the esophagus, caused a tear, which was causing the abscess, and the foreign body is now in the abdomen. So we took the imaging of the abdomen, no foreign body. So finally we did an endoscopy, and to our surprise, the foreign body is lying right there in the esophagus. So you have these kind of dentures. So sometimes the teeth would have been there. Even after the teeth is gone, they continue to use the dentures. So, and this will not be seen on X-ray, CT. So your X-ray picture will be like this. You see this? I think sir had already spoken about retropharyngeal abscess. So you see this line shows the prevertebral space, and it is widened. And if you extrapolate that line onto the vertebra, it's almost double. So a normal prevertebral shadow will be less than half of the size of that corresponding vertebra. Here it is almost double. So, and there is gas shadows. So you can see there are gas shadows. So this is an evolving retropharyngeal abscess, but this foreign body was not seen. So sometimes you'll have foreign bodies like this. So only that teeth will probably be radiolucent. So you'll think it's a very small foreign body, but when you take it out, it'll be a huge denture. So this is how some throat foreign bodies can be tricky. And in other instances, it can be opposite. The foreign body is seen on X-ray, CT very clearly, but when you go into the endoscope, it will not be seen. Why? Because it has pierced the esophagus. It's not in the lumen anymore. It's outside. So it is important that you refer patients with a foreign body early, because after a few days it will get mucosalized and then it is hell to remove it, because you can't do it endoscopically, you'll have to go through the neck. So refer these patients early, okay? So yeah, so I think we spoke about all that, and beware of the development of retropharyngeal abscess. Now this third case. It's a very common scenario, okay? A 7-year-old boy presented with severe earache since maybe last evening or since today morning, whatever. And there is a history of upper respiratory tract infection. So think about what diagnosis you would have. You look at the you have a red, congested, angry-looking, bulging tympanic membrane. So the diagnosis is quite obvious, acute otitis media. The reason why I put this as an ENT emergency is because of this. We have a lot of cases that are referred. Whenever you think it is acute otitis media, we start on antibiotics. Antibiotics is not required for all cases of acute otitis media. There is just, for children above 2 years, there are just 2 indications. One, if there is otorrhea, if there is discharge, once the TM is ruptured, okay, you can start antibiotics. Otherwise, if they have severe symptoms, non-remitting pain. Generally, children with acute otitis media will have pain for 2-3 hours. That means at night they'll be next day morning, they'll bring the child to the hospital, and that time when you look at the child is not having any pain. So usually it's just bouts of pain. Okay, so unless, otherwise if the child has continuous pain or some complication like a mastoid abscess or a facial paralysis, anything of that sort, don't start oral antibiotics. Antibiotics are not required for acute otitis media. Another thing I'd like to highlight is there is no point putting drops on this kind of a tympanic membrane. If you keep putting drops, then it is not going to reach the middle ear. So there is no role for any ear drops. So when the patient comes with ear pain and you think it's otitis media, treat the upper respiratory tract infection. Give nasal drops, give nasal decongestants, but don't give ear drops. Don't prescribe antibiotics unless needed. And if the child is less than 2 years, one more indication is if it is bilateral. If your child has both ears pain, then you can start antibiotics. But otherwise, don't start oral antibiotics. Treat symptomatically. Okay. And refer the patient if they don't respond within 2 to 3 days of antibiotics. And on the same note, this is so can you guess which is perichondritis and which is cellulitis? So, the first picture, this picture is perichondritis. You see, it is the redness and is restricted to the areas where there is cartilage in the pinna. You see the lobule is spared. But you see in cellulitis, even the lobule gets involved. So in cellulitis, there may be a furuncle in the external aortic canal which is causing a secondary cellulitis, or on the pinna, or there's some scalp infection causing a cellulitis. So it will be a diffuse thing involving the pinna as well. Perichondritis, there will be history of trauma with exposed cartilage, there will be ear piercing, something where you disturb the cartilage. So it will be like this. So the antibiotics you prescribe will be different for both. Here in cellulitis, you will want to cover staph and you'll give antibiotics that have good skin penetration, whereas here you will give ciprofloxacin which has good cartilage and bone penetration. Okay. Okay, another case. A 75-year-old man, diabetic, present with left ear ache since the past 1 week. So remember, it's 1 week duration, it's worse at night, and he notices some minimal discharge. So he's already consulted a physician and they've prescribed analgesics, routine antibiotics, and it's not subsiding. So these are points that you have to keep your antennae up. So it's a diabetic patient, maybe an immunocompromised patient, elderly patient, patient who's not responding to your normal treatment. Usually, most cases of otitis externa, unless it is auto, will respond to your general antibiotics within 2 to 3 days. For 1 week, if the patient is having, please, and you look into the canal, you might get maybe a small granulation, a polyp, a mass. Sometimes there won't be anything, there'll be just edema of the canal. So think of this condition, malignant otitis externa, which is a precursor to skull-base osteomyelitis. So when you're dealing with diabetic patients, immunocompromised patients, don't keep giving antibiotics if they're not responding. Send them to a specialist because they will need investigation. They'll need long-term treatment for this condition. Okay. So, and do not image these patients because they will need a specific set of imaging, and your imaging will not help in the diagnosis also. So, if you want to start them on antibiotics, the best antibiotic will be ciprofloxacin, 500 mg BD. You can safely refer the patient if you suspect malignant otitis with this curve, because the most common organism is Pseudomonas. Okay, so the next one. So this, just think about what you think as the diagnosis, okay? So a 35-year-old man, he's absolutely normal. He gets up in the morning one day, he's having fullness in his ear, okay, right ear. And he's not able to hear. He's having a block. He's having this tinnitus in his ear. And upper respiratory tract, he says that korchu jaladoshakku undayirunnu or 3 days back, not very specific. What do you think the diagnosis is? Do you think this is an emergency? So you could have benign conditions like a middle ear effusion. Sometimes wax, he would have probed something and the wax would have got impacted and he would have had a ear block. But this is also a possibility, a sudden sensory neural hearing loss. One person comes with a sudden loss of hearing, tinnitus in 1 ear. Even young people, when they come, you have to differentiate whether it is a conductive pathology, which can happen because of wax or ear fluid or upper respiratory, whatever, and a sensory neural problem. So how do you easily differentiate? You can do if you have a tuning fork in your office, you activate the tuning fork, keep it on the patient's forehead. If the vibration is heard on the affected ear, then you are happy. It is just conductive and you can give symptomatic treatment. But if the sound is heard only in the good ear, that if it goes to the opposite side, then you have to suspect sensory neural hearing loss. And suppose if you don't have a tuning fork, then what do you do? So you can do the simple test called the hum test. So you close your mouth, ask the patient to close the mouth, clench their teeth, and then make this sound. So you can try it yourself now. If you open and you go, you won't feel that the hum is localized. But you take your finger, you close the ear, and then you go, the ear that you caused that conductive loss, the hum will be lateralized. So it is similar to a tuning fork. If you go, I can hear it on my right. So it is similar to using a tuning fork. If the hum is heard on the affected ear, it is conductive. If it is heard on the opposite ear, then it is sensory neural. So you can easily, even over the phone, you can differentiate. And if the patient is confused as to which side he's hearing, or if he's hearing to the good ear, then suspect sensory neural loss. And in sudden sensory neural loss, it is imperative that you start steroids within a window period. And the best time to start is within 24 to 48 hours. If you lose this window period, or if you lose beyond 1 week, then even starting steroids may not help the patient. So it is the first contact people who have to be very careful about this condition, and don't start on low doses. Start on higher dose, 1 mg per kg prednisolone. You can start. If the audiogram is taken 2-3 days later, and if you find that it is conductive, it's no problem. He's taken 2-3 days of high steroids. You don't have to taper. You can stop the steroids straight away. But start the patient on steroids if you suspect sensory neural loss. Okay, this is a common scenario. Husband hits the wife. Wife has a ringing sensation in the ear. Or child is playing with something, brother comes and pushes his hand, and then something goes and blood starts coming from there. So external aortic canal trauma. What would you do in these conditions? When this kind of a patient, what would you do? What would you prescribe? So ideally, don't prescribe anything. Don't give ear drops. If you give ear drops in this kind of a traumatic, you will be inducing an infection. If you have an external aortic canal trauma, there is no need for prescribing antibiotic ear drops, analgesic ear drops, no need. These clots will heal, and only if there are signs, like after 2-3 days, if there is canal edema, if there is pain, only then, most of the time, these conditions heal on their own. So don't give drops, don't give antibiotics, don't try to remove the clots. Let the clots be there, it will come off on its own. Only advise the patient that keep the ear dry. And how do you keep the ear dry? You take cotton, apply Vaseline over it, and plug the ear. That is the only thing that you need to do when they're having a bath. After that, they can keep it open. Okay. So, then we come to epistaxis. So a 60-year-old hypertensive man, he comes with acute onset bleeding, both nostrils. And arriving on the casualty, there is just a minimal ooze, and his BP is normal. So this is something that we see. Most of the blood pressure, but sometimes you have cases which is a hypertensive bleed, but when you look at the BP in casualty, it will be normal. So don't rule out that possibility, and ask the patient for any drugs that he's taking, whether he's taking antiplatelets or any other anticoagulants. Epistaxis management, 90% of the epistaxis will stop. Okay, if it's traumatic, it will stop. If it's hypertensive, it will stop. Just give them some time. If you're not familiar with packing, just ask them to pinch the nose, bend forward, and just wait for 10 to 20 minutes. During that time, you can do all the other investigations. You can see if he's hemodynamically stable. You can do the routine blood investigations, platelet counts, coagulation profile. You can do cross-matching and typing. You can arrange all that, and most of the time by holding itself, the bleeding will stop. Suppose it doesn't stop, then it's a little more severe. In that case, you have to control the BP and you have to pack. Nowadays we have these commercial kits available for packing. So one of the most commonly used is, the brand name is Ivalon. Okay, so you can get these things they come in these rigid strips. You see those rigid strips are there. So you just insert that strip into the nose and fill it with water, and it'll fill like a sponge, and it'll stop the bleeding. So they're very easy to use, and most of the bleeding will be controlled before. You can refer by just putting this in the nose, and you can refer. So this is easy. Don't put cotton wicks in the vestibule only, and then, because all the patient will then start swallowing, and then they'll have hematemesis, and they'll vomit out that blood. So if you want to pack, you pack with Ivalon. Otherwise, just ask them to pitch their nose and refer. And this is the direction of insertion. So whenever you insert something in the nose, don't go along the dorsum. Never insert something like this. Always draw a line from the tip of the nose to the lower border of the ear, lower part of the pinna tragus. That is the line of insertion. So you insert along the floor, and most of things will go down. All the packs or whatever you're trying to insert will go in that direction. If you want to do a formal anterior nasal packing, then you'll need a speculum, and then this is the right way. You make layers. You start from the floor, and then you make layers up till the roof. Okay, so this is a little technically challenging, especially in a bleeding patient, but Ivalon works just fine. And if you want to do postnasal packing, it's very simple. Take a Foley's, visualize the Foley tip in the oropharynx. Ask them to open the mouth. When you see it, inflate the bulb and just pull it back. So it will come and sit snugly in the choana. And once you've done this posterior nasal pack, you can be sure that nothing goes into the throat. And anteriorly, you can put this Ivalon, and you can fix it there, and you can refer the patient. Okay. So that's about management of epistaxis. Okay. So this I just want, what do you think this is? So the history is that there's a blunt trauma to the nose. 2-3 days later, no epistaxis, the patient comes like this. So this is a condition called a septal hematoma, or it may be an evolving septal abscess, where you have a fluctuant swelling on either side of the septum. And if you touch the septum, you can feel that fluctuance. So you can just put a needle and aspirate and see. Sometimes you might get blood. Sometimes if it's a few days, it'll be clotted. You won't get any thing. But there is no harm. You can put a small nick, or refer these patients early. If you don't want to put a nick, if you don't want to address this, don't tell them it's fine, it'll subside, because they won't be very symptomatic. They won't be having pain or anything. But if you leave this like this, it'll cause necrosis of the cartilage, and then they'll have a deformity of the nose. So when you see a condition like this, either and release all the pus and blood, or refer early. So this is how you put incision. They say a horizontal incision, but if that's difficult, even a vertical incision along the septum, and put a small wick inside, so that whatever is pus or whatever drains out. Okay, so this I put because we get a lot of cases where there is acute sinusitis, and as a complication, the patient develops a facial swelling or periorbital swelling. So this is a preseptal cellulitis or orbital cellulitis secondary to sinusitis. So you can give oral antibiotics and watch for 2 to 3 days. Respond very well to steroids and antibiotics. But in case they don't respond, okay, nowadays, especially post-COVID, we're getting young patients. At least now it's less, but at least during that time of COVID, we're getting a lot of patients who have atypical features, atypical sinusitis, like fungal sinusitis, mucormycosis. I'm sure all of you have heard of it. So if it's not subsiding by your usual antibiotics, or if there's something out of the normal, like if the patient is having a lot of symptoms but nothing is seen on scan, like even if you take a CT scan, there's not much of mucosal thickening, there's no bony erosion, but the patient is having severe pain, and if it is a diabetic patient and all, refer these patients early, because they may be having some fungal sinusitis or skull-base osteomyelitis and things like that. Okay, so if it's not responding to treatment, refer early. So this is not an emergency that you would want to manage in your office. It is something that you will have to take to theatre. So there are 2 types of injury. One is like the first case. So a motorcycle rider does not, his neck gets entangled, so it's blunt injury, or somebody strangles the neck, so some blunt trauma to the neck. The other is a cut throat, either suicide or homicide. So these are 2 presentations. So this is how they'll come. One obviously see the cut. The other will be having contusions, pain over the neck. So the cutthroat injury will need exploration. If you can see the airway, the patient is stable, you don't have to do anything immediately. Don't touch the wound in the office. Ideally, take it to a theatre setup and then only disturb the clots. If the patient is desaturating and you can see the airway, you can see it very clearly, then in an emergency setting, what you can do is you can put the tracheostomy tube or a small size ET tube without disturbing the clots into that airway and inflate and then bag the patient. You can ventilate. Okay. That is only in an emergency. Most of the time, these patients are stable. Even with an open airway here, they are quite stable. They can be referred. Avoid intubation in these patients because when you intubate, you might further injure the larynx. The more important thing is the blunt injury, because in blunt injury, they will not have initial, some of the patients will not have any symptoms in the initial period. They just have pain and mild hoarseness. But never send these patients off. Keep them under observation for at least 24 hours, because whatever small hematoma, mucosal edema that develops, it may increase over the few hours. And then patient will start having stridor. So monitor these patients seriously. Ideally, all these patients should have a endoscopy done to see what is the endolaryngeal injury. But if that's not possible, at least don't send these patients off. Keep them under observation. Yeah, and then rule out spine injuries also when you're dealing with neck trauma. Okay, so this is also another spotter. So if you have a patient coming with trismus, difficulty to open your mouth, severe throat pain, dysphagia, you look at the throat and you see a bulge. One side of the pharynx is bulge pushing the tonsil. So this is a peritonsillar abscess or a quinsy. So this white arrow, that is the point where you put a small incision. So if you want to put an incision, you take a 11 blade, and you don't want the blade size to be more than around 0.5 centimeters. So just from the tip, you put a tape. Okay, so it acts like a guard, so that your blade does not go any more than that sticker that you've put. And then put it over here and make a small stab incision. Before you do that, put a needle and aspirate and see if there is pus coming. And then you make an incision. Soon as the pus is drained itself, the patient will have relief of symptoms. But if you don't want to do that, refer these patients early, because it is a potential to obstruct the airway, cause parapharyngeal, retropharyngeal abscesses and all. Okay. And steroids may be helpful under antibiotic cover. Okay, so for want of time, I am skipping vertigo because it is a huge discussion. So I'll come to my last case. So this is actually I think many of the pediatricians in the audience would be familiar with this kind of a case where the child comes with recurrent croup. So the mother says noisy breathing. They give antibiotics, steroids, bronchodilators, everything. Child is normal. Few months later, again, noisy breathing. So if this happens recurrently, there's a recurrent croup, recurrent noisy breathing, and especially if there is a history of some surgery in the past, like the patient has had history recently or any time in the past, think of a acquired or a congenital subglottic stenosis. They need intubation history. Even patients with congenital subglottic stenosis will present with this recurrent croup. And on a patients having recurrent lower respiratory tract infection, like you treat the lower respiratory tract infection, few months later again the child has, so think of a aspirated foreign body. Sometimes it may not be visible on your routine imaging. You may have to do a bronchoscopy itself. So in a patient with recurrent LRTI, keep this possibility in mind. Okay. Now, last two slides, these are not emergencies, but these are common things that which we feel are which need a little more awareness. So nowadays we get a lot of patients with adenoid hypertrophy. So the patients are either counseled to the extreme. One is that the adenoid will be of very small size, but the parents will be convinced that the adenoid is the cause for the child's lack of brain development. They feel that the child's faces will change. So somebody is counseled and they'll want that removed no matter how much you tell them no. And the other end is when you have a huge adenoid, patient is having all the OSA features and they'll still refuse surgery because somebody has told them that it will get normal with age. So adenoid hypertrophy, surgical management, the indication is when they have obstructive sleep apnea. So when these children have problems in concentration, poor scholastic performance, when their sleep is disturbed, ask them how the child sleeps. Is the child keeping on tossing, turning? Is he gasping for breath? Is he sitting up in his sleep? Is he having a lot of sweating during sleep? Enuresis. Next day morning, is the child not alert? Some children become hyperactive. So if they have these kind of change in behavior, if you feel that there is some features of OSA, then refer these patients early for imaging and surgical management. And on the same note, if the children have hearing loss, even if it's mild to moderate hearing loss, if it is conductive loss, bilateral ears, you do an audiogram and there is some fluid in the ear, don't counsel the patient telling that that fluid will settle with antibiotics and all. Because sometimes these fluids form a glue-like substance, and this persistent otitis media is one of the causes for ear disease or a thinning of the tympanic membrane in adulthood and formation of cholesteatoma. So if you have a child with a persistent middle ear effusion, always get it surgically drained. Maximum 3 months of medical management, you still see there's fluid in the ear, get it surgically drained. Because if you leave this child, it'll develop into chronic ear disease in adulthood. And chronic tonsillitis, size is not a criteria for removal except in cases of OSA. If you're removing the tonsil for an obstructive sleep apnea, fine. But otherwise, for infection, size is not a criteria. Just because the child has a large tonsil doesn't mean that it needs to be removed. Okay. And lastly, about newborn hearing and speech and language development. So these are the risk factors for a congenital hearing loss. So if the child has a family history, birth weight is less than 1.5, Apgar score less than 6. If the child has any syndromic craniofacial anomalies, any history of NICU stay, any history of hyperbilirubinemia requiring exchange transfusion, any one of these risk factors also if the child has, child should not be going on screening OA, the newborn hearing screen. That is insufficient for these children. They have to have a complete audiological evaluation. See, the newborn screen is only a screening test. So you can't say that just because the screen is in both ears, it doesn't mean the child has normal hearing. And whether you're an audiologist, ENT surgeon, clinician, whoever, you cannot assess the child's hearing clinically. Just because the mother says that when I call, the child turns around, he's responding to loud noise, it doesn't mean the child is hearing normally. If you want to know, you have to do a complete audiological, includes a BERA, includes a battery of audiological tests. So if there's any suspicion on the parent's part or on your part that there is some delay in speech or language development, always get a full assessment. Even if previously they've done a full assessment, later on they come back with suspicion, do the test again, because there are some conditions where the hearing is normal at young age and there is a progressive decline. So anytime you find a suspicion that probably the hearing could be less, then get a full audiologic evaluation. And these high-risk patients, screening is not at all, in fact, they should not be screened at all. They should go direct for a full audiologic evaluation. So thank you. With that I come to you.
Thank you, Nikhil. You have for that brilliant talk, almost covering almost touching all the, even though vertigo is one of the favorite topic of Nikhil that has not been touched at all, because it itself is a big topic, and he has almost covered on all the major emergencies in ENT, even though there are some areas to be further reinforced, like invasive fungal sinusitis, culpable osteomyelitis, which also comes with very CSF rhinorrhea meningitis, recurrent meningitis as CSF rhinorrhea, which is often missed. Thank you, Nikhil, for that excellent talk. And I'm sure most of them will be having a lot of doubts. If time permits, he'll be happy to answer. Okay. Then we'll go on to the
Ma'am, we are short of time. So thank you very much, sir. It has been a very, like the definition of nutshell, everything in nutshell, it was that. Thank you so much.
Thank you, sir. Thank you.
Thank you. That was Dr. Nijil Seedran, Assistant Professor of ENT. We will move to the next topic, common pediatric emergencies. Speaking on this topic is Dr. Prashant Dev Arvind, Consultant, Pediatric Intensivist, Aster MIMS Hospital. Welcome, sir. The stage is yours.
Hello. First of all, I would like to thank the organizers for keeping this very important topic, that is pediatric emergencies, in this list. Because most of the general practitioners and pediatricians, they come across emergencies in their OPD. And that's the practice here in our setup. So to talk about this, we have got an expert in the field, Dr. Prashant Dev Aravind. He is my colleague. He's now working as a pediatric intensivist, heading pediatric cardiac intensive care now. He did his MBBS from Cochin Medical College, and after that he did his MD from Trivandrum Government Medical College, that is SAT Hospital. And after that he did a fellowship in PICU from Cgpcon Child Trust Hospital, Chennai. And from there he went to Toronto Sick Kids Hospital. Then he did his fellowship in pediatric intensive care and pediatric cardiac intensive care. Then he again took another fellowship from Birmingham, UK. So Dr. Prashant will be covering the topics which are common topics which general pediatricians and general practitioners come across in OPD and hospital-based practice. So over to Dr. Prashant.
Thank you, Suresa, for those very kind words. Thank you, Cgpcon, for giving me this opportunity, as well as IMA Calicut branch for giving me this opportunity to talk on common pediatric emergencies. I'm not sure how much I'm going to justify talking about the common pediatric emergencies in a 25-minute talk, but I'll try to cover some points, pertinent points, so that you go home taking some points back. So I've just divided into these features like a introduction, a quick identification, common emergencies, their management, referring a sick child, what not to do, and some take-home points. So coming to the introduction, so as GPs, you frequently see children with medical conditions that may evolve into emergency if not promptly attended to. And assessment of children is sometimes pretty difficult because the signs and symptoms might be very subtle and not markedly expressed. Also, normal value of vital signs vary with age, and thus their interpretation requires discrete knowledge of age-appropriate values. Now, the most common pediatric emergencies seen during general practice are respiratory distress, shock, anaphylaxis, seizures, and trauma, and this is Indian data, and so it's pretty reliable. And a quick assessment is a bedrock of identifying this, and a quick eyeballing can sometimes help you to identify the sickest of patients, but not always, because sometimes it might even be deceptive. And careful systematic examination becomes the key. So the first step is an initial impression, and this is the first quick assessment of the child by just looking and listening as to what can be done within seconds of encountering the child. It consists of assessing the consciousness, breathing, and color. And as you can see here, this is the pediatric assessment triangle. The level of consciousness, whether the child is alert, irritable, or unresponsive. The breathing, whether it's increased work of breathing, abnormal sounds heard without auscultation, such as stride or grunting. And the color of the patient, whether the child is pale, mottled, flushed, or cyanosed. This gives you an idea as to where the trajectory is with respect to the sickness of the child. And it might help you to have your antenna up and introduce or institute treatment as soon as possible. The next step comes into the pentagon, that is the ABCDE, the next step. So you first take care of the airway, because that becomes the most important part. You need to know whether your airway is clear, maintainable, or not maintainable. And once you take care of the airway, you go into the breathing and see what is there with respect to the breathing of the child, whether there's an abnormal rate, retractions, abnormal work of breathing, asymmetrical air entry, or cyanosis. And then you look at the circulation, abnormal heart rates, weak or absent peripheral pulses, a prolonged capillary filling time, hypotension, mottling, and cold extremities. These are features that tell you you're dealing with a very grave situation. Coming to a neurological disability that stands for D, you go for the AVPU scale. That's your alert, responsive to voice, responsive to pain, and a totally unresponsive child. Or your Glasgow Coma scale and your pupillary response to child. And when it comes to E, that is exposure, you look at temperature, skin rash, PTK, purpura, or injury. So if you go systematically, you will know as to where your child is within a spectrum of illness. And the more graver the child is, you may need to institute treatment promptly or refer the child so that we don't send the child labeling as late referral. Now, the most common emergencies, as I mentioned before, and a careful initial assessment and a good history will help go in a long way in stabilization of the sick child. Coming to approach to respiratory distress. So when a child comes with difficulty in breathing, it is essential to establish the site of the disease, whether it involves the upper airways, your lower airways, or your lung parenchyma, or your central control of breathing. And when respiratory effort is inadequate to sustain effective gas exchange, that is, both oxygenation as well as CO2 removal, your respiratory failure ensues. And so respiratory failure becomes the end stage of respiratory distress, and it requires urgent intervention because the next step is going to be cardiac arrest. So this diagram shows you a level of lesion and symptomatology. So for an upper airway disease, you can have stridor, a barking cough, hoarseness, suprasternal retractions. For a lower airway disease, you can have wheeze, prolonged expiration, and subcostal retractions. And for a lung or parenchymal disease, you can have grunting, crepitations, reduced breath sounds, or intercostal retractions. See, there's no rule that there can be a mixed pattern, right? So imagine a child who comes with a massive aspiration. You can have some upper airway issues, lower airway issues, as well as parenchymal issues, depending upon how fast the child was brought into your care. Because if it's, say, after a gap of, say, a couple of hours or so, you can have parenchymal involvement, and the child may have all three features. So what you need to assess is actually where the child stands with respect to gravity of the situation. As I mentioned, your A, B, C, D, E to institute treatment. And the clinical signs of respiratory distress, as mentioned before, your abnormal respiratory rate or effort, your abnormal airway sounds, your deterioration in skin color, pale, cool skin, or being cyanosed, and changes in the level of consciousness, drowsy, markedly irritable, or agitated. Now, please always take care with level of with respect to level of consciousness, because that shows how much oxygen is going into the brain. So if you have a very, very, very agitated child or very drowsy child, that means the oxygen that enters your blood is not reaching the brain enough, and that is a very grave situation. So for upper airway disease, you have a lot of differential diagnoses like angineurotic edema, enlarged tonsils, inflamed sinuses, croup, epiglottitis. For your lower airway disease, the commonest causes being bronchiolitis, asthma, a foreign body, or a lymph node enlargement. And parenchymal disease as well, you have a lot of DDs, including pneumonia, ARDS, pulmonary edema, pleural effusion, and pneumothorax. Now, what do you do with respect to management? You keep the child in a position of comfort, you minimize agitation. Now, if upper airway obstruction is suspected, then perform manual airway measures such as your head tilt, chin lift, a jaw thrust in case of suspected cervical spine injury, a suctioning of the nose or mouth if secretions are present. That becomes extremely important. I've seen patients, especially less than 2 or 3 months, when they are referred with respiratory distress with just a nasal block. Remember, the younger you go, especially in neonates, they are obligate nose breathers. They can breathe only with the nose. So once you have a significant nasal block, they might come to you with severe respiratory distress. So clearance of the upper airway is of paramount importance here. And provide humidified oxygen, preferably with high concentration delivery devices like head box for infants less than 6 months, or an oxy mask, or NRMs for older children. You start inhaled medications as indicated, whether it's bronchiolitis or asthma, you can start those pertinent medications. You monitor the vitals if possible. If you have a good monitor, please ensure that you monitor the vitals so that you know where you are with respect to cardiopulmonary reserve, especially heart rate, respiratory rate, blood pressure, and SATs. And establish vascular access for fluid therapy, investigations, and medications as indicated. Now, after initial stabilization of the child with respiratory distress, further management depends upon the underlying etiology. Now, this is just a very, very quick summarization of the major causes for respiratory distress. For croup, you give nebulized adrenaline and you can institute steroids. For bronchiolitis, remember it's humidified oxygen that works. Nothing else works. It's humidified oxygen, and you can give some 3% saline nebulization and time. That's the only thing that works. Plus some pressurized air delivery mechanism like HFNC or NIV. For asthma, you have your routine medications, your humidified oxygen, your salbutamol or ipratropium MDIs. For salbutamol, you can give 6 puffs if the child is less than 6 years, or 12 puffs if the child is 6 years and over. You can consider ipratropium nebs as well, and you can give oral steroids, which is as effective as IV steroids. Please remember that these are all not fixed doses, because if you're using MDIs and your delivery is not proper, the child is not going to get it. It's not some like IV medications where your bioavailability is going to be 100%. So there's no cut and written in stone that you should never give more than 6 puffs. Because if you give the adequate amount, the child will show some response, and if you give, say, salbutamol, the child will show some tachycardia. If there's no tachycardia after your beta agonist, that means you haven't given enough beta agonists. Now coming to the next category, that is approach to shock. So remember, shock is a critical condition where you have inadequate tissue delivery of oxygen nutrients. So it's a balance between the two. You have a demand-supply mismatch. So either your demand for oxygen can be more, or your supply is less, or it can be a combination of both. So you have to manage both aspects, both with respect to demand as well as the supply. So broadly, shock can be classified into hypovolemic, like dehydration, distributive shock, such as septic or anaphylactic shock, cardiogenic shock, and obstructive shock. And early recognition and rapid intervention are critical to halt the progression from a recompensation to a decompensated state. So you suspect shock in a case of tachycardia, very quiet tachypnea because of compensation to the associated metabolic acidosis, a cold, pale, mottled, diaphoretic skin, a delayed CFT, weak peripheral pulses with a narrow pulse pressure, a history of decreased urine output, and change in level of consciousness, being irritable or lethargy or pretty drowsy. As I mentioned before, that's a very grave sign. Now, the approach to shock initial management is to position the child. Again, you start high flow oxygen because, as I mentioned, you take care of the demand by increasing the supply. Okay, then you support ventilation. You can use oxygen delivery devices such as CPAP machines or invasive mechanical ventilation if needed. You establish vascular access for investigations, fluid resuscitation, and administration of medication. This is of paramount importance. You give rapid fluid bolus of 20 ml per kg over 5 to 10 minutes in hypovolemic and distributive shock, and you reassess after each fluid bolus. So you see a hypotension, you establish vascular access, you don't step back after saying give a bolus. You need to reassess after each bolus, because depending upon the cause of shock, your bolus can either be inadequate, adequate, or might be more. Say if it's a cardiogenic shock, your 20 ml per kg might even technically worsen the patient. So when it comes to cardiogenic shock, you give a lesser amount, like 5 ml per kg, over 10 to 20 minutes or even longer. Some people give over 1 to 2 hours. The fluid that is used is isotonic crystallites. Please don't go for your ISOPs or D5 or D10s. That makes of no use. You need isotonic crystallite solution in order to expand your intravascular volume. Again, as mentioned before, you need to monitor your vitals and perform frequent assessment to determine the response to therapy. The more sicker the patient is with respect to your pediatric assessment triangle and that pentagon, the more, close observation the child needs. So if you're able to get some blood samples, please do take initial blood sample for basic lab studies and identify and correct hypoglycemia and hypocalcemia early. Give medications like vasoactive agents, the ones that you're familiar with, like dopamine or epinephrine, dextrose, and calcium. If you're suspecting septic shock, please give your first dose antibiotic, preferably as soon as possible. If you're suspecting an above diaphragm infection, give a gram-positive plus anaerobic coverage. If you're suspecting a below diaphragm source of sepsis, please do cover with a gram-negative and anaerobic coverage. So I refer to a pediatric facility with intensive care monitoring for further management. Coming to anaphylaxis, it's not very uncommon because as we are going forward and forward, we are seeing more cases of anaphylaxis, probably because of increased genetic causes. Anaphylaxis in infants typically involves the skin in 98%, the respiratory system in 59%, and the GI in 56%, and cardiovascular symptoms are rarely reported in infants. Now, cutaneous manifestations occurs in most cases of anaphylaxis. It can also develop with the absence of cutaneous manifestations. And children, the most common presentation is respiratory symptoms, and you can have other presentations, especially abdominal symptoms. Now, this is your simple dosage schedule that can be given reliably to patients of all age groups using a tuberculin syringe or your insulin syringe. You take adrenaline, the undiluted one, 1 mg per ml in this tuberculin syringe, and this is the dosage schedule that you can give in this age group reliably. You have to give it intramuscularly. Intramuscular is superior to both subcutaneous and intravenous dosage of anaphylaxis. So you need not worry if you don't have IV access. What you need is epinephrine to go intramuscularly ASAP. Okay, so these are the dosage schedules. And in the initial minutes, again, position of the child becomes very important because you need to make your airway stabilized enough so that air can flow smoothly into your respiratory system. Now, if the child is having significant respiratory distress, nausea and vomiting, they might even refuse to lie down because it might obstruct their lower airways. You have to assess, as mentioned before, the airway breathing circulation and your vitals. You start oxygen by NRM. You are giving oxygen as much as possible. Remove the allergic trigger if possible, especially if it's an insect sting, and administer the first dose of epinephrine, 0.01 mg per kg per dose. You can use the chart that I showed before in the anterolateral aspect of thigh, which can be repeated every 5 to 10 minute intervals as needed. Now, it may not respond immediately. It might take time. When do you administer the next dose? It's an interval of 5 to 10 minutes. After 5 minutes, if there is a respiratory distress, you might have to escalate your respiratory support into a high flow nasal oxygen and even plan for an intubation. The reason is, if it's not responding to adrenaline, that means your vocal cord might get more and more edematous and you might find it difficult to intubate. So you might have to prepare for intubation pretty early if there is significant respiratory distress. If there is stridor, please institute epinephrine 0.5 ml per kg, and if there is wheeze, administer salbutamol 0.15 mg per kg. If there is hypotension, please make sure you have your BPs recorded. You have to have your intravenous access as soon as possible. If not, you have to get an intraosseous access. And please administer your first bolus of normal saline by a rapid push technique. After 10 minutes, no improvement, give your second dose of IM epinephrine, establish access as mentioned before, prepare for a difficult intubation, and you can repeat your NEBs as I mentioned before, and you might have to repeat your boluses and prepare for intravenous epinephrine because you are going down a very grave pathway. After 10 to 20 minutes, you can give your third dose of epinephrine, and for distress, you can repeat your NEBs. You have to proceed for intubation. You have to be prepared that there's going to be hypotension, poor perfusion, loss of consciousness, and even cardiac arrest. You may have to start intravenous epinephrine at that point, and you have to alert your team in order to transport to your pediatric ICU or a tertiary care center. So the immediate supportive measures in case of seizures, that's the next category. So here again, as I mentioned before, positioning of the child is extremely important because you need to avoid injury and aspiration. You clear the airway, you institute monitoring of your vital signs, and you place your IV line. And here you might, it's very important that you get some investigations, especially of blood sugar and some blood sampling in case the child has features of meningitis. Now, the prime thing when it comes to management of seizure is to stop the fit. It's as simple as that. If you have a vascular access, please institute IV lorazepam, 0.1 mg per kg, max dose of 4 mg. You may have to give it over a couple of minutes and not as a sudden bolus. You have to repeat it in 5 minutes if the seizures does not stop. Now, what if you don't have IV access? It's not a big problem if the child is hemodynamically stable and the airway is okay. You can give intranasal midazolam, you can give buccal midazolam, you can give IM midazolam. You have ways and means to tackle if you don't have an IV access, and you can give perirectal diazepam as well in the dosages as I've written. It's only if the seizures persist after 10 minutes that you need to absolutely get an IV access in, because you'll have to go to the next step. That can be IV phenytoin or Levipil or whatever you have within your pharmacopoeia. You have to monitor ECG and BP in case you are instituting an infusion, because you can have hemodynamic compromise at that point, and you need to correct hypoglycemia because that is very, very frequently missed. Now, the important points when it comes to approach of to seizure management is a focused history and examination, because there can be a lot of reasons for seizures. It can be head injury, meningitis, or metabolic. A very young child can have a metabolic cause which is extremely difficult to treat. You have to rule out meningitis in a febrile child with CSF analysis and blood tests, and refer the patient ASAP if you are not able to do those. Consider simple febrile seizures in 6 months to 5 years age group, but that should be a diagnosis of exclusion. And consider neuroimaging in a child with focal seizures with a history of head injury or raised intracranial tension as manifested by a different GCS. Coming to trauma, again, the bedrock of everything of pediatric emergency management is A, B, C, D, E, and even in trauma, you extend that. You take care of the airway, you have to assess for obstruction, because it can be anywhere from the lips to the carina. I've had to manage a major trauma where, as Dr. Nikhil had mentioned before, a Foley's was inserted to take care of the posterior nasopharyngeal bleed, because we were not able to intubate the child, we were not able to visualize the cords, so we had to undertake those. You have to look for features of upper airway obstruction. You need to suction the secretion, start oxygen, and if there's a difficult airway because of fractures, you might have to involve the ICU team, the anesthesia team, and the ENT team to do an emergency tracheostomy. Take care of breathing. You have to evaluate the child's ability to ventilate and oxygenate. Sometimes there might be absence of spontaneous ventilation if there is a very severe traumatic brain injury. You can have differential breath sounds. You can have differential chest movements. Look at the chest movements of any person with a major trauma, be it child, be it adult. And if you see one side of the chest is not moving, be prepared for a needle decompression in case there's a pneumothorax. And it might require a chest tube placement. If there is respiratory failure, you have to start bag and mask ventilation and prepare for a rapid sequence intubation. Circulation, extremely important. Please check pulses in all 4 limbs, because you can have localized injury of the vascular structures which can result in loss of limbs. So you have to check pulses in all 4 limbs. You have to check for external hemorrhages, signs of shock, pelvic fractures. If there is absent circulations, please start chest compressions immediately according to your BLS training. Controlled major exsanguinating hemorrhage by external compression. You have to secure our IV access and fluid resuscitation, and you may have to wrap or bind pelvis. When it comes to disability, you look at your GCS, pupillary reactions, signs of spinal cord injury, and signs of impending herniation like abnormal pupils. And with a rapidly declining GCS or GCS less than 8, you have to intubate, moderate hypoventilation, and take care for a neurosurgical consultation. And when it comes to exposure, you need to identify hypothermia. The reason is hypothermia can worsen your coagulopathy, which might be because of severe bleeding. So you have to take care of a temperature, not make the person hypothermic, but at least ensure that the child or the person is not severely hypothermic. You can start an external rewarming with the air blanket. So the general consideration is to repeat vital signs every 5 minutes, reassess response to intervention, assess pain, and provide analgesia. And all significant injured children must be assumed to have a cervical spine injury, and you have to apply a cervical collar. It's extremely important, because if you just even turn the neck, it can lead to a quadriplegia, even which can, paralyze the child for life. And in case of suspected cervical injury, just completely immobilize the spine. So when do you refer a sick child? That's the next part. You have to first identify, according to the triangle and the pentagon, you identify a sick child. If you have resources, please institute management. If you don't have the resources, you refer the child. So you need to identify the need for referral or transport. You need to identify your resources and your limitations. Not everyone has a backup anesthetist or ENT surgeon who can intubate in case you are not comfortable intubating. Not everybody has a good nursing team who can give drugs or who are familiar with giving drugs in case of an emergency. So identify your resources and limitations and know where resources are available and affordable, because based on your patient clientele, you might have to refer patients to different places based on what the condition is. You can't refer to another hospital which may not have the resources to, take care of this pertinent patient. And you identify the urgency of transport. Now, try to do the minimum stabilization. Try to get an intravenous, if not possible, an intraosseous access. Oxygen supplementation, I think, which is possible definitely. Fluid administration should be possible. Your first dose antibiotics in case of sepsis, first dose antiepileptic therapy for seizures, and cervical collar in trauma. And coming to what not to do, some important points. Please avoid too fast, too much bolus if there is hepatomegaly and crepitations, because there might be cardiac failure. It's extremely important because it might just worsen the cardiogenic shock. Please do not do it. Please do not continue in your non-rebreathing mask for long in respiratory distress, because if you feel the lung is damaged, the next step is to give pressurized oxygen. That may need an HFNC or a CPAP or an NIV or mechanical ventilation. NRM does not do anything, it just provides pure oxygen at a slightly higher flow which does not satisfy your ventilatory needs. Do not trust normal vital numbers in a very sick child. You can have extremely sick child who had very abnormal vitals, but once they go into a decompensated phase, what happens is you find their heart rates and respiratory rates coming down. And in a very sick, cold, clammy child, say 6-month-old with a heart rate of 100, it's an extremely grave situation and it's a peri-arrest situation. Now, do not waste time for intravenous access. Go for intraosseous access after 2 or maximum 3 failed attempts. Avoid beta agonists in children less than 6 months. It's said that your amount of beta 2 receptors is pretty less in children less than 6 months, but it's not absent. There's another cause for it in that there's this huge subset of population who might have tracheobronchomalacia. And if you give beta agonists to them, that might even worsen your wheezing. So in case you need to give beta agonists, be very careful to deal with worsening wheeze. Anticholinergics like ipratropium bromide or steroids might be a better option rather than beta agonists in children less than 6 months. Be very careful while intubating a child with stridor. You might find a very difficult airway. Okay, so you need a backup person in case you're not able to intubate. And please do not try to paralyze a child. Please sedate the child, but please do not paralyze a child with stridor if you do not have a backup. Because if you paralyze, then there's no going back. You might have to wait until the paralytic agent comes off, and you may not even be able to bag. The next point is extremely important. Bagging without chest raise is the same as manual strangling. What I've seen a lot of times is you will have 3 or 4 people, medical professionals, bagging a child and looking into the monitor for saturations. Nobody looks at the child, because if you don't have chest raise, there's absolutely no use of bagging. It's like manual strangling. So when the person who is bagging has to look only at the chest raise and not the monitor. You have to allocate some other person to look at the monitor. If there is no chest raise, there's absolutely no use of bagging, and you will worsen. And you will keep on forcing more and more, and the child will keep on desaturating. You will feel anaphylactic shock if you cannot monitor the patient. So when I was in Canada, antihistamines in anaphylactic shock became an actual relative contraindication. The reason for that is, if you give antihistamines, you need to be prepared to see the associated drowsiness for that. So if the child becomes little lethargic, you will not know whether it is because of your antihistamine or it's because of your decreased cerebral perfusion due to your anaphylactic shock. So remember, for anaphylactic shock, it is IM, epinephrine and fluids. That's the only thing that needs to go into. If you've given steroids, if you've given antihistamines, it's of no use. The only proven physiological antidote is IM, epinephrine and lots of fluids. Do not delay the first dose of antibiotics in case of septic shock. Do not correlate intensity of trauma to the level of head injury, because a minor trauma can lead to catastrophic intracranial bleeds and you might totally miss it. Do not pump in a lot of fluids in trauma-induced hemorrhagic shock. What happens is you're just diluting the blood, you're bringing the hemoglobin level down, and you're bringing the oxygen carrying capacity in your blood worse and worse. So what you need in case you're losing blood is replacement with blood products. Do not hesitate to call for help, because it's not possible to manage and multitask while dealing with a sick child. You need to take care of a lot of things. So the take-home points, how to identify a sick child, establish oxygen supply mechanism, and provide hemodynamic support to ensure that oxygen gets delivered in respiratory distress and in shock, because in shock your oxygen, demand is very, very high. And if you don't supply enough, your demand goes sky up and there'll be a mismatch leading to worsening of shock. Go for an intravenous needle if not able to secure intravenous access. Adrenaline is the only useful drug in anaphylaxis. Getting the seizure aborted is one of the prime foci in anti-seizure management. Secure airway, neck, and blood products for a major trauma. Sometimes less is more. Don't overdo things always. And remember, patients don't follow textbooks or protocols. Use common sense. Thank you.
Excellent presentation, Dr. Prashant. Actually, you took us through a virtual tour. The clear-cut guidelines in emergency management of children with illness. Thank you very much. I don't think we have time for questions.
We are running short of time, yes.
Okay, thank you.
Thank you very much, sir.
Thank you.
With that, we come to the end of this session. I request Dr. Suresh Kumar E.K. to hand over the memento to Dr. Prashant. Thank you. I call upon Dr. Chandrakant to hand over the mementos to the chairpersons, Dr. Suma R and Dr. Suresh Kumar E.K. Thank you, sir. The results of the poster competition is out. I request Dr. Neeraj to announce the results.
First of all, I thank CGP and Dr. Chandri Madam for giving us a chance to judge this. All the cases are wonderfully worked up and nicely presented. Unfortunately, when it comes to prizes, we have 2 prizes in the postgraduate category and 1 prize in the undergraduate. And the first prize goes to Dr. Remya, who did it from Cooperative Hospital. A wonderful case of basophilic stippling from an alternative drug intake. And the second goes to Gautam Krishna, postgraduate student, Government Medical College, Kozhikode, on presenting a tenofovir-associated hypophosphatemia. And in the undergrads category, we have a single prize, and that is for Dr. Aisha. I think, yeah, please give her a big hand. The prizes will be distributed in the evening session. Thank you.
Thank you, Dr. Neeraj. I call upon Dr. Chandini Madam to hand over a small memento to Dr. Neeraj. Thank you. We'll move to the third session, the pre-lunch session, Management of COPD, Dr. K.P. Suraj. The chairpersons for this session is Dr. Ravindran C. and Dr. Laila B. Dr. Ravindran C. was the former principal of Medical College, Kozhikode, head of Department of Pulmonology, now a senior consultant in the Pulmonology Department, Baby Memorial Hospital, Kozhikode. And Dr. Laila B. is a professor of community medicine.
Welcome to this session on COPD management. First of all, I am very happy to be part of this wonderful CME. Thank you organizers for inviting me. This topic is management of COPD. We all know that COPD is a chronic airway disease, and we all see it in general practice. Once a diagnosis of COPD is made, probably we take it lightly, knowing that it is not curable. But if you treat properly, we can control the disease, control the symptoms, and prevent exacerbations, which will improve the patient's quality of life. That is most important in managing COPD. And more than that, preventing COPD is more important than managing COPD. Now we have few entities called pre-COPD, preserved lung function COPD, all those things where you can pick up COPD at an early stage, where you don't have a fixed airway obstruction. So that should be our motto when we see patients with symptoms who do not have full-fledged COPD. So to talk on the management of COPD, we have none other than Dr. K.P. Suraj, Professor of Pulmonology. Dr. Suraj was my student, then for a long time colleague in the Department of Pulmonary Medicine in ICD Calicut. Now he is the Professor of Pulmonary Medicine in Government Medical College, Mancheri. He is a sincere and reliable pulmonologist. I should qualify like that. Suraj, please.
Thank you, sir. I thank the organizers for giving me this opportunity. COPD is a public health problem due to many reasons. It's the third leading cause of death globally, and in India, the chronic lung disease is the second leading cause of death. Its prevalence is increasing world over due to many reasons, because of the high prevalence of smoking, then atmospheric pollution, and increasing lifespan of the population. The sad thing is that the diagnosis of COPD is delayed. The diagnosis of early COPD is only around 25%, and that of moderate COPD is only about 50 to 60%, even in developed countries. For confirming the diagnosis of COPD, a good quality spirometry is required. This, according to the etiology, COPD can be named as COPD G, that is due to genetic cause, or D due to developmental cause, then C, that is smoking, then pollution, P, I, infection, like that. And asthma, if there is associated asthma, it's called COPD A. This graph shows the rate of fall of FEV1 in normal population and in patients prone to develop COPD. You can see that there is a rapid fall of FEV1, that is at the rate of 50 to 60 ml per year. But in normal people, it's only around 25 ml. The importance of small lung is that in the patients, even a small increase in rate of fall will cause development of COPD. This graph shows the importance of cessation of smoking even after development of COPD. You can see that the rate of fall becomes much less, and it also almost becomes that of normal persons. For the confirmation of diagnosis, spirometry is required. The left curve is normal. From the appearance itself, you can diagnose COPD. On the left curve, you can see that after about 2 seconds, there is a straight line. That means there is no more flow is there. On the right curve, even after 6 seconds, there is an upslope. That means flow is continuing. A post-bronchodilator FEV1 by FVC of less than 0.7 is diagnostic of COPD. Spirometry can also be used to classify COPD or severity of COPD. That is gold class 1 to 4. Gold class 1 is mild. Mild means FEV1 is more than 80%. Then moderate, FEV1 is between 50 and 80. Severe means it is between 30 and 50. And very severe means less than 30. After confirming the diagnosis of COPD, we should assess to which gold class it include, and assess by symptoms and number of exacerbations. If there are more than 2 moderate exacerbation or 1 severe exacerbation requiring hospitalization, then it's classified as E group, that is exacerbation group. Previously there were 4 groups, A, B, C, D, E. C and D are merged together as E. A means it's a mild disease. That is, the symptoms are either MMRC 0 to 1 or CAT score less than 10. If symptoms are more than that, then it's category B. So CT has no role, in fact, in COPD, except in a few conditions. Like if you want to rule out underlying bronchiectasis, if there is frequent exacerbations, then you should rule out associated bronchiectasis. And if the symptoms are disproportionate, then you have to rule out any other cause for dyspnea. And if you are planning any interventions or planning to refer for any interventions like bullectomy or LVRS, then CT is indicated. So also, if you are suspecting underlying malignancy, especially in emphysema, they are prone for development of malignancy. As in case of any other disease, the indications are, the aim of our treatment is to reduce symptoms and to reduce risk. Reduce risk means to reduce further progression of the disease and to prevent and treat exacerbations. With each exacerbation, the lung function falls significantly, and even after you treat the exacerbation properly, the patient will not regain the baseline lung function, FEV1. FEV1 will go a little bit lower. And reduce mortality. The main thing is to reduce the risk exposure and by preventing exacerbation. So the initial management depends upon the GOLD classification, and either the patient belongs to A, B or E. Initial management steps include smoking cessation, vaccination, then active lifestyle. You should always encourage the patient to do exercise. Then initial pharmacological treatment, and educate the patient and manage comorbidities. And during review, you should review the patient's symptoms and assess the inhaler technique during each visit, and the adherence to the treatment protocol, and you should modify the treatment accordingly. Coming to individual steps, the smoking cessation or avoidance of the risk factor is probably the most important step in the management of COPD. If you avoid smoking, I have already seen the slide. If you stop smoking, that will have a very good impact on the natural cause of the disease. In case of ladies in India, the major cause of COPD is biomass fumes. So ask them to use a clean fuel like LPG or CNG. Vaccinating the patients is very helpful to prevent exacerbation. CDC, WHO and GOLD recommend annual influenza vaccination. Regarding pneumococcal vaccine, the ideal vaccine is 20-valent conjugate vaccine. If that is not available, a 15-valent conjugate vaccine followed by 23-valent polysaccharide vaccine is recommended. In India, both 20-valent and 15-valent conjugate vaccine is not available. What's available in India is 13-valent conjugate vaccine. You may give it, followed by 23-valent polysaccharide vaccine. There should be a minimum gap of 8 weeks, or an ideal gap is 1 year. Or at least you should give a 23-valent polysaccharide vaccine that can prevent pneumonia and exacerbation. Then CDC also recommends Tdap vaccine in those who has not taken the adolescent pertussis vaccine, and also recommend varicella vaccine. The mainstay of treatment of COPD is bronchodilators. Inhaled bronchodilators are preferred over oral agents. The preferred agents are long-acting drugs like long-acting beta-2 agonists and long-acting muscarinic antagonists. LABAs, there are two types. The first one is having a duration of action of 12 hours. The drugs are formoterol and salmeterol. Between the two, formoterol is preferred because it has got a quick onset of action. Then LABAs with 24 hours of duration of action are called ultra-LABAs. 3 drugs are available in India: Intecatrol, Vilanterol, and Vilanterol. Only 2 is available in India. Vilanterol is not available in India. Between the two, Vilanterol has a quick onset of action, but it is more expensive. Between LAMAs, the 3 drugs are available in India: tiotropium, glycopyrronium, and umaclidinium. Umaclidinium is highly expensive. Between the tiotropium and glycopyrrolate has a quick onset of action. And regarding side effects, the side effects are a little bit less for glycopyrrolate. The main side effects are drying of mouth and urinary retention. Between LABAs and LAMAs, the LAMAs are preferred because it has got a good bronchodilator action, improves quality of life, prevents exacerbation, and it is found that it even reduces the mortality. Theophylline is not a preferred drug and it's not recommended because it has got only a weak bronchodilator action and the therapeutic index is very narrow. Coming to anti-inflammatory agents, steroid is not a preferred drug in COPD, unlike in asthma. In asthma, the mainstay of treatment is steroid. In fact, steroids have got a lot of side effects. It can cause recurrent pneumonia. Then if you give a long-term oral steroid, patients can develop a pneumothorax. So steroid is not a preferred drug. And a combination of ICS plus LABA, that is the common trade names are Foracort, Budamate, Seroflow. Such combination is not recommended for use in COPD. If there is any indication for steroid, then a triple drug combination is preferred. That is LABA, LAMA plus ICS. Then other anti-inflammatory agents that are recommended are, one is roflumilast. That is, in case of patients, if the eosinophil level is less than 100, then either roflumilast or azithromycin is preferred. Azithromycin in a dose of either 250 milligram daily or 500 milligram thrice a week for 1 year is recommended. There are only a few indications for steroid. The strong indications are if there is a life-threatening exacerbation, or if there are 2 or more moderate exacerbations, or if the blood eosinophil count is more than 300, and if there is associated asthma. If there is associated asthma, then you should include steroid in the treatment regime. Then other favorable indications are if there is 1 moderate exacerbation and if the eosinophil count is between 100 and 300. It's totally contraindicated if there is history of recurrent pneumonia, then blood eosinophil count is less than 100 and history of mycobacterial infection. Then pulmonary rehabilitation. It has got a very favorable impact on the course of the COPD patients because it improves quality of life, reduces anxiety and depression. Most of the COPD patients are depressed because they cannot move out. And it's also found to reduce mortality also. Then education alone is not of much use, but if you educate the patient how to manage exacerbation, initial management of exacerbation with communicating with the healthcare worker, then it's very effective. Regarding oxygen therapy, long-term oxygen therapy is found to be very effective in patients with chronic severe hypoxemia. The indications for starting oxygen are a PaO2 of less than 55 millimeters of mercury or a saturation less than 88% in the resting condition. not immediately after an exacerbation. If the patient was hypoxic during exacerbation, you're not supposed to initiate oxygen, long-term oxygen. After discharge, after 3 to 4 weeks, you should reassess, at least during 2 times, if the saturation is less than 88% or PaO2 is less than 55%. Then that's an indication for long-term oxygen therapy. And the target oxygen saturation is 90 to 92%. Between 55 and 59, PaO2 between 55 and 59, and a saturation less than 90. The indications for starting LTOT are, one, if the patient there is copulmonary or pulmonary hypertension or polycythemia. If there is associated these 3 conditions, then you may start patient on LTOT. Then long-term NIV support, domiciliary NIV support is found to be very effective in patients with chronic daytime hypercapnia of more than 53 millimeters of mercury. Antitussives and vasodilators have no role in the management of COPD. Coming to treatments that have a favorable impact on the prognosis of COPD include pharmacotherapy with a triple drug combination, that's LABA, LAMA and ICS, then smoking cessation, pulmonary rehabilitation, then long-term oxygen therapy in patients with chronic hypoxia, then NIV support in patients having persistent daytime hypercapnia, and lung volume reduction surgery in patients with upper lobe emphysema. So, suppose a patient come to you with COPD. If the patient is having only minimal symptoms, that means if the patient is belongs to category A, then it's better to initiate with a single agent, either LABA or LAMA. As I already told, LAMA is preferred. If the patient is not willing for LAMA, then you may start the patient on a combination of SABA and SAMA. If patient is not willing for that also, then you may give a single agent, either SABA or SAMA. In the category 2, if the patient is more symptomatic, but there are not much exacerbations, then a combination is preferred. A combination of LABA plus LAMA is preferred. And in patients with a frequent exacerbation, or if there is a history of previous admission due to COPD exacerbation, you can initiate treatment with the LABA plus LAMA and check the blood eosinophil count. If the blood eosinophil count is more than 300, you should add ICS. If it is less than that, you can wait. During the follow-up visit, if the patient is doing well with your initial management, continue with that. If the patient is not doing well, then you should assess the adherence to treatment inhaler technique. The most important thing is inhaler technique. Most of the times, patients will not take these drugs properly. That is the main reason for treatment failure. If the I'll continue. If the എല്ലാം പോയല്ലോ കമ്പ്യൂട്ടറിലുണ്ട്. If the patient is on, after reassessing, if the patient is on a single agent, either LABA or LAMA, you can step up to LABA plus LAMA. Even after that, if the patient is persistently symptomatic, then you may switch over the device. Sometimes patient may not be taking properly with a DPI, then you may switch over to MDI with a spacer or vice versa. and look for any other cause for increased dyspnea. And you may add other non-pharmacological methods like rehabilitating the patient and such things. And if exacerbation is the main concern, then you should, if the patient is on either drug, you may switch over to LABA plus LAMA if the blood eosinophil count is less than 300. If it is more than 300, you should switch over to triple drug, that is LABA, LAMA plus ICS. If even if after switching over to LABA plus LAMA, if the patient is having recurrent exacerbations, you again check the blood eosinophil count, and if it is between 100 and 300, you may add ICS. If it is less than 100, then the option is either roflumilast or azithromycin, as I have already told. Azithromycin is given only in cases of former smokers. For current smokers, it's not recommended. So a COPD exacerbation means there will be increased dyspnea, cough, and sputum production that occurs within last 14 days. And patient will be tachypneic, and there will be tachycardia. And usually it occurs due to either infection or pollution or some other insult to the airway. So you should rule out other causes for increased dyspnea like cardiac failure, pneumonia, or pulmonary thromboembolism. You may classify the exacerbation into mild, moderate, and severe. In case of mild, only nebulization with either salbutamol or ipratropium or a combination of both is sufficient. In case of moderate exacerbation, usually repeated nebulization plus oral corticosteroid plus or minus antibiotics. Antibiotics is recommended only if there is definite evidence of infection. Steroid has got a very good role during the exacerbation. The recommended dose is only 40 milligram daily, 40 milligram of prednisolone daily for 5 days. Steroids giving a higher dose of steroid and a longer duration of steroid will do more harm than good. The key points in the management of exacerbation are repeated nebulization with SABA and SAMA. The agents are salbutamol and ipratropium. And if the patient is already on LABA, LAMA, and ICS, you may continue that. Then add steroid, as I have already discussed. Then antibiotic is indicated if there is increased dyspnea, sputum production, and purulence, out of which purulence should be there. The only indication for starting antibiotics, if there is no purulence, is if the patient is ventilated. In such cases, there is no time to wait. Non-invasive ventilation is very effective in the management of exacerbation, especially if there is, I'll come to that, another slide. Indications for hospitalization means if the patient is not responding to initial treatment, and if there is a confusion, then if there is features of respiratory failure, and if there is other potential comorbidities like heart failure or arrhythmias. Whenever a patient with a severe exacerbations come to you, you should get a chest X-ray to rule out other causes, and like pneumothorax or pneumonia. Then ABG is very important, and if there is acidosis, that means pH less than 7.35 and a PaCO2 more than 45, then an NIV is indicated. Then nebulize the patient and give oral steroids, antibiotics if indicated. Always monitor the fluid status. Then always give DVT prophylaxis, because COPD patients are prone to develop DVT and pulmonary embolism. You give either unfractionated heparin BD or low molecular heparin OD. intensive care unit, if the patient is not responding to initial treatment, then if hemodynamically unstable, or if there is an indication for invasive ventilation, or if there is severe acidosis, if the pH is less than 7.25 and PaO2 is less than 40. For NIV, as I already told, if the pH is less than 7.35 and PaCO2 is more than 45, then NIV is indicated. You can try NIV even if the pH is 7.1 and if the PaCO2 is 100. There is no harm in giving a trial, but you should give the trial in an ICU. You should be ready to intubate the patient at any moment of time. Then another indication is if the patient is having very severe dyspnea and there is features of respiratory muscle fatigue, like paradoxical abdominal movement, if the axillary muscles are acting, if there is intercostal indrawing. And another indication is persistent hypoxemia even with the oxygen therapy. Apart the poor prognostic indicators, apart from severe disease, there are some independent bad prognostic indicators like anemia, a BMI of less than 21, poor nutrition, resting tachycardia, frequent exacerbation. These are all bad prognostic indicators. To conclude, the prevalence of COPD is increasing and it causes a significant morbidity and mortality. If there is a respiratory cripple in your home, that means even you cannot work. Such patients always require a support. So always try to prevent that. Then avoid risk factors, that is very important. Vaccination can prevent exacerbations. Maintenance of good nutrition and rehabilitating the patient will improve the quality of the life. Bronchodilators are the mainstay of treatment, and steroids, always try to avoid steroid if there is no definite indication. As I already told, exacerbation causes a fall in lung function. So try to prevent exacerbations and treat exacerbation properly. Thank you.
Thank you, Dr. Suraj, for the excellent presentation. Dr. Suraj has covered the management of COPD as such, both for the general practitioners as well as for the institutions. And his presentation is mainly based on Gold COPD Guideline 2023 update. That is the latest update on COPD management. Probably you may be wondering whether we can classify these diseases into A, B, E in the general practice or into different severity classification. It is not that important. You just look at the symptom of the patient, clinical disability of the patient, and treat the patient with the bronchodilator. That's a mainstay bronchodilator. It should be either LABA or LAMA or a combination in a little bit severe cases. And there are certain limited indications for using steroids. That is, now doctors may be aware of the popularity of triple drugs, which is being marketed widely in Kerala, and everybody is writing the triple drug combination. And triple drug combination contains steroid. Steroid has got only limited indication. Whenever the patient had exacerbation, hospitalization, or peripheral eosinophilia, or if you suspect COPD, asthma combination, only we need to give steroid. Otherwise, bronchodilator is the drug of choice, which will give good symptom control and prevent progression of the disease, and patients' physical activity will be maintained. That's a main point which he has highlighted. He has done it very well. Probably the message is passed on to the audience very well, I think. Dr. Laila.
Thank you, Dr. Suraj, for excellent presentation. I'm not a topic expert. Sir has mentioned everything. Okay. Anyway, very good presentation. Thank you.
Thank you, Dr. Suraj. I call upon Senior General Practitioner Dr. Diwan over to the dais to hand over the memento to Dr. K.P. Suraj. Thank you, sir. We'll move to the next session. Office practice in dermatological conditions. Speaking on this topic is Dr. Febin Tanveer, Senior Consultant Dermatologist and Quality Head, Star Care Hospital, Kozhikode.
Good afternoon.
I request IMA Kozhikode Secretary Madam to hand over the memento. I call upon Dr. Tulasidharan, sir, to hand over the memento to Dr. Ravindran C.
Good afternoon. At the outset, let me congratulate Team CGP and IMA Kozhikode organizing wonderful conference. And many topics are very essential for CGP. And also my thanks for inviting me as a surprise the chairperson of this session, because the expert Dr. Prasanna Kumar has some inconvenience, so the chairperson and secretary asked me to chair the session. I am not the subject expert. I am in community medicine. Okay. Then the daily we have 10 to 20% cases in general practice. It is of dermatology specialty. So in this regard, my professor Sugadan sir used to say itching. The common symptoms of the dermatological manifestation is the pleasant sensation. So all the people might have experience. So for today's topic on office procedures in dermatology by Dr. Febin Tanveer. She is the Senior Consultant Dermatologist and Quality Head Star Care Hospital, Kozhikode. Her topic of interest are eczema, urticaria, dermatosurgery, quality in healthcare. She have many academic achievements, and she has 4 publications, media cell member, and she was the organizing secretary for Cgpcon 2022 and scientific secretary for Cgpcon Kerala 2018. So over to Dr. Febin Tanveer.
Thank you, ma'am, for your kind introduction. Good afternoon, everyone. I know all of you are awaiting the lunch break. So we'll just have a quick look at the office procedures that we do on a day-to-day basis in our dermatology practice. Dermatology as a specialty has seen huge changes over the past few decades. Originally started as ma'am said, to diagnose over the past few decades. Originally started as ma'am said, to diagnose itchy conditions. Now it has expanded to encompass various aesthetic procedures and dermatosurgical indications. 2 specialties in special, the aesthetic dermatology with the advent of lasers and various minimally invasive procedures has expanded like anything, and more of a focus has come on dermatosurgery with increased attention and training over the past few years. So let's have a look at the common dermatosurgical procedures that we do. Skin biopsy is one of the most common procedures that we do to diagnose as well as treat certain skin conditions. It can be done by shave biopsy, where the lesion is cut at the level of the skin surface when it is confined to the epidermis or just rising above the epidermis, like for example a seborrheic keratosis. But the punch biopsy is the one that we do most commonly, where a disposable punch, a pen-like device, is pressed onto the lesion and twisted so that you can take out a cylindrical piece of tissue and this can be sent for the histopathological examination. It's a very simple technique to do and heals well with very minimal scarring and may not even need a suture at times. But when the lesion has to be removed incomplete, we go for an excisional biopsy. The radiofrequency machine is one of the most commonly used machine in our practice, and it uses radio waves at 3.8 megahertz, and the passage of these radio waves through the tissues creates resistance, thereby generating heat, and that can cause a cutting or the coagulation of the tissue. The advantage over the electrosurgical procedure machine would be a better precision and minimal collateral damage so that there is no scarring after the procedure is done, which the patients are mostly concerned about. Skin tags and DPN are one of the most common benign growths that you can see over the face, neck and axilla, and these can very easily be lifted up and cut through by the radiosurgery machine. Even broad skin tags with a broad base can be easily removed with adequate hemostasis. Freckles or ephyllites are light brown macules that you see on the skin surface on the photoexposed area which get aggravated when there is sun exposure. They can be removed by either by light radiosurgery or by lasers. And flat seborrheic keratosis lesions as shown in the figure can also be removed using the radiosurgery machine. Warts or the verruca vulgaris is another common problem which can be tackled using radiofrequency device. Coming to the excisions that we do, epidermoid cysts constitute 80% of the cutaneous cysts. They can be either removed intact in toto or an incisional excision can be done and the contents expressed out and along with the cyst wall. If you leave the cyst wall behind, there is a risk of recurrence. Pilar cyst or tricholemal cyst, they are benign hair growths coming out of the hair follicles. They are mobile, firm, and well circumscribed nodules and are located mostly on the scalp. Steatocystoma multiplex. These are asymptomatic yellowish tinged nodules which can occur anywhere on the body, but scrotum is a common site. And we can get a cheesy material that is expressed when the cyst is incised. Usually, we just need to put in a nick on the cyst and the content and the cyst wall is expressed. You can do the nicking either using the surgical blade or the radiosurgery probe. But in this patient, he had a long-standing history and the cyst had calcified and so the overlying skin including had to be removed. Lipomas can be excised by the conventional method, incision, or by the minimal incision extrusion technique where a small punch is used to make a nick and through that nick the whole of the lipoma is excised, removed. The advantage is that you can see that one of the lipomas on this patient's forearm was removed by the conventional method and that gave a bigger scar, while the other one is removed using a punch and the whole lipoma was excised and that gives a negligible scar which again the patient is bothered about. Acquired melanocytic nevus or the common mole, these can be removed either using a radiosurgery or a punch excision, the disposable punch, or an elliptical excision and suturing. This one was removed using radiosurgery, this one by punch excision and suturing, and again another case of punch excision. This is a labial melanotic macule. This is a benign discoloration of the oral mucosa, and you can just leave it alone. You can, if the patient wants that it doesn't need to be treated, you can just leave it alone after counseling of the benign nature. But if the patient wants to get it removed, it can either be surgically removed or even using pigmentary lasers. So this was our before and after pictures, bringing the beautiful smile back on the patient's face. Xanthalasma palpebrarum can be an indicator of familial hypercholesterolemia, but it can also occur in individuals with normal cholesterol levels. It can be treated by chemical cautery like TCA or radiosurgery and again surgical excision. The pinching technique can be used for the ease of excision. The lesion has been excised and sutured here. The eyelid being a lax skin heals well without scarring, but recurrence is a common possibility in the case of xanthalasma. The neurofibromas which occur either as a solitary lesion or as part of the neurofibroma syndromes can be excised to improve the cosmesis. Dermatofibromas, these are cutaneous benign fibrous histiocytomas. This is one of the differential diagnoses for tender nodules. And we have to do a deep excision of the dermatofibromas, otherwise there is a high chance of recurrence. Plantar corns are a common complaint for many people, and after a common keratolytics like corn cap or something, if it doesn't work, Then punch excision is an easy technique to relieve the patient of the symptoms along with pressure relieving strategies. The disposable punch takes out the corn tissue as a cylindrical material, cylindrical tissue, and that can be removed. And there is no need for suturing, it heals well. Wide scars are revised using various techniques to give a better cosmesis. And this is platelet-rich fibrin used in the treatment, actually used for several indications. A common use is for non-healing ulcers. It is a derivative of the platelet-rich plasma, where autologous platelets and leukocytes are present in a complex fibrin matrix. And this helps to accelerate the healing. The patient's own blood is taken, centrifuged, and the platelet-rich fibrin is obtained. It's kind of like a gel-like material, which is applied onto the non-healing ulcer after cleaning it. And then the dressing is applied and kept for 1 week, and the patient sent home. This was a case, this is after 2 sittings of platelet-rich fibrin. This is a non-healing diabetic ulcer. Nail complaints are common. Ingrowing toenail is a very common complaint that can be distressing to the patient. And this occurs due to the piercing of the lateral nail fold by the nail plate. If conservative measures fail, then a partial nail plate avulsion with chemical matricectomy with phenol is a standard treatment. Glomus tumor is a very rare tumor, but classically presents with exquisite pain and tenderness. This was a 35-year-old lady with severe pain over the thumb of her right hand, and an MRI showed a subungual lesion which extended into the medullary cavity of the distal phalanx. The extension into the bone is unusual for a glomus tumor. An excision was done under distal digital block using the transungual approach, and thorough curettage of the intraosseous portion was done. The histopathology showed uniform small polygonal cells, confirming the diagnosis of glomus tumor. Hair transplant is one of the in vogue procedure that we do in our practice. Dermatologists usually do the FUE technique, that is the follicular unit extraction technique. The donor area is the back of the scalp, which is considered a safe zone. Even all the bald people here know that the hair at the back doesn't fall off even at the older age group, so that forms the safe zone. And around 2,000 hair follicle units were taken from this individual, but the scarring is very minimal, and this is transplanted onto the anterior aspect, which grows like normal hair later on. Vitiligo surgeries. Vitiligo surgery is a useful modality of treatment in stable vitiligo lesions. The vitiligo lesions are called stable when there are no new lesions for the past 1 year, there is no extension of the lesions, and there is no Koebner phenomenon. That is, no new lesions appear whenever there is an area of trauma. The principle behind it is to introduce melanocytes into the lesional skin from a donor area. These melanocytes will establish and function as epidermal melanin units. A split thickness graft is harvested under topical anesthesia, and this is placed in a trypsin solution and incubated to induce cell separation. The action of the trypsin is neutralized with a chemical, and the epidermis is separated from the dermis by teasing. The dermis on the right side is discarded, and you can see the melanocyte sheet and the epidermal sheet on the left side without the melanocytes. The melanocyte cells are suspended in a growth medium called DMEM, and this is then centrifuged to obtain a cell suspension. The vitiliginous area, the recipient area, is dermabraided, that is the top layer of the skin is removed, and the cell suspension is applied onto the dermabraided area, and dressing is kept for 7 days and then removed. The area should be immobilized, and the patient has to be called back after 1 week to remove the dressing. Another method to harvest the melanocyte is the suction blister grafting. In this, the epidermis is separated from the dermis by prolonged suction at a negative pressure to the donor site, which is usually the thigh, and a blister is created. The roof of the blister is harvested, and this is then transplanted onto the dermabraided recipient site. So you can see the blister transplanted onto the vitiliginous site. Another technique for again harvesting getting the melanocytes is the punch grafting, where small punches, small disposable punches are of about 1.5 to 2 millimeter diameter punches are used to get donor tissue from obscure areas like the thigh or the retroauricular area, and similar holes are created in the recipient area, and these punches are put into the recipient area. This is done when there are very minimal lesions or, after a non-cultured epidermal cell suspension procedure, a few areas are left missing, then that can be corrected using the punch grafting. These are few pictures of procedures done. This was done using non-cultured epidermal cell suspension. Again, another case. This one by suction blister grafting. So coming to the procedures for aesthetics and rejuvenation, laser hair reduction is one of the most commonly sought indications in consultations for lasers. Several wavelengths are utilized for LHR. The most common ones are diodes, long pulse Nd:YAG, alexandrite or intense pulse light. The common aesthetic indications for LHR is hirsutism and hypertrichosis. But basically the hair anywhere can be removed using the laser machines as desired by the patient. For example, the side locks, the patient here didn't want to have significant side locks, and that was removed by LHR. Non-aesthetic indications include pseudofolliculitis barbae, pilonidal sinus, hidradenitis suppurativa. In all these, the hair forms a role in the pathogenesis, and where there is post-skin grafting, hair removal is needed. Will all the hair go in a single sitting? That is a common question that the patients ask us. The laser targets only the growing hair, so a minimum of 5 to 6 sittings, which are spaced 4 to 6 weeks apart, are needed for facial hair. And the ideal candidate is the one who has got a dark hair on a comparatively fairer skin. The hair removal means there is a complete destruction of the growing cells of the hair follicle, which is neither possible nor desirable, because the hair plays an important role in skin wound healing, and it's also the melanocyte reservoir in that area. So we don't want to destroy the hair as such. What we aim for is a long-term hair reduction. Now coming to the lasers for the scars and rejuvenation, the pathophysiology of scars is due to an imbalance of matrix degradation and collagen biosynthesis. The abnormal collagen deposition can be reduced or remodeled using different lasers. We have ablative lasers, which actually vaporize the tissue as it passes through them, or non-ablative lasers, where the tissue deeper down is actually heated up to cause collagen remodeling. This can again be divided into fractional or non-fractional. You can see that the fractional ablative resurfacing, there are small channels created where in only those areas the vaporization occurs, the surrounding tissue is not affected. So that gives a better healing. Again, we also have non-ablative fractional lasers, so the armamentarium is huge. These are the pre and post-treatment photographs of a young girl with acne scars who underwent 2 sessions of fractional carbon dioxide laser. The downtime for the scar lasers depends on the type of the laser used and the depth of penetration of the lasers. Now coming to the lasers for pigmentary disorders, the laser light transfers the energy to a target chromophore, and that absorbs that energy. A huge amount of energy is absorbed in a very small amount of time. This leads to photomechanical disruption of the target chromophore, which can be a tattoo ink or melanin. For example, in freckles and lentigens, the target chromophore is the melanin, and in tattoos, it is the tattoo ink. Moving on to the procedures for rejuvenation of the skin, chemical peeling is a very simple in-office procedure that has gained popularity over the past few decades because it's very simple and the downtime is minimal. The rationale of skin peeling is to produce controlled, graded skin destruction and eventual reepithelialization, which will improve the skin texture. And the peels are classified according to the depth that they go to. The superficial peels will exfoliate the epidermal layers without going beyond the basal layer of the epidermis. Medium peels will penetrate into the upper reticular dermis, and deep peels penetrate into the lower reticular dermis. We don't do deep peels in Indian skin because of the risk of post-inflammatory hyperpigmentation. A variety of agents are available as chemical peels. They are used either individually or sequentially or are available as combination depending on the different indications. Apart from rejuvenation, chemical peels are also utilized for conditions like acne, post-inflammatory hyperpigmentation, melasma, and photo damage. This was a young girl with acne lesions treated with medications as well as chemical peels. Microneedling. This is a very safe and economic treatment in the armamentarium of an aesthetician's practice. It can be performed manually with a derma roller, which either has a drum-shaped cylinder with fine microneedles attached, or a pen-like device which is automated with the microneedles which move back and forth. The principle is a percutaneous collagen induction following a mechanical trauma. It can also be used for the as a transdermal delivery system. You might have heard of the vampire facial, which is basically where microneedling is done along with platelet-rich plasma application on the face. Minute channels are created which lead to collagen remodeling and thereby the rejuvenation of the skin. Because these kind of trends are common in the social media, it gets fancy names like Hollywood peel, vampire facials and so on. Hollywood peel is nothing but a carbon peel where a topical carbon suspension is applied followed by the Q-switched Nd:YAG laser treatment, which is a pigmentary laser. The dermal fillers today are the first choice of treatment for aging face which has suffered volume loss. Among the various fillers, hyaluronic acid filler are the most commonly used. They can be used for contouring the face, improving the drooping nasolabial fold and the tear trough. Botulinum toxin, the common brand name heard is Botox. It is used to soften negatively perceived lines of facial expression. The mechanism of action is inhibiting the release of acetylcholine at the neuromuscular junction and thereby causing muscular paralysis. This lady was unhappy with her vertical frown lines and the bunny lines. These are the vertical frown lines and the bunny lines over the top of the nose. The procerus and the corrugator superciliae were treated with botulinum toxin, and we can see in the post-treatment picture that even though she is frowning, the frown lines are not seen. She's actually frowning in the post-treatment, trying to frown actually in the post-treatment picture. And similarly, the bunny lines have been smoothened with the treatment of the nasalis. She just wanted a softening of the crow's feet. She didn't want to actually fully smoothen it out, and a small dose was toxin was injected into the orbicularis oculi muscle. Till now, we have seen the techniques which improve the skin texture and show subtle changes in the facial appearance. Non-surgical thread lifting can help in the reversing or reducing the drooping of the skin that comes with age. Non-absorbable sutures are placed into the subcutaneous tissue, which pulls up the skin. We have either mono threads or cork threads. The mono threads actually don't lift much. They kind of smoothen out the fine wrinkles and give the increased cheek volume. While cork threads or the barbed threads, they have hooks or corks which open unidirectionally so that they give a pulling to the tissue once they are placed in the subcutaneous area. This is an example of a mono thread. Multiple needles are introduced into wherever the patient feels rejuvenation is needed, can be done in the cheek, in the neck area. They are placed in a crisscross pattern. The needle is introduced, twisted, and the needle is withdrawn so that the thread remains inside. So as a young gentleman who was very concerned about the drooping of the nasolabial fold, and cork threads were used to soften those nasolabial folds. So this was a brief overview of various procedures that we do. Actually, I haven't covered all of them, but this is just a glimpse into a dermatologist's life. Thank you for your patient listening, and I thank the organizers of Cgpcon, Venu sir and Ranjit sir especially, for giving me this opportunity. Thank you.
Thank you, Dr. Febin. Congratulations. Your very excellent, informative, and simple presentation. You have discussed various surgical procedure, dermatosurgery, and it is useful for the clinician also for personal use. Once again, thank you. Thank you so much.
Thank you, madam. I call upon Dr. Venugopal, Senior Consultant Pediatrician, to give the memento to Dr. Febin. Thank you, sir. I call upon Dr. Sushma Anil, Senior Consultant Pediatrician, to hand over the memento to the chairperson, Dr. Laila B. Thank you, madam. Ladies and gentlemen, we break for lunch. It's 2:10 now. We reassemble back by 2:30 p.m. Have a sumptuous lunch.
Well done to all of us. Ashraf, please. Good afternoon to all. So, at the outset, I thank the organizers for inviting me for this talk. So, my talk will be on a practical approach to headache disorders. Headache, as you know, is the very common symptom with patients come to us. It is one of the most common cause of medical consultation. Majority of headache disorders are benign, that is primary headache disorders like migraine or tension headache or other primary headache disorders. But chronic primary headache disorders can be disabling and it can affect our quality of life. And as with respect to migraine, it results in loss of work productivity, and in US studies it has shown that 8% of healthcare visits are for headache. And most of these disorders are underdiagnosed and undertreated. And one of the major tasks when a patient with headache comes to us is to rule out a secondary, that is a serious cause for headache. So I will be mainly focusing on screening for secondary headache. So headache can be broadly classified into three groups. One is primary headache, which is 90% of the patients will be having primary headache. And nearly less than 10% will be secondary headache, which can be due to various causes. And very small percentage neuropathies and facial pain like trigeminal neuralgia. I will be mainly discussing the first two, that is primary and secondary headache. And one important point we have to remember is primary headaches are so common that many of the patients with primary headache can develop a serious secondary cause. So a patient with already diagnosed primary headache, you have to screen for a secondary headache if there is some change in character or frequency of headache. So I will come to that later. So this is the classification of headache. Broadly again, primary headache include migraine, tension type headache. Of this tension, in the population, tension type headache is the most prevalent headache, which constitute about 25 to 30%. Whereas migraine prevalence is around 15 to 20%, more common in females. And small percentage of primary headaches are called trigeminal autonomic cephalalgias, which has a typical features, which I will discuss later. And there are some rare primary headache disorders like exercise-induced headache, sexual headache, hypnic headache, that is headache only during sleep, etc. And there is a broad category called secondary headache. Some of these are very serious illnesses, manifestation of serious illnesses, which we should not miss. And some are benign but not related to a brain disease. For example, one of the common cause of secondary headache may be some ENT cause like sinusitis or sometimes ophthalmic causes like glaucoma or some iris disorders, etc. So this picture depicts the common manifestations of migraine, which we should ask for all patients. So as you can see here, usually the pain will be unilateral, throbbing headache. And it can be on both sides sometimes, or it can change the side. Some attack will be on right side, some will be on left side. And photophobia is one of the prominent symptoms of migraine. And again, phonophobia. And they will have a nausea and vomiting, which is again a typical symptom of migraine. So the main features, one is a PIN, that is a mnemonic used for migraine, which include photophobia, and it impairs the function of the person. That is important in severe migraine. And usually it lasts to 4 to 72 hours. And there are three types mainly: migraine with aura, migraine without aura. Aura is not seen in all patients, which is typically a visual aura. And there is an entity called chronic migraine, and these are usually episodic. And chronic migraine patient will have repeated headaches at least more than 15 days a month. Then you call it a chronic daily headache. So another common primary headache is tension type headache, which usually may vary in time. That is, it may last for minutes or sometimes days. It can be bilateral or unilateral. Usually it is a dull aching band-like pain, unlike the migraine, which is a throbbing unilateral pain. And severity may vary, But even some patients will report severe headache, but they will be able to do routine activity, unlike migraine. And usually there won't be any photophobia or phonophobia. And the third category is trigeminal autonomic cephalalgias, which is not common as the other two. But here the classically patients will have a unilateral severe pain around the orbit, periorbital pain, with conjunctival congestion, tearing from the eyes, nasal congestion, sometimes eyelid edema, etc. The common causes are cluster headache, paroxysmal hemicrania, and SUNCT. Of these, cluster is the most common trigeminal autonomic cephalalgia, and usually it affects men. There is 10 times predilection for men for cluster headache, and it will be a unilateral severe pain which can last up to 3 hours, and usually there will be associated conjunctival congestion, nasal congestion, eyelid edema, then forehead and facial sweating, etc. So now coming to approach to a patient who has headache who comes to our OPD. The first and foremost is to screen for a secondary headache. That you should know the red flags of headache. And if there are no red flags, you can diagnose a primary headache based on the history. And if there are any red flags, you should rule out secondary headache with appropriate investigation, including imaging, brain imaging. So this is the most important slide I have. This is a well recognized mnemonic, that is SNOOP4. These are the red flags. First is systemic symptoms. Ask for fever, weight loss, other things. Then secondary risk factors, secondary diseases like cancer, immunocompromised individuals, HIV. Third, N stands for any neurological symptoms or abnormal signs. If a patient has a weakness or a sensory deficit, we will be able to identify easily. But sometimes patient will have a subtle cognitive deficit if a disease affecting frontal lobe or temporal lobe, which they may not tell us in the history, but you will have to probe that. Or otherwise a cortical visual symptoms like cortical blindness. So patient may not report that. You have to watch for the walk, gait and other things. Another most important point is onset. If there is a severe explosive onset, you have to suspect a thunderclap headache due to SAH or other causes. Then age, any new headache after the age of 50, you have to suspect a secondary cause. Or a patient with a previous primary headache who has a significant change in the headache characters. That is another red flag. Then positional component. If the headache is more when the patient is upright, that indicates a low CSF pressure. Or if there is a raised ICP, patient will report that headache is more when they lie down. And ask for any provocative factors like coughing, exercise, or sexual intercourse. And pregnancy is another risk factor. They can have various disorders like cerebral vein thrombosis. So now I will discuss each point with some cases. This was a 21-year-old male who was a renal transplant recipient 3 years ago. He presented with severe headache and vomiting and had some on and off fever. There was no focal deficits. His X-ray chest was normal. And this was the MRI, which showed multiple lesions in the thalamus and in the parietal cortex. And it was enhancing with the ring enhancement with central necrosis. So we suspected a granuloma. His toxoplasma serology was positive. And we went ahead with brain biopsy, which showed a perivascular lymphoid infiltrate suggestive of toxoplasmosis. And he improved with treatment. So this is just highlight the secondary risk factor, a systemic illness. He was a renal transplant recipient. Likewise, in systemic symptoms, chronic meningitis like TBM can present with only headache. And on the background, they may have on and off fever and weight loss. So that you have to be careful. And case number 2 is a 35-year-old obese lady who reported headache of 6 months, which was a diffuse headache. And another important symptom was transient visual obscurations and tinnitus. That indicates some raised ICP features. And the most important examination was fundus, which showed papilledema. So this case is to highlight the importance of examining a fundus. I think any new significant headache needs a proper fundus examination. So this patient had actually idiopathic intracranial hypertension. Her MRI brain was otherwise normal except for indirect features of raised ICP, and CSF opening pressure was 400. So IIH usually has a predilection for obese young ladies. Usually they will have papilledema, and if you don't detect papilledema early and treat it, they can go in for optic atrophy and even sometimes permanent blindness. So early treatment is important with reduction of ICP as well as weight reduction. And imaging will be otherwise normal, and CSF analysis will be normal. Only thing will be raised CSF pressure, usually more than 200 millimeter water. And it is actually earlier called as BIH, benign intracranial hypertension. But now the name has changed to IIH because it's not always benign. It can lead to permanent blindness. So this highlights the importance of neurological signs, that fundus is one of the important things. And as I discussed earlier, sometimes a posterior cerebral artery stroke can present with only headache. And if you examine very carefully, you may find a visual field defect. Coming to case number 3 is a 35-year-old man who had an acute severe headache, which was an exploding headache he never had in his life while he was lifting heavy objects. Actually, he was on a vacation, so he was lifting some weight, and he had an associated sweating and vomiting. So he did not have any access to a major hospital, so he got some analgesics, and that after rest he got relief after 24 hours. But he continued to have a minimal headache, so he got admission. His CT scan brain, which was done after a week of the event, that was normal. That is one important point. We went ahead with CSF, which showed a xanthochromic CSF and crenated RBCs, which made us to diagnose a subarachnoid hemorrhage. So subarachnoid hemorrhage, just by doing a CT scan, you cannot 100% rule out a subarachnoid hemorrhage. And this patient had a CT angiogram which showed an aneurysm of the right MCA. So he did a clipping and he was okay. So what is subarachnoid hemorrhage? Subarachnoid hemorrhage is the headache, otherwise called as a thunderclap headache. So you will be able to differentiate from other headaches, because it will be a sudden, severe, explosive headache which peaks in few seconds. And sometimes it may be precipitated by exercise or Valsalva maneuver. In some severe SH, they will have a decrease in arousal or loss of consciousness. And you should ask for a family history of aneurysm and subarachnoid hemorrhage. And examination may be some meningeal signs and sometimes retinal hemorrhages, cranial nerve third palsy if it is due to a posterior communicating artery aneurysm. And the important point is CT scan. It is nearly 100% sensitive if it is a significant SH within 6 hours. But as time goes on, that by day 5, the sensitivity is only 50%. So if you are doing a CT scan after 5 days of onset, you may not see a bleed in the CT. Then you should do a lumbar puncture or a CT angiogram. So lumbar puncture may show a gross blood or xanthochromia. And CT angiogram is usually done to see for aneurysm and further treatment. And there is an entity called sentinel hemorrhage in subarachnoid hemorrhage. So these patients will have sometimes a subtle severe headache, but usually resolved because of small leak. So CT may miss a small leak, and this patient was initially missed, and after some time he had a rebleed. So SH is the most important cause for thunderclap headache, and missing SH can be disastrous because rebleed, there is a mortality rate of around 30-40%. So there are various other causes of thunderclap headache which you should consider after ruling out subarachnoid hemorrhage, which include a reversible cerebral vasoconstriction syndrome, which usually occurs in postpartum ladies or who are put on some immunosuppressants. There are various causes which I will not be discussing. Cortical vein thrombosis is another cause for thunderclap headache. And another major cause is cervical artery dissection. So dissection, initially patient may have only headache and some neck pain. And after some time they may develop a hemiplegia or something else. So usually it happens after a maneuver, some vigorous maneuver over the neck. Sometimes we see some patients going for barber for hair dressing. They must sometimes does a maneuver, that is clicking maneuver of the neck. And I had seen a couple of patients who had a cervical artery dissection after this. So those history should come in. So this case highlights the importance of history of onset of headache. That is, you should see whether it was a sudden, and the patient will tell the time of onset and what he was doing during the onset. Coming to next case is a 65-year-old lady who was diabetic. She had headache of 2 months, which was severe, disabling. She had insomnia because of headache. Her neurological examination was normal, but she had an elevated inflammatory markers, and she had some tenderness in the temporal arteries. And her MRI showed a small meningioma, otherwise it was normal. So we did a temporal artery Doppler, which showed a diffuse wall thickening, suspicion of giant cell arteritis. And we also did a temporal artery biopsy, which confirmed the diagnosis of giant cell arteritis. So importance of giant cell arteritis is it can lead to blindness if you don't treat it early. And it usually occurs in older age group. So this highlights the importance of age, new onset headache after age of 50. So this is another case the 28-year-old lady who had a chronic migraine of more than 10 years. And she was on various medication. And she came with a new onset symptoms with severe worsening of headache and some neck pain. And she had some transient visual obscurations. And examination, there was a papilledema. And this was her MRI. You can see there was some hydrocephalus. Actually, this was a second MRI. And there was a small cyst in the third ventricle, which was probably an epidermoid cyst, which was not very much enhancing. And there was another cyst in the posterior fossa behind the medulla. So initially this hydrocephalus was not very prominent, so we suspected an IIH. But repeat scan showed this, and she had worsening of headache. So she underwent a endoscopic third ventriculostomy, and she's doing fine. So this highlights the importance of a change in character of headache. This patient had a headache of more than 10 years, which was a primary benign headache. But later on, she had a change in character of headache, which should make us to suspect a new pathology. Coming to next case, which is a 40-year-old lady. She had a recent onset headache with some fullness in ears with photophobia. One important point in the history was the headache was worse and she was upright posture. She was a teacher by profession, so by afternoon she will have to go and lie down in the staff room. Even sitting will not relieve her headache. She did not have any other focal neurological deficit. This was her MRI, which showed a bilateral subdural collections. And contrast showed a pachymeningeal thickening, enhancement. And there were some features of intracranial hypotension, that is decreased CS of pressure. So for diagnosing intracranial hypotension, you should ask for a contrast MRI, which will show a pachymeningeal enhancement. So usually it happens due to some small leak in the spinal dura. Most common is lumbar puncture, but sometimes it can be a spontaneous. Those who have a weak connective tissue or some other connective tissue disorders. So this patient was treated with a blood patch because she did not improve with our conservative management of hydration and caffeine. So this highlights the importance of positional history in the headache. When the headache is severe on upright posture, you should suspect an intracranial hypotension. Or when it is more when lying down, it is the opposite, intracranial hypertension. this is a 26-year-old lady who had a headache for 2 years. It's a diffuse, mainly occipital, frontal, sometimes neck. And she reported some vague intermittent numbness, and her CT brain was done, which was reported normal. And probably she was diagnosed as tension headache. But on further history, she reported severe headache, which was more on coughing and mainly occipital. So this was her MRI. When there is a cough headache, you should suspect a CV junction anomaly. So this patient had an Arnold-Chiari malformation. And by the time we diagnosed, there was a long syrinx in the secondary to Arnold-Chiari malformation. So cough headache is another important thing you should, it's a red flag. Other precipitating factors like exercise, sexual intercourse, again can be due to a mass lesion or an aneurysm. And another major red flag is pregnancy, which I'm not discussing. So pregnancy, especially postpartum ladies, you should suspect a cerebral vein thrombosis. And these are red flags, but there are some yellow flags, which also we should make suspicious of a primary headache. There is headache always occurring on one side, constant unilateral headache, or headache with severe neck pain. That is a yellow flag, and you should keep the patient on follow-up, or you should ask for an imaging. Children, primary headaches can occur in pediatric age group, but if it happens in a small child that is less than 7 years, always you should be careful, because they may not be able to give you a proper history. Then a patient with trigeminal autonomic cephalalgias, first episode, always you should rule out a secondary cause, or sometimes even glaucoma can mimic TAC. Or nocturnal headaches, that is patient awakens with severe headache in the night, that you should make suspicious of a secondary headache. Headache refractory to usual treatment, that is another point. Recent head trauma. So a post-traumatic headache it may be migraine can occur post-traumatically, tension headache, myofascial pain. But sometimes chronic subdural can occur very slowly without much neurological deficit. Or headache following a dental or ENT procedures, because that can cause sometimes a CNS infection or abscess. So these are the yellow flags which you should be careful. So I will just touch upon a few management tips for migraine. So migraine is we should have a combination of management of preventive and acute. And behavioral therapy is also very important, because migraine, especially proper sleep, proper dietary habits and proper hydration, those things. An acute treatment recommendation for a migraine, acute migraine, mild actually interferes with patient's daily routine. These are the indications, and some special circumstances like hemiplegic migraine, or if the patient prefers to have a prophylaxis. And what are the options? There are various options. The beta blockers, and you should be cautious in patients with asthma, diabetes, and cardiac comorbidities. But it is useful in patients with comorbid anxiety. Tricyclic antidepressants like amitriptyline, again, you should be cautious in angle closure glaucoma. And it is good for patients with comorbid depression and comorbid tension type headache. And topiramate is another anticonvulsant which is very useful in migraine. And you should, the side effects are sometimes patients may have renal stones, glaucoma, and it is not recommended in pregnancy. Valproate again can cause obesity, liver disease. But it's a mood stabilizer, so it's a good option in patients with depression. And flunarizine is another commonly used drug. And this table is actually from a US publication. It's not available in US. So flunarizine, the main side effect is weight gain. And in old age, you should be careful because it can cause extrapyramidal syndrome like Parkinsonism. So what is new in migraine treatment? There are various drugs in pipeline. These drugs have already come into the international market. It will be coming soon to Indian market. For acute treatment, there is CGRP receptor antagonists called GPANs, and another one is lesmeditan. And monoclonal antibodies have come into a big use in Western countries, which is very expensive. That has not come to India. Then botulinum toxin is already in India. which is again a very expensive treatment, only reserved for very resistant, highly disabling migraine. So to conclude, I will just give this thing. The first step when you have a headache is to rule out a secondary cause. So you should remember the mnemonic SNOOP4 and other yellow flags I had discussed. So you should go for appropriate investigation if you have any of these red flags and yellow flags. And 90% are primary. Then again you can see whether it's more than headache duration, more than 4 hours, when there is a photophobia or impaired function or nausea, vomiting, and then it is migraine probably. When there is a redness, lacrimation and autonomic features which I had discussed, then it is cluster hemicrania continua and cluster migraine. And if there are no redness, lacrimation, there are various chronic headache disorders like medication overdose headache disorder or chronic tension headache. And if it is less than 4 hours with redness, then we have discussed cluster headache, again SUNCT. If there are no autonomic features, there are various rare primary headache like primary cough headache or primary exertional headache. So that's all. Thank you.
Thank you, Ashraf, for covering the topic clearly and giving guidance on how to carefully exclude the secondary causes, which are the main concern when patient comes with headache to an OPD. One more point I want to say is some people with jaw temporomandibular pain also, they can come with chronic headaches and sometimes it's difficult to pick up. We'll open for questions.
Thank you, sir, for the informative session. I would request Chairperson to please give the momentum to the speaker. Vinu, ഒരു minute. Before going to the next session, result of the poster presentation. First prize goes to Dr. Remya, Dippenby resident, District Cooperative Hospital, Kozhikode. Please come, Dr. Remya.
I'm requesting Chandri Madam to give the certificate to Dr. Remya.
Second prize, Dr. Gautam Krishna. I also welcome Dr. Aisha Hana to please come and receive.
She is an undergraduate student, presented very nicely in the poster presentation. You will be clap to her.
Now coming over to the next session, it's a short session, Healthcare Disruption and Technology Influence. I welcome Mr. Adish Chakiri, CEO and co-founder MedQ. And I also welcome Dr. Mohan Leslie Noor to please chair the session.
So good evening again. So next session is on interface of technology and healthcare, a phase area where I also have a lot of interest. And it's an era of where technology is disrupting existing ways of doing things. So let's hear from Mr. Adarsh on how he is working in this area.
Hello. Yes, good evening, doctors. Actually, I was here for English prepared. I already ഭയങ്കര സംഭവം നടന്നുകൊണ്ടിരിക്കുകയാണല്ലോ. നിങ്ങൾ അത്രയും സീരിയസ് ആയിട്ട് ഭയങ്കര സീരിയസ് ആയിട്ട് ഇരിക്കുന്ന കണ്ടപ്പോൾ എനിക്ക് തോന്നി ഇനി എൻ്റെ സെഷൻ കഴിഞ്ഞാൽ മിക്കവാറും നിങ്ങൾ ഉറങ്ങിപ്പോകുന്നത്. അപ്പോൾ എനിക്ക് കുറച്ച് ടൈം കിട്ടിയിട്ടുള്ളൂ, ഒരു വിത്തിൻ 10 minutes. അപ്പോൾ ടെക്നോളജി കേൾക്കുമ്പോൾ തന്നെ ഒരു പക്ഷേ നിങ്ങൾക്ക് പെട്ടെന്ന് ദഹിക്കില്ല. കാരണം ഓൾറെഡി മെഡിക്കൽ ടേംസും അതിൻ്റെ ടെർമിനോളജിയും അതിൻ്റെ കുറേ കാര്യങ്ങൾ നിറഞ്ഞു നിൽക്കുന്ന ആൾക്കാരാണ്. എനിക്കറിയുന്ന കുറേ സുഹൃത്തുക്കൾ ഡോക്ടേഴ്സ് ഉണ്ട്. അപ്പോൾ അവരുടെ മൈൻഡ് അറിഞ്ഞുകൊണ്ടേ പറയാൻ കാണും. Let me go to some slide-by-slide presentation. ഇതിൽ ഹെൽത്ത് കെയർ ഡിസ്ട്രപ്ഷൻ എന്ന് പറയുമ്പോൾ ഞാൻ ഈ ഒരു സെഷനിൽ പറയാൻ ഉദ്ദേശിക്കുന്നത് ഡിജിറ്റൽ ഡിസ്ട്രപ്ഷനാണ് കേട്ടോ. ഹെൽത്ത് കെയറിൽ കുറേ മാറ്റങ്ങൾ സംഭവിച്ചിട്ടുണ്ട്. അത് നിങ്ങൾക്ക് ഡോക്ടേഴ്സ് നിങ്ങൾക്ക് അറിയാൻ പറ്റും. ഞാൻ മെയിൻ ഉദ്ദേശിക്കുന്നത് നമ്മുടെ ഒരു കുറഞ്ഞ കാലഘട്ടത്തിൽ സംഭവിച്ച ഡിജിറ്റൽ മാറ്റങ്ങളെക്കുറിച്ചാണ്. അത് വളരെ കൂടുതലും ഇൻഫ്ലുവൻസ് നമ്മുടെ മെഡിക്കൽ ഫീൽഡ് വരുത്തിയിട്ടുണ്ട്. അതിൽ സ്റ്റാർട്ടിംഗ് എന്ന് പറയുമ്പം തീർച്ചയായിട്ടും ഇലക്ട്രോണിക് ഹെൽത്ത് റെക്കോർഡാണ്, ECH. എനിക്ക് തോന്നുന്നു മിക്ക ഡോക്ടേഴ്സ് അതിനെക്കുറിച്ച് അവെയറാണ്. ഒരു ഏർലി 90s 70s ആ സമയത്താണ് ഇതിനെ കൂടുതൽ ആൾക്കാർ ശ്രദ്ധിച്ചു തുടങ്ങിയതും പിന്നെ ഇന്ത്യയിലേക്ക് വന്നതും. ഇപ്പം നമുക്കറിയാം നമ്മുടെ പേഷ്യൻസിൻ്റെ കാര്യത്തിൽ പേഷ്യൻ്റാണ് ഒരു ഹെൽത്ത് കെയർ സമയത്തും ഏറ്റവും ഇമ്പോർട്ടൻ്റ് പേഷ്യൻ്റാണ്. അപ്പോൾ പേഷ്യൻറ്റിൻ്റെ ഒരു റെക്കോർഡ് അവർ കൺസൾട്ടേഷൻ മുതൽ അവരുടെ ഡയഗ്നോസിസ് മുതൽ അവരുടെ പോസ്റ്റ് ട്രീറ്റ്മെൻറ്റ് എല്ലാ കാര്യങ്ങളും റെക്കോർഡ് ചെയ്തിട്ട് പ്രോപ്പറായിട്ട് നമുക്ക് കാര്യങ്ങൾ മനസ്സിലാക്കുക എന്ന് പറഞ്ഞിരിക്കുന്നത് വളരെ ഇമ്പോർട്ടൻ്റ് കാര്യമാണ്. അപ്പം ഈ ഇലക്ട്രോണിക് ഹെൽത്ത് കെയർ റെക്കോർഡ് വന്ന ശേഷം വലിയ മാറ്റങ്ങൾ സംഭവിച്ചിരിക്കുന്നത് ഫാസ്റ്റായിട്ട്. അതെന്നറിയാം, ഒരു കോർഡിനേഷൻ അതിൽ സംഭവിച്ചിട്ടുണ്ട്. പിന്നെ എറേഴ്സ് അറിയാം, വി ആർ ഹ്യൂമൺ, ഡോക്ടേഴ്സ് എന്ന് പറഞ്ഞാൽ പോലും വി ആർ ഹ്യൂമൺ. അപ്പോൾ അതിൽ ചിലപ്പോൾ നമുക്ക് മാനേജ് ചെയ്യുന്ന സമയത്ത് പല എറേഴ്സ് സംഭവിക്കാം. അപ്പോൾ ഇത് ടെക്നോളജി റെക്കോർഡ് ചെയ്യുന്ന സമയത്ത് ഒരു പേഷ്യൻറ്റ് വന്നു കഴിഞ്ഞാൽ അടുത്ത പ്രാവശ്യം അയാളെ റെക്കഗ്നൈസ് ചെയ്യാനും അതുപോലെ തന്നെ അയാളുടെ ഡാറ്റ ഈസിയായിട്ട് നമുക്ക് മനസ്സിലാക്കാൻ ഈ ഒരു സിസ്റ്റം നമുക്ക് സഹായിച്ചിട്ടുണ്ട്. പിന്നെ എൻഹാൻസ് പേഷ്യൻ്റ് ഔട്ട്കം തീർച്ചയായിട്ടും. കാരണം ഇത് ഒരു പേഷ്യൻ്റെ എല്ലാ ഹിസ്റ്ററിയും കാര്യങ്ങളും നമുക്ക് കിട്ടിക്കഴിഞ്ഞാൽ അവരുടെ ഒരു റീകവറി സ്റ്റേജ് വളരെ ഫാസ്റ്റ് ആയിരിക്കും. ഇതാണ് ഒന്ന് ഇലക്ട്രോണിക് ഹെൽത്ത് റെക്കോർഡ് എന്ന് പറഞ്ഞത്. ഇതിൻ്റെ ഒരു ടെക്നിക്കൽ സൈഡിലേക്ക് ഞാൻ പോകുന്നില്ല, കാരണം അതൊരു വലിയൊരു ഏരിയ തന്നെയാണ്. പിന്നെ രണ്ടാമത്തെ ഒരു ഹെൽത്ത് കെയർ ഡിസ്ട്രിബ്യൂഷൻ എന്ന് പറഞ്ഞിരിക്കുന്നത് ടെലി ഹെൽത്ത് അല്ലെങ്കിൽ നമ്മൾ ടെലിമെഡിസിനൊക്കെ പറയുന്ന കാര്യമാണ്. അത് പോസ്റ്റ് കൊറോണയ്ക്ക് ശേഷം വളരെ മാറ്റങ്ങൾ സംഭവിച്ച ഒരു സംഭവമാണ്. പിന്നെ അതുപോലെ റിമോട്ട് മോണിറ്ററിങ്. ഇതിൽ നമുക്കറിയാം ഒരു വെർച്വൽ കൺസൾട്ടേഷൻ, ഡോക്ടേഴ്സൊക്കെ ഇപ്പം ഓൺലൈൻ കൺസൾട്ടേഷൻ തുടങ്ങിയിട്ടുണ്ട്. അപ്പം നമുക്ക് എന്ത് ചെയ്യാം, റിമോട്ടായിട്ട് ഇവരെ ആക്സസ് ചെയ്യാനും അതുപോലെ തന്നെ പേഷ്യൻ്റായിട്ട് സംസാരിക്കാനൊക്കെ നമുക്ക് ഈ ഒരു ടെക്നോളജി നമ്മൾ നന്നായി സഹായിക്കുന്നുണ്ട്. പിന്നെ ഇത് ഇംപ്രൂവിങ് ആക്സസ് ടു കെയർ. പിന്നെ ഇത് വരുന്നത് റെഡ്യൂസിങ് ദ കോസ്റ്റ്. തീർച്ചയായിട്ടും പേഷ്യൻ്റ് ഒരിക്കലും ഡോക്ടേഴ്സിൻ്റെ അടുത്ത് വരേണ്ട ആവശ്യം വരുന്നില്ല. അതാണ് അതിൻ്റെ ഒരു ഏറ്റവും വലിയൊരു ഗുണം. അതുപോലെ തന്നെ ഡോക്ടേഴ്സിനെ ഏത് സ്ഥലത്തും എവിടെ വെച്ചിട്ട് എന്ത് ചെയ്യാം, അവരുടെ കൺസൾട്ട് ചെയ്യാൻ പറ്റും. അതുകൊണ്ട് ആ കോസ്റ്റ് നമുക്ക് റെഡ്യൂസ് ചെയ്യാൻ പറ്റും ഈ ഒരു സെഗ്മെൻറ്റിൽ, ടെലി ഹെൽത്തിൽ. പിന്നെ ഏർലി വാർണിംഗ് സൈൻസ്. ഇപ്പം നമുക്ക് എന്തെങ്കിലും ഒരു രോഗങ്ങൾ വരാൻ സാധ്യതയുണ്ടെങ്കിൽ നമുക്കത് മുൻകൂട്ടി മനസ്സിലാക്കാനും അതുപോലെ തന്നെ അത് മോണിറ്റർ ചെയ്യാനും ഈ ഒരു ടെലി ഹെൽത്തും അതുപോലെ റിമോട്ടിംഗ് ആക്സ് വെയിറ്റ് നമുക്ക് ചെയ്യാൻ പറ്റും. ഒട്ടനവധി ടെക്നോളജികളും ഡിവൈസസും ഇതിൽ അവൈലബിൾ ആണ്. അപ്പോൾ അതൊന്നും ഞാൻ ഇവിടെ കാണിക്കുന്ന സമയം ഉണ്ടാവില്ല, കാരണം എനിക്കകത്ത് കുറച്ച് സമയമാണ് തന്നിരിക്കുന്നത്, അതുകൊണ്ടാണ്. ഒബ്വിയസ്ലി ഇത് എല്ലാ ആൾക്കാരും ഈ സമയത്ത് കൂടുതൽ ആൾക്കാരും സംസാരിക്കുന്നതും അതുപോലെ തന്നെ ചർച്ച ചെയ്യുന്ന ഒരു സെഗ്മെൻറ്റാണ് AI. ഈ ChatGPT ഒക്കെ യൂസ് ചെയ്യുന്ന ആൾക്കാരും ഉണ്ടോ? ജസ്റ്റ് കൈപൊക്കിയാൽ കൊള്ളാം, ഇത് അറിയാൻ വേണ്ടിയിട്ടാണ്. ChatGPT യൂസ് ചെയ്യുന്ന ആരെങ്കിലും ഉണ്ടോ? സ്റ്റുഡൻസായി ഐ തിങ്ക് സ്റ്റുഡൻസൊക്കെ കൂടുതൽ യൂസ് ചെയ്യുന്നുണ്ട്. ആർ യു ഫെമിലിയർ വിത്ത് ChatGPT? യെസ് ഓർ നോ? യെസ്, ഓക്കെ, വെരി ഗുഡ്. ഇത് ന്യൂജൻ ആൾക്കാരൊക്കെ ഇപ്പം കൂടുതൽ നമ്മൾ ഡിപ്പെൻഡ് ചെയ്യുന്ന സംഭവമാണ്. പ്രത്യേകിച്ചിട്ട് അസൈൻമെൻറ്റ്സ് അതുപോലെ തന്നെ പല കാര്യങ്ങൾക്ക് വേണ്ടിയിട്ടും ക്യാപ്സൂൾ ലെവലിൽ നമുക്ക് കിട്ടും. പണ്ട് ഗൂഗിളൊക്കെ ആണെങ്കിൽ നമ്മളിത് കൊടുത്തു കഴിഞ്ഞാൽ ഒരു വലിയൊരു ഏരിയയാണ് തരുന്നത്, സമുദ്രമാണ് തരിക ഗൂഗിളൊക്കെ. അതിൽ നമ്മൾ എന്ത് ചെയ്യണം, സെലക്ട് ചെയ്ത് കണ്ടുപിടിക്കണം. പക്ഷേ ChatGPT എന്ന് പറഞ്ഞിരിക്കുന്ന ഒരു AI ടൂൾ നമുക്ക് ക്യാപ്സൂൾ രൂപത്തിൽ എന്താണ് കൊടുത്തു കഴിഞ്ഞാൽ കറക്റ്റായിട്ട് കിട്ടും. കോഴിക്കോട് എന്ന് പറഞ്ഞിരിക്കുന്ന കോഴിക്കോടിൻ്റെ ഏതൊക്കെ ഭാഗമാണ് നമുക്ക് ആവശ്യമുള്ളത് അത് ശരിക്കത് പിക്ക് ചെയ്തിട്ട് നമുക്ക് എടുത്തിരും. അതാണ് ChatGPTൻ്റെ ഗുണം. അപ്പോൾ ഞാൻ പറഞ്ഞു വന്നത് ആർട്ടിഫിഷ്യൽ ഇൻ്റലിജൻസ് ഒബ്വിയസ്ലി നമ്മുടെ ഹെൽത്ത് കെയറിൽ വളരെ ഇൻഫ്ലുവൻസ് നടത്തിക്കൊണ്ടിരിക്കുകയാണ്. അതിൽ മേക്ക് പ്രിഡിക്ഷൻ എന്ന് പറഞ്ഞിരിക്കുന്നത് നമുക്കറിയാം. ഇപ്പം ഡോക്ടേഴ്സ് എന്ന് പറഞ്ഞിരിക്കുന്ന നിങ്ങൾ പലപ്പോഴും ഈ രോഗം നിർണ്ണയിക്കുക നിങ്ങളുടെ ഒരു പെർസെപ്ഷൻ വെച്ചിട്ടാണ്, നിങ്ങളുടെ അറിവ്, നിങ്ങളുടെ എക്സ്പീരിയൻസ്, അതുപോലെ തന്നെ നിങ്ങൾക്ക് കിട്ടിയിരിക്കുന്ന ആ ഒരു റെക്കോർഡൊക്കെ വെച്ചിട്ടാണ്. പക്ഷേ ആർട്ടിഫിഷ്യൽ ഇൻ്റലിജൻസ് ഡാറ്റ കൊടുത്തു കഴിഞ്ഞാൽ അത് അക്യുറേറ്റ് ആയിട്ട് നമുക്ക് അതിൻ്റെ റിസൾട്ട് തരും. അതാണ് ഈ ഒരു ടൂളിൻ്റെ പ്രത്യേകത. പിന്നെ റെഡ്യൂസ് ഫിസിക്കൽ അഡ്മിനിസ്ട്രേറ്റീവ് ടാസ്ക്. അറിയാൻ പറ്റും, നമുക്ക് സമയം ഉണ്ടാവില്ല, രാവിലെ മുതൽ വൈകുന്നേരം വരെ ഭയങ്കര തിരക്കായി ഡോക്ടേഴ്സിന്, നിങ്ങൾക്ക് ഒന്ന് തിരിയാനൊന്നും സമയം ഉണ്ടാവില്ല. ബട്ട് നിങ്ങളെ ഒരു AI ടൂൾ വെച്ച് കഴിഞ്ഞാൽ നിങ്ങളുടെ ഇത്തരത്തിലുള്ള അഡ്മിനിസ്ട്രേഷൻ ടാസ്കുകൾ പൂർണ്ണമായിട്ടും കുറക്കാൻ പറ്റും. പിന്നെ ഇംപ്രൂവിങ് പേഷ്യൻ്റ് ഔട്ട്കംസ്. തീർച്ചയായിട്ടും, കാരണം ഇത് ഒരു കൊടുത്തിരിക്കുന്ന ഡാറ്റയുടെ അനുബന്ധിച്ചായിരിക്കും നമുക്ക് ഇന്ന് കിട്ടിയതിൻ്റെ റിസൾട്ട് കിട്ടുക. അപ്പോൾ ഇതിൽ നമുക്ക് കിട്ടുന്ന ആ ഒരു റിസൾട്ടിൻ്റെ ഒരു തോത്, ഡെൻസിറ്റി വളരെ കൂടുതലായിരിക്കും. പിന്നെ വരുന്നത് ബ്ലോക്ക് ചെയിൻ ടെക്നോളജിയാണ്. ഈ ബ്ലോക്ക് ചെയിൻ ടെക്നോളജി എന്ന് പറഞ്ഞിരിക്കുന്നത് ഇപ്പം നമ്മൾ യൂസ് ചെയ്യുന്ന പല സോഫ്റ്റ്വെയർസും സെക്യൂർഡ് എന്ന് പറയാം. ഇപ്പം നമ്മൾ പല സോഫ്റ്റ്വെയർസ് യൂസ് ചെയ്യുന്നുണ്ട്. അതിലൊക്കെ നമ്മൾ യൂസ് ചെയ്യുന്ന പല പ്രോഗ്രാമിംഗ് ലാംഗ്വേജുകളും ശരിക്കും പഴയ ടൈപ്പ് സാധനമാണ്. ബ്ലോക്ക് ചെയിൻ എന്ന് പറഞ്ഞിരിക്കുന്നത് ഇത് വളരെ സെക്യൂർഡാണ്. ഒരാൾക്ക് ഇതിനെ ഹാക്ക് ചെയ്യാൻ പറ്റില്ല. അതുപോലെ തന്നെ ഒരാൾക്ക് ഇതിനെ എന്താ പറയുക, പിന്നെ റീകൺസ്ട്രക്ട് ചെയ്യാനൊന്നും പറ്റില്ല. വൺസ് ഇത് എടുത്തു കഴിഞ്ഞാൽ അതിൻ്റെ മുകളിൽ ഇത് കൺസ്ട്രക്ട് ചെയ്ത് പോവുക ചെയ്യുക. അപ്പോൾ ഇത് വളരെ സെക്യൂർഡാണ്. അപ്പം പ്രധാനമായിട്ട് ഇത് യൂസ് ചെയ്യുന്നത് നമ്മുടെ ഹെൽത്ത് കെയർ സെഗ്മെൻറ്റിലാണ്. ബിക്കോസ് നമുക്കറിയാം ഈ EGS എന്ന് പറഞ്ഞാൽ നമ്മുടെ ഡാറ്റ ഉണ്ടാവില്ല, പേഷ്യൻ്റ് ഡാറ്റ വളരെ ഇമ്പോർട്ടൻ്റ് ആണ്. ഇപ്പം ഗവൺമെൻറ്റൊക്കെ കുറേ റൂൾസ് കൊണ്ടുവന്നിട്ടുണ്ട്, പിന്നെ പല ആൾക്കാരും ഇത് ഹാക്ക് ചെയ്ത് കൊണ്ടുവന്നു പറഞ്ഞിട്ട്. അപ്പം തീർച്ചയായിട്ടും ഈ ഒരു സെഗ്മെൻറ്റിൽ ബ്ലോക്ക് ചെയിൻ ടെക്നോളജി വരുന്ന കൂടിയിട്ട് പൂർണ്ണമായിട്ടും സെക്യൂർഡ് ആയിരിക്കും. പിന്നെ എറേഴ്സ് നമുക്കറിയാം, നമുക്ക് ഏറ്റവും കൂടുതൽ പേടിയുള്ളത് നമ്മൾ കൊടുത്തിരിക്കുന്ന ഡാറ്റാസ് അതിലെന്ത് എറേഴ്സ് സംഭവിക്കുന്നുള്ള. പക്ഷേ ബ്ലോക്ക് ചെയിൻ ടെക്നോളജി ഉപയോഗിക്കുമ്പോൾ അത് എറേഴ്സ് വളരെ കുറവായിരിക്കും ആസ് കമ്പയർഡ് ടു നമ്മുടെ ഇപ്പോൾ യൂസ് ചെയ്യുന്ന സോഫ്റ്റ്വെയറിനെ വെച്ചിട്ട്. ഇപ്പോൾ ബ്ലോക്ക് ചെയിൻ എന്ന് പറഞ്ഞിരിക്കുന്നത് ഒരു സോഫ്റ്റ്വെയർ ടെക്നോളജിയാണ്. പ്രെസിഷൻ മെഡിസിൻ, ഇത് എനിക്ക് തോന്നുന്നു നിങ്ങളെല്ലാവർക്കും ഭയങ്കര ഫെമിലിയർ ആയിരിക്കും. പിന്നെ ഇതിൽ നമ്മൾ പല തീരുമാനങ്ങളും എടുക്കുന്നത് ചിലപ്പോൾ ഒരു ഹിസ്റ്ററിയൊക്കെ നോക്കിയിട്ടായിരിക്കും. അത് പെർട്ടിക്കുലർ ഒരു ഇൻഡിവിജ്വൽ കെയറിന് വേണ്ടിയിട്ടാണ് മിക്കവാറും ഈ ഒരു സെഗ്മെൻറ്റ് നമ്മൾ യൂസ് ചെയ്യുന്നത്. അപ്പം ഇതിൽ നമ്മൾ ഉപയോഗിക്കുന്ന ജനോമിക് ഡാറ്റ, കാരണം ഒരു രോഗിയെക്കുറിച്ച് പഠിച്ചിട്ട് അയാൾക്ക് ട്രീറ്റ്മെൻറ്റ് കൊടുക്കണമെങ്കിൽ കുറേ സമയം എടുക്കും. പക്ഷേ നമുക്ക് ടെക്നോളജി വെച്ചിട്ട് തീർച്ചയായിട്ടും ആ ഡാറ്റ ഫീഡ് ചെയ്യാനും അത് റീകവർ ചെയ്യാനും അതുപോലെ തന്നെ നമുക്ക് അക്യുറേറ്റ് ആയിട്ട് വളരെ ഫാസ്റ്റായിട്ട് ആ പെർട്ടിക്കുലർ പേഷ്യൻറ്റിന് നമുക്ക് ട്രീറ്റ്മെൻറ്റ് കൊടുക്കാൻ ഈ ഒരു സംഭവം പറ്റും. നമുക്ക് തീർച്ചയായിട്ടും റിസൾട്ട് ഇറ്റ്സ് ഒബ്വിയസ്ലി വളരെ ബെറ്റർ ആയിരിക്കും, വെരി ഫാസ്റ്റ് ആയിരിക്കും. ഓക്കെ, ഞാൻ പറഞ്ഞു വന്നത് ഈ 5 കാര്യങ്ങളാണ് നമ്മുടെ ഈ ഒരു അറൗണ്ട് ഒരു 40 to 35 ഇയേഴ്സ് സംഭവിച്ചിരിക്കുന്ന വലിയൊരു ഡിസ്ട്രപ്ഷൻ എന്ന് പറഞ്ഞിരിക്കുന്ന കാര്യം. ഇതിൻ്റെ ബേസ് ചെയ്തുകൊണ്ടാണ് പല ടെക്നോളജികളും പല കാര്യങ്ങളും നമുക്ക് ഹെൽത്ത് കെയറിൽ സംഭവിച്ചിരിക്കുന്നത്. ഞാൻ ഒരിക്കലും ടൂൾസിനെ പറ്റി പറഞ്ഞില്ല. ഇപ്പം നമുക്ക് റോബോട്ടിക്സ് ഉണ്ട്, അതുപോലെ തന്നെ മറ്റുള്ള അനേകമായിരിക്കുന്ന ടൂൾസുകൾ അവൈലബിൾ ആണ്. ബട്ട് ഞാൻ ഡിജിറ്റൽ സ്പേസിൽ നമുക്ക് വന്നിരിക്കുന്ന ഒരു ചേഞ്ചസ് ആണ് മെയിനായിട്ട് ഞാൻ ഇതേക്കുറിച്ചിട്ട് പറയാൻ ശ്രമിച്ചത്. യെസ്. അപ്പം ഇവിടെ വേറൊരു കാര്യം എന്ന് വെച്ചാൽ വൈ ഞങ്ങൾ ഇപ്പം പ്രൊമോട്ട് ചെയ്യുന്ന അല്ലെങ്കിൽ ഞങ്ങൾ പിന്നെ മെയിനായിട്ട് ഡെവലപ്പ് ചെയ്തിരിക്കുന്ന നമ്മുടെ ഒരു പ്രോഗ്രാമിങ്, അതുപോലെ നമ്മുടെ കമ്പനി ഉണ്ട് മെഡിക്കൂ എന്ന് പറഞ്ഞാൽ ഇത്രയും പറഞ്ഞിട്ട് 5 കാര്യങ്ങൾ ഞങ്ങൾ കമ്പൈൻഡായിട്ട് അസൈൻ ചെയ്തിട്ട് ഡോക്ടേഴ്സിന്, പ്രത്യേകിച്ച് ഡോക്ടേഴ്സ്, നമുക്കറിയാം ഹെൽത്ത് കെയറിലെ ഏറ്റവും ഇമ്പോർട്ടൻറ്റ് ഡോക്ടേഴ്സാണ് സ്റ്റാർട്ടിംഗ് പോയിന്റ് അവിടെ വരുന്നത്. അപ്പോൾ ഡോക്ടേഴ്സിനെ കൂടെ ഉൾപ്പെടുത്തിയിട്ട് അവർക്ക് വേണ്ടിയിട്ടുള്ള എല്ലാ കാര്യങ്ങളും ഈ പറഞ്ഞിരിക്കുന്ന 5 കാര്യം ഉൾപ്പെട്ട് ഞങ്ങൾ ഡെവലപ്പ് ചെയ്തിരിക്കുന്ന ഒരു സിസ്റ്റമാണ്, ഒരു ഡിജിറ്റൽ സിസ്റ്റമാണ് മെഡിക്കൂ എന്ന് പറഞ്ഞിരിക്കുന്നത്. ഇപ്പോൾ ഇന്ത്യയിൽ തന്നെ ഫസ്റ്റ് ടൈം ഒരു അഗ്രിഗേറ്റിംഗ് പ്ലാറ്റ്ഫോം എന്ന് പറയാം. കാരണം എല്ലാ ഹെൽത്ത് കെയർ സർവീസുകളെയും ബന്ധിപ്പിക്കുന്ന ഒരു സിസ്റ്റം നിലവിൽ ഇപ്പോൾ ഇന്ത്യയിൽ ഇല്ല. ഒന്നുകിൽ ഇപ്പം നിങ്ങൾ പ്രാക്ടോ കേട്ടിട്ടുണ്ടാവും. പ്രാക്ടോ എന്ന് പറഞ്ഞിരിക്കുന്നത് ആക്ച്വലി അത് ഡോക്ടേഴ്സിന് ഓൺലൈൻ കൺസൾട്ടേഷൻ കൊടുക്കാനുള്ള ഒരു പ്ലാറ്റ്ഫോം മാത്രമാണ് ആക്ച്വലി അത് വരുന്നത്. പക്ഷേ ഒരു ഡോക്ടർ, ഒരു പ്രൈവറ്റ് പ്രാക്ടീസ് ചെയ്യുന്ന ഡോക്ടറെ സംബന്ധിച്ചിടത്തോളം അദ്ദേഹം ഇപ്പോഴും ഒരു കൺവെൻഷണൽ മെത്തേഡിലാണ് പ്രാക്ടീസ് ചെയ്യുന്നത്. നമുക്കറിയാൻ പറ്റും അത് വേറെ സോഫ്റ്റ്വെയർസ് ഒന്നും യൂസ് ചെയ്യുന്നില്ല. പിന്നെ സെയിം ഞാൻ നമ്മൾ ഫസ്റ്റ് പറഞ്ഞു, ടെക്നോളജി പറഞ്ഞിരിക്കുന്നത് ഒരിക്കലും ഒരു മാൻ പവറിനെ മാറ്റി നിർത്തുന്ന സംഭവമല്ല. നമ്മുടെ സമയം, അതായത് നമ്മൾ നിലവിലെ സമയത്തെ മാക്സ് യൂട്ടിലൈസ് ചെയ്യുക, അതുപോലെ തന്നെ നമ്മൾ റിസ്ക് കുറക്കുക, അതുപോലെ തന്നെ നമുക്ക് മാക്സിമം റിസൾട്ട് കിട്ടുക, ഇതൊക്കെയാണ് ആക്ച്വലി ടെക്നോളജി എന്നുള്ള സംഭവം കൊണ്ട് നമ്മൾ ഉദ്ദേശിക്കുന്നത്. ചില ആൾക്കാർക്ക് പറയും ഇത് കാരണം ആൾക്കാർ ജോലി പോകും അല്ലെങ്കിൽ മറ്റും സംഭവിക്കും. നെവർ. നമ്മുടെ ഏരിയ ടാലൻറ്റ് ഓക്കെ ആണെങ്കിൽ, നമ്മുടെ അതിൽ എക്സ്പേർട്ട് ആണെങ്കിൽ ഒരിക്കലും നമുക്ക് ഈ ഒരു സംഭവം കൊണ്ട് ഒരിക്കലും നമ്മുടെ ഒരു ചാൻസ് പോകില്ല. അപ്പോൾ ഞങ്ങൾ ഇതുകൊണ്ട് തന്നെയാണ് ഡോക്ടേഴ്സിന് വേണ്ടിയിട്ട് ഈ സാധനം ഡെവലപ്പ് ചെയ്തിരിക്കുന്നത്. ഇപ്പോൾ ഡോക്ടേഴ്സ് മാത്രമല്ല, ഡോക്ടേഴ്സ് തുടങ്ങി അവസാനം വരുന്ന നമ്മുടെ ഒരു ഗ്രൗണ്ടിൽ വരുന്ന ആൾക്കാർക്ക് വരെയുള്ള ഹെൽത്ത് കെയർ സിസ്റ്റമാണ് ഇതുവഴി പ്രൊവൈഡ് ചെയ്യുന്നത്. ഇപ്പോൾ ഇതിൽ മേജറായിട്ട് ഞങ്ങൾ ഉദ്ദേശിക്കുന്നത് വെച്ചാൽ, ഇപ്പം നിങ്ങൾക്കറിയാം ഡോക്ടേഴ്സ്, ഞാൻ പറയും 99% നിങ്ങളായിട്ടുള്ള ഒരു ഫീൽഡായിട്ട് ഭയങ്കര ഫോക്കസ്ഡ് ആയിരിക്കും. എപ്പോഴും ഞാൻ സ്റ്റാർട്ടിങ് പറഞ്ഞ പോലെ തന്നെ നിങ്ങളെ മെഡിക്കൽ ടേംസുകൾ, മെഡിക്കൽ കാര്യങ്ങൾ, റെക്കോർഡ്സുകൾ, പേഷ്യൻസ് ഹിസ്റ്ററി, ഇതൊക്കെ വെച്ച് നിങ്ങൾ ടോട്ടലി നിങ്ങളുടെ മൈൻഡ് എൻഗേജ്ഡ് ആയിരിക്കും. അപ്പോൾ അതിൻ്റെ ഇടയ്ക്ക് നിങ്ങൾക്ക് ഈ കാലഘട്ടത്തിൽ മുന്നോട്ട് പോകണമെങ്കിൽ കുറേ കാര്യങ്ങൾ നമ്മൾ എന്ത് ചെയ്യേണ്ടത്, അഡോപ്റ്റ് ചെയ്യണം. ഇപ്പോൾ നിങ്ങൾക്ക് കോമ്പറ്റീഷൻ വരാം, ഡയറക്റ്റ് കോമ്പറ്റീഷൻ വരാം, ഇൻഡയറക്റ്റ് കോമ്പറ്റീഷൻ വരാം, പിന്നെ പലതരത്തിലുള്ള എന്താ പറയുക മറ്റുള്ള കാര്യങ്ങൾ നമുക്ക് നമ്മുടെ ഈ ഒരു സർവീസിൽ വരുന്ന നിങ്ങളെ പ്രാക്ടീസ് വരുന്ന സമയത്ത് അവിടെയൊക്കെ നിങ്ങൾക്ക് ഒരു മാനസികമായ സമ്മർദ്ദം വരാം. അപ്പോൾ ഇതൊക്കെ നമുക്ക് റെഡ്യൂസ് ചെയ്യാൻ വേണ്ടിയിട്ട് തീർച്ചയായിട്ടും നിങ്ങൾക്ക് നല്ലൊരു ശക്തനായ ഒരു പാർട്ട്ണർ, ഒരു ടെക്നോളജി പാർട്ട്ണർ നിങ്ങൾക്ക് അത്യാവശ്യമാണ്. ഇപ്പോൾ നിങ്ങൾക്ക് ഒരിക്കലും ഹയർ ചെയ്യാൻ പറ്റില്ല. നിങ്ങൾക്ക് ഒറ്റയ്ക്ക് പോയി പഠിക്കാനോ അല്ലെങ്കിൽ നിങ്ങൾക്ക് അതിനുവേണ്ടി ഒരാളെങ്കിൽ ഹയർ ചെയ്യാൻ പറ്റില്ല. അപ്പോൾ ഞങ്ങൾ ഡിസൈൻ ചെയ്തിരിക്കുന്നത് ഒരു ഡോക്ടർക്ക് നമുക്ക് മാക്സിമം അവരുടെ ടെക്നോളജി ലെവൽ എങ്ങനെ ഹെൽപ്പ് ചെയ്യാൻ പറ്റും, അവരുടെ പ്രാക്ടീസിൽ അവരുടെ റിസ്ക് എങ്ങനെ കുറക്കാൻ പറ്റും, അവർക്ക് മുന്നോട്ട് പോകാനുള്ള എന്തൊക്കെ ഡിജിറ്റൽ പരമായിട്ടുള്ള സഹായം ചെയ്തു കൊടുക്കാൻ പറ്റുന്ന ലെവലാണ് നമ്മൾ ഡെവലപ്പ് ചെയ്തിരിക്കുന്നത്. പിന്നെ റെഗുലർ സപ്പോർട്ട്, നിങ്ങൾക്ക് വേണ്ടി ഏത് സമയത്തും ഞങ്ങളെ കോൺടാക്ട് ചെയ്ത് കഴിഞ്ഞാൽ, ഞങ്ങളുടെ ടീംസിനെ കോൺടാക്ട് ചെയ്ത് കഴിഞ്ഞാൽ നിങ്ങൾ സപ്പോർട്ട് കിട്ടും. ഇത് ഞങ്ങളുടെ ഒരു ഇൻ്റർഫേസ് ആണ് ആപ്ലിക്കേഷൻ്റെ. യു ക്യാൻ സീ ദാറ്റ് ഫ്രം ബിഗിനിങ് യു ആർ ദ ടോപ്പ്, യുവർ ഡോക്ടേഴ്സ് ആർ ടോപ്പ്. കാരണം നമ്മുടെ സമൂഹത്തിൽ അല്ലെ ഹെൽത്ത് കെയർ സിസ്റ്റത്തിൽ ഡോക്ടേഴ്സ് ഇല്ലാണ്ട് നമുക്ക് ചിന്തിക്കാനല്ല, ഹെൽത്ത് കെയർ സിസ്റ്റം ഇല്ല. അപ്പം ഡോക്ടേഴ്സ് മുതൽ ലാസ്റ്റ് പെയിൻ പാലിറ്റീവ് ടോട്ടലി 24 സർവീസാണ് നമ്മളിതിൽ ഇൻറ്റഗ്രേറ്റ് ചെയ്തിരിക്കുന്നത്. കാരണം ഏറ്റവും അത്യാവശ്യമായിരിക്കുന്ന ഒരു സമൂഹത്തിൽ ഒഴിച്ചുകൂടാൻ പറ്റാത്ത, ഇത് റിയൽ ടൈം കൂടിയാണ്. നമുക്ക് നിൽക്കുന്ന സമയത്ത്, നിൽക്കുന്ന സ്ഥലത്ത് നമുക്ക് എന്ത് ചെയ്യാൻ പറ്റും, ഇത് ആക്സ് ചെയ്യാൻ പറ്റും. ഓക്കെ, യെസ്. ഞങ്ങൾ പ്രൊവൈഡ് ചെയ്യുന്ന ഒരു സമയം ഡോക്ടർ പേഷ്യൻ്റ് അപ്പോയിൻമെൻറ്റ് മാനേജ്മെൻറ്റ് സിസ്റ്റമാണ്. അപ്പോയിൻമെൻറ്റ് മാത്രമല്ല, ആക്ച്വലി ഒരു മാനേജ്മെൻറ്റ് ഒരു ഇന്ത്യയിൽ ഞാൻ നേരത്തെ സൂചിപ്പിച്ചു, നിങ്ങളെ സമയത്തോളം നിങ്ങൾക്ക് നിങ്ങളുടെ സമയം റെഡ്യൂസ് ചെയ്യണമെങ്കിൽ കുറേ ടെക്നോളജിക്കൽ കാര്യങ്ങൾ നിങ്ങൾക്ക് തരേണ്ടതായിട്ടുണ്ട്. ഇതിൽ ജോയിൻ ചെയ്യണമെങ്കിൽ ടോട്ടലി 0 കോസ്റ്റ് ആണ്. ഡോക്ടേഴ്സിൽ ഒരു എമൗണ്ട് ഒന്നും മുടക്കേണ്ട ആവശ്യമില്ല. യു ക്യാൻ യൂസ് ആപ്ലിക്കേഷൻ ഫ്രീ ഓഫ് കോസ്റ്റ്. രണ്ടാമത്തെ ഈസി ടു മാനേജ് ആണ്. ഇതിൽ വലിയ ടെക്നിക്കൽ നോളജ് ഒന്നും വേണ്ട. ഞങ്ങൾ ഇത് സാധാരണക്കാർക്ക്, ഇതൊരു ടെക്നോളജി നോളജ് അറിയാത്ത ആർക്കും ഇത് യൂസ് ചെയ്യുന്ന തരത്തിലാണ് ഇതിൻ്റെ ഇൻ്റർഫേസ് ഞങ്ങൾ ഡെവലപ്പ് ചെയ്തിരിക്കുന്നത്. പിന്നെ ഡിജിറ്റൽ പ്രിസ്ക്രിപ്ഷൻ, ഒബ്വിയസ്ലി ഇപ്പം നിലവിൽ ആരെങ്കിലും ഡിജിറ്റൽ പ്രിസ്ക്രിപ്ഷൻ ചെയ്യുന്നുണ്ടോ പ്രൈവറ്റ് പ്രാക്ടീസിൽ? ജസ്റ്റ് കൈപ്പൊക്കിയാൽ കൊള്ളാം ആരെങ്കിലും. ഇല്ലെന്ന് വിശ്വസിക്കുന്നു. ചിലപ്പോൾ ഹോസ്പിറ്റലൊക്കെ നമ്മൾ ചെയ്യുന്നുണ്ട്, പക്ഷേ പ്രൈവറ്റ് പ്രാക്ടീസ് ചെയ്യുന്ന സമയത്ത് നമ്മളൊരിക്കലും ഡിജിറ്റൽ പ്രിസ്ക്രിപ്ഷൻ യൂസ് ചെയ്യാൻ സാധ്യത കുറവാണ്. ഇത് നിങ്ങൾ പേഷ്യൻസിനെ നിങ്ങൾ അപ്പോയിൻമെൻറ്റ് എടുത്തു കഴിഞ്ഞാൽ, ഷെഡ്യൂൾ ചെയ്ത് കഴിഞ്ഞാൽ, ഒരു പേഷ്യൻറ്റ് വന്നു കഴിഞ്ഞാൽ നിങ്ങൾക്ക് ഓട്ടോമാറ്റിക് ക്ലൗഡ് സിസ്റ്റം ഉപയോഗിച്ചിട്ട് നമുക്ക് എന്ത് ചെയ്യാം, ഡിജിറ്റൽ പ്രിസ്ക്രൈബ് ചെയ്യാം. നിങ്ങളെ കോമ്പോസിഷൻ വെച്ചിട്ട് മെഡിസിൻസ് നിങ്ങൾക്ക് എന്ത് ചെയ്യാം, ഇമ്പോർട്ട് ചെയ്യാം ഈസിലി. അതുപോലെ തന്നെ നമുക്ക് ടെസ്റ്റുകൾ ഉണ്ടെങ്കിൽ ടെസ്റ്റുകളെ പേര് വെച്ചിട്ട് നമുക്ക് എന്ത് ചെയ്യാം, വിത്തിൻ സെക്കൻഡ് വെച്ചിട്ട് നിങ്ങൾക്ക് എന്ത് ചെയ്യാം, അത് പ്രിസ്ക്രിപ്ഷനിലേക്ക് നിങ്ങൾക്ക് അത് ഇമ്പോർട്ട് ചെയ്യാം. സ്പോട്ട് തന്നെ ജനറേറ്റ് ചെയ്യാം. ജനറേറ്റ് കഴിഞ്ഞാൽ ആ സാധനം, ആ പ്രിസ്ക്രിപ്ഷൻ പേഷ്യൻ്റ് കിട്ടുന്നു. പേഷ്യൻ്റ് ചെയ്യാം ഈസിലി ഏറ്റവും അടുത്തുള്ള ഫാർമസിയിലേക്കോ ലാബിലേക്കോ അത് ഷെയർ ചെയ്യുന്ന ഓപ്ഷൻസ് ഉണ്ട്. അപ്പം ഇത് ഇൻ ബിറ്റ്വീൻ, അതായത് ഡോക്ടറും പിന്നെ അതുപോലെ തന്നെ പേഷ്യൻ്റ് തമ്മിലുള്ള ആ ടൈം സംസാരത്തിനിടയിൽ പോലുള്ള കാര്യങ്ങൾ പോലും നമുക്ക് മാക്സിമം ടൈം യൂസ് ചെയ്യാൻ പറ്റും. പിന്നെ ഹൈലി പ്രൊട്ടക്റ്റഡ് ഡാറ്റ. നമുക്ക് ഏറ്റവും കൂടുതൽ കൺസേൺ എന്ന് പറഞ്ഞിരിക്കുന്നത് ഇത് പ്രൊട്ടക്റ്റീവ് ആണോ, അല്ലെങ്കിൽ ആരെങ്കിലും ഇത് മിസ്യൂസ് ചെയ്യുമോ എന്നുള്ള. ഇത് പൂർണ്ണമായിട്ടും ലീഗലി പ്രൊട്ടക്റ്റഡ് ഡാറ്റ ആയിരിക്കും. പിന്നെ ഞങ്ങൾ ഒരിക്കലും പേഷ്യൻസിൻ്റെ ഹിസ്റ്ററിയോ അല്ലെങ്കിൽ മറ്റുള്ള ഈ EHR പോലത്തെ കാര്യങ്ങൾ നമ്മൾ ഒരിക്കലും വായിക്കുന്നില്ല. അവരുടെ ഒരു അപ്പോയിൻമെൻറ്റ് സിസ്റ്റമോ അതുപോലെ നിങ്ങൾ കൊടുത്ത പ്രിസ്ക്രിപ്ഷൻ മാത്രമേ നമ്മുടെ സെർവറിൽ സേവ് ആവും. ബാക്കി ഒരു കാര്യങ്ങൾ നമ്മുടെ സെർവറിൽ സേവ് ആവുന്നില്ല. പിന്നെ ഈസി ടു എക്സിറ്റ്. പിന്നെ പലർക്കും പേടിയായിരിക്കും ഇതിൽ വന്നു കഴിഞ്ഞാൽ, ഇത് ചെയ്ത് കഴിഞ്ഞാൽ വേറെ എന്തെങ്കിലും പ്രശ്നങ്ങളുണ്ടോ. നിങ്ങൾക്ക് ഏത് സമയത്തും യൂസ് ചെയ്യാം, അല്ലെങ്കിൽ ഇത് അൺഇൻസ്റ്റാൾ ചെയ്യാം. നിങ്ങൾക്ക് ഏത് സമയത്തും എക്സിറ്റ് ചെയ്യാം. ഓക്കെ, താങ്ക് യു. ഇതിൽ കുറേ കാര്യങ്ങൾ ഉൾപ്പെടുന്ന വിചാരിച്ചിട്ടുണ്ടായിരുന്നു, പക്ഷേ എനിക്ക് കിട്ടിയിരിക്കുന്ന സമയം വളരെ കുറവാണ്. അപ്പോൾ അതുകൊണ്ട് ആണ് ഇത്തിരി ഫാസ്റ്റായിട്ട് കാര്യം പറഞ്ഞത്. താങ്ക് യു വെരി മച്ച്.
താങ്ക് യു. ആദർശ് പേര്?
യെസ് സർ, ആദർശ്.
ഈ ടെക്നോളജി ഇപ്പോൾ നമ്മുടെ കാലഘട്ടത്തിൻ്റെ അനിവാര്യമായ ഘടകമാണ്. മെഡിക്കൽ പ്രാക്ടീസ് നമ്മളത് മാറി നിൽക്കുന്നതിൽ കാര്യമില്ല. എല്ലാവരും ടെക്നോളജിയിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്ത് ഡോക്ടേഴ്സ് ഉൾപ്പെടെ മുന്നോട്ട് പോയാൽ അത് എല്ലാവർക്കും മെച്ചം ചെയ്യും. അത് തന്നെയാണ് ഇങ്ങനത്തെ പ്ലാറ്റ്ഫോംസ് നമുക്ക് ആവശ്യമാണ്. സോ ഇറ്റ്സ് വെരി ഗുഡ്. ഓൾ ദി ബെസ്റ്റ്. എന്തെങ്കിലും ക്വസ്റ്റ്യൻസ് ഉണ്ടെങ്കിൽ ചോദിക്കാം, സംശയം ഉണ്ടെങ്കിൽ.
എനിക്ക് ക്വസ്റ്റ്യൻസ് ഉണ്ടെങ്കിൽ ജസ്റ്റ് ചോദിക്കാം. ഞാൻ പറഞ്ഞല്ലോ, ഇത് ഓപ്പൺ ഒരു പ്ലാറ്റ്ഫോമാണ് നിങ്ങൾ സമയത്തോളം.
ഒരു ഇഷ്യൂ എല്ലാവരും ഫേസ് ചെയ്യുന്ന ഇതിൽ എങ്ങനെ എൻട്രി ചെയ്യുന്നുള്ളതാണ്. എല്ലാവരും പേപ്പർ ആൻഡ് പെന്നായിട്ട് കംഫർട്ടബിളാണ്. അപ്പം ന്യൂ ജനറേഷൻ ആകുമ്പോൾ പിന്നെ കുറച്ചും കൂടി അവർ ട്യൂൺഡ് ആയിരിക്കും. പേഷ്യൻസൊക്കെ പിന്നെ പറഞ്ഞ പോലെ എല്ലാവരും വാട്സപ്പും അതായിട്ട് കാലക്രമേണ എനിക്ക് തോന്നുന്നു എല്ലാവരും അതിലേക്ക് ആയിക്കോളും. ഒരു ട്രാൻസിഷൻ പീരീഡ് ഉണ്ടായിന്.
തീർച്ചയായിട്ടും. അല്ല, ഇത് നമുക്ക് ഒരു ടെക്നോളജി നമ്മൾ അഡോപ്റ്റ് ചെയ്യുന്ന ഒരു ടൈം എപ്പോഴും ഉണ്ടാവും. പിന്നെ ഇപ്പം തന്നെ ഏകദേശം ഒരു 66 കോടി ജനങ്ങളോളം ഇന്ത്യയിൽ ഇപ്പം സ്മാർട്ട് ഫോണും അതുപോലെ തന്നെ മൊബൈൽ ഫോൺ യൂസ് ചെയ്യുന്നുണ്ട്. കേരളത്തിൻ്റെ സ്ഥിതി 4.5 കോടി സ്മാർട്ട് ഫോൺ യൂസേഴ്സാണ്. അത് പറയുമ്പോൾ ആകെ 3.5 കോടി ജനങ്ങളേ ഉള്ളൂ, പക്ഷേ അതിൻ്റെ ഡബിളാണ് ഇവിടെ കേരളത്തിലെ സ്മാർട്ട് ഫോൺ യൂസേഴ്സ്. അപ്പോൾ തീർച്ചയായിട്ടും ഇനി ഒരു സ്മാർട്ട് ഡിജിറ്റൽ കാര്യമില്ലാതെ നമുക്ക് മുന്നോട്ട് പോകാൻ പറ്റില്ല, അത് ഏത് മേഖലയായാലും. പിന്നെ പ്രിസ്ക്രിപ്ഷൻ്റെ കാര്യത്തിൽ ഡോക്ടർ പറഞ്ഞ പോലെ എക്സാക്ട്ലി എഴുതിയിരിക്കുന്ന ആൾക്കാർക്ക് പെട്ടെന്ന് കൺവേർട്ട് ചെയ്യാൻ ബുദ്ധിമുട്ടായിരിക്കും. പക്ഷേ ഇത് ഈസി ടു ഞങ്ങൾ ആ ഒരു ഇത് വെച്ചിട്ട് തന്നെയാണ് സംഭവം ചെയ്തിരിക്കുന്നത്.
ഡാറ്റ പ്രൈവസി എങ്ങനെയാണ്? ഹൗ യു ആർ മെയിൻറ്റെയിനിങ്? എക്സ്ക്യൂസ് മീ, ഡാറ്റ പ്രൈവസി ഹൗ യു ആർ മെയിൻറ്റെയിനിങ്?
ഡാറ്റ പ്രൈവസി എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഞങ്ങൾ ഒരിക്കലും ഒരു പേഷ്യൻ്റെ റെക്കോർഡുകൾ, അതായത് ഹെൽത്ത് റെക്കോർഡുകളൊക്കെ ഞങ്ങൾ ഇതിലേക്ക് എടുക്കുന്നില്ല. നമുക്ക് അവർക്കുള്ള ബേസിക് ആയിട്ടുള്ള അവരുടെ അപ്പോയിൻമെൻറ്റിന് വേണ്ടിയിട്ടുള്ള അവർ കോൺടാക്ട് ഡീറ്റെയിൽസ് അതുപോലെ തന്നെ അവരുടെ പേര് മാത്രമേ ഞങ്ങൾ ഇതിലേക്ക് ഫീഡ് ചെയ്യുന്നുള്ളൂ. അപ്പോൾ അതുകൊണ്ട് നമുക്ക് എന്ത് ചെയ്യുക, അതിനെക്കുറിച്ച് കൂടുതൽ വേറിയുടെ കാര്യമില്ല. പിന്നെ ഡാറ്റ സെക്യൂരിറ്റി എന്ന് പറഞ്ഞാൽ ഇപ്പോൾ ഏറ്റവും ലീഡിംഗ് ആയിരിക്കുന്ന ആമസോണിൻ്റെ ഏറ്റവും പവർഫുൾ ആയിരിക്കുന്ന സെർവർ നമ്മൾ യൂസ് ചെയ്യുന്നത്. അത് ഇന്ത്യൻ ഗവൺമെൻറ് ലീഗൽ വാലിഡിറ്റി അതിനുണ്ട് കറക്റ്റായിട്ട്. പിന്നെ ഞങ്ങൾ സ്റ്റാർട്ടപ്പ് ഇന്ത്യയുടെയും സ്റ്റാർട്ടപ്പ് കേരളയുടെയും അണ്ടറിൽ വരുന്ന കമ്പനിയാണ്. ഞങ്ങൾ സ്റ്റേറ്റ് ഗവൺമെൻറ്റും ഇന്ത്യ ഗവൺമെൻറ് മോണിറ്റർ ചെയ്യുന്ന ഒരു കമ്പനിയാണ് ഞങ്ങൾ.
Thank you, Mr. Adish, for the short and impressive session.
Thank you, ma'am.
I invite Dr. Mohan to please present the momentum to Mr. Adish. I invite Dr. Venugopal B., President IMA Kozhikode, to present the momentum to Dr. Mohan. Now we are approaching the next session, approach to chest pain in emergency. I welcome the speaker, Dr. Sandeep Mohanan, Head of Cardiology Department, KMCT Medical College, Calicut. I welcome Dr. Sajeev sir to chair the session. Welcome, sir. A few words on Dr. Sandeep. He did his MBBS from Calicut Medical College, MD from AIMS New Delhi, DM from Calicut Medical College. He focused training in complex coronary and structural cardiac interventions at Mount Sinai Hospital. He's a second rank holder in the state medical entrance examination by Government of Kerala. He is the first rank in DM cardiology entrance examination. He's a gold medalist in the cardiology DM 5.
Hello. Good afternoon, respected teachers, respected Sajeev sir. First of all, thank you, CGP team, Chandni madam and Dr. Ranjit for inviting me to give this brief session on chest pain in the emergency and GP clinics. So I'll be talking about the plausible diagnostic diversities of chest pain, mostly focused on the cardiac aspect. When a patient comes with chest pain to your clinic or in the ED, how to deal with it based on a few examples so that you get an idea on how to evaluate these patients. So the ED is always a mess, and not only just the ED. When a patient comes to the clinic with an emergency, it's always a mess, whether what to do first, how to make the diagnosis, how to manage the patient's vitals, and how to convey the same to the relatives. And why we should be on your toes always, because diagnosis is utmost importance, then only we can plan the treatment. Complications can happen very fast, especially the final stage of death. The next issue is the bystander aggression and the volatility at that point of time when the patient comes with chest pain, because they would be thinking of the worst. And the last thing is the litigation. So whenever we see a patient with chest pain, you should not compromise based on the cost of evaluation. You should always compare the cost of evaluation using the modalities available in your clinic or ED versus the personal risk that can happen. When a patient comes with chest pain, it is most important to assess whether this chest pain is a low-risk chest pain or a high-risk chest pain. When a patient comes with a low-risk chest pain, it is mostly pathologies that involve the muscles, nerves, cartilages, bones, and sometimes the GIT. High-risk chest pains usually involve the heart, aorta, lungs, and also the GIT, but there can be some interrelation also. There can be low-risk chest pains arising from the heart, such as in pericarditis, and some high-risk chest pains can come from the bones, fractures, etc. So how to approach any patient who comes with chest pain? The first thing you should check is the immediate care, the A, B, and C, the heart rate and the blood pressure. See if the patient is stable and hemodynamically fine. Then ask the right and relevant questions, the history, whether the pain is typical or not, how the patient presented, the past presentation, past treatment, the risk factors of the patients are of utmost importance, the treatment history, what that patient was on when he came to your clinic. Then you should never forget to do the examination. Heart sounds and respiratory sounds should always be looked for, and look at the abdomen also for tenderness and other possibilities of chest pain which can arise from the abdomen. The investigations that you should do is, the most important thing when a patient comes with chest pain is ECG. It is part of the clinical examination now, and no patient should be sent off saying that this could be just gas. Then whatever is available in your clinic or emergency, do a troponin, do the basic blood test, if possible an amylase and a D-dimer as well. If you have a point of care ultrasound in your lab or in your clinic, try to do a bedside screening echo and to look for any dangerous pathologies or involvement, and if possible, get an X-ray or CT if it is in the emergency. Any patient who comes with chest pain, you should always conclusively rule out acute coronary syndrome. That is the most important thing, and only after you have ruled out ACS, you go for other diagnosis. So this all depends on the typicality of the chest pain, the various symptoms, sweating, nausea, palpitations. If the patient has come with a syncope, then it is a definite high-risk sign. The age, previous risk factors, as we previously mentioned. At least 2 ECGs should be done 4 to 6 hours apart. And at least 1 troponin should be done, preferably 2 troponins, around 6 hours apart. Do the HS tropi immediately after admission and then repeat after 4 hours. Many a time the GP colleagues often have a doubt that the patient's symptoms started only 2 hours ago, why should I do the tropi right now? But what the patient says may not actually be true. The patient may be a diabetic, the symptoms might have started the day before. So it is always best to do the tropi when the patient comes to the ED and then repeat it after a few hours again. A screening echo will also be very useful. You can look for LV dysfunction. If you can identify RWMA, it is also useful. Of course, you can also find out effusions. And even if you do not find anything abnormal, and if you think the chest pain is benign, it is always good to send the patient for a physician or cardiology consultation on the next available date. So I'll go through a few examples just to guide you on how to go through a patient with chest pain. We are not going to the theoretical aspects. So this is a 28-year-old male who came with severe chest pain since 2 hours, no other symptoms. Tropi was negative. You can see that the ECG is essentially normal. How did the RMO manage? She gave a Rantac and Tramadol. It was in a peripheral clinic. The symptoms immediately decreased. Many a times, a patient with myocardial infarction can have immediate decrease of symptoms with all these Tramadol and Rantac because all the symptomatic aspect of that would have come down. And once the symptoms decreased, this patient was sent home. However, after 3 hours, this patient had a sudden cardiac arrest at home itself, and he was brought dead to the same ED. This had become a recent issue a few years ago because nobody could resuscitate the patient, and the patient could also not be referred to a cardiac center, and the patient died. So where an MI with a normal initial ECG, even though the textbooks say it is seen in 5% of the patients, it could be avoided if you can admit or observe the patient for some time in your casualty, do a repeat ECG follow-up after a few hours, do a repeat troponin and explain the importance of doing the troponin to the bystanders and the patients. Never give too much reassurance to the patient without a full protocol-based observation and a mandatory troponin test. And most of the death in myocardial infarction is due to arrhythmia, which can cause sudden death. Patient 2, this is a 56-year-old female, diabetic, hypertension, dyslipidemia. You have all the risk factors for an acute coronary syndrome, presented with chest pain and breathlessness for 4 hours. Here you can see that there is a definite ST elevation, Q waves in V1, V2, V3, and V4. So the diagnosis would be anterior wall MI. The patient had come to a center where cath lab was not available, and the physician immediately gave streptokinase and referred to our center. However, the patient, during shifting itself, the patient had a massive GI bleed. Patient progressed into heart failure, got ventilated, and the patient was very sick on arrival. Once the patient came, we did a screening echo, and this was the finding. So this is one very interesting diagnosis that you should think about in any patient who present with any type of ECG changes in chest pain and heart failure. This was actually a case of Takotsubo cardiomyopathy, also called as a stress cardiomyopathy. It is not at all uncommon. We see it routinely at least weekly once, especially in the oncology sector where patients get chemotherapy, undergo through multiple surgeries, etc. We have to document an angiogram that the coronaries are normal. This patient was later stabilized, and we need not give any antiplatelets and anticoagulation because once the LV function improves, these are all not required. So any patient, stress cardiomyopathy can present in any forms, VT, VF, chest pain, heart failure, syncope. It has presented in the way of inferior wall MI, anterior wall MI, and various presentations can also be seen in the echo, like a reverse Takotsubo, where the ballooning that you see in the apex is actually at the base, and then there can also be focal cardiomyopathy. So it is one thing that any patient who comes with chest pain, we should think of such diagnosis before, especially thrombolizing a patient. So this is a patient who came with stress cardiomyopathy masquerading as MA. So the learning point is, it is not uncommon. And thrombolysis mostly for MI is mostly an outdated modality, especially with streptokinase. But once you are sure that it is a coronary involvement and there is a definite ST elevation MI with ongoing symptoms and there is no availability of cath lab where you can shift within 1 hour, then there is no other option but to go ahead with thrombolysis. But never thrombolyze without getting a physician or a cardio opinion. Patient 3 is a 54-year-old male, again chest pain. He was having diabetes, hypertension on chronic Ayurveda treatment. So this call came while I was driving and the CCU physician told me, sir, it is a case of anterior wall MI with inferior wall MI. We see such mid-LAD occlusion patterns. You can see diffuse ST elevation in most leads and ST depression in AVR. And I asked them whether they could be shifted to a cath lab. They were not willing. So they proceeded to go with streptokinase. However, I asked him to do a bedside screening or echo just to be sure that we are not missing anything. And I checked the ECG once again to make sure that it was not a focal regional wall motion involvement, that is ST elevation involving one anterior wall or inferior wall. It was a diffuse ST elevation. So the echo showed that there was severe LVH and no RWMA. So then we could wait. We gave the patient symptomatic treatment and awaited the reports. The creatinine was 7.8. So this was a case of uremic pericarditis. So whenever you see ST elevation, you need not think of acute coronary syndrome always. Also think of other possible diagnoses. If this patient had a streptokinase, he might actually have got into pericardial hematoma and died. So always wait for the reports, look for more data, get a better history from the patient. You won't be missing uremic pericarditis often. Again, the importance of the clinical scenario is important. Echo is not mostly available everywhere, but a point of care ultrasound is mostly seen in most emergency departments, and you should use it to make initial differentials of ST elevation. The patient 4 is a diabetic hypertensive patient with severe central chest pain and back pain. The BP was very high, 200/100, but the ECG showed findings of inferior wall MI. So, you know, severe central chest pain and back pain, you should think of another diagnosis rather than just an ST elevation MI. And on examination, the patient had a definite radial delay, and the CT showed a significant, you can see a dissection across the aorta with a false and true lumen. And this was a case of type A aortic dissections. Type A aortic dissection may often cause inferior wall MI because sometimes the dissection flap can extend down into the right coronary sinus and occlude the right coronary artery. So again, the importance of physical examination in any patient with chest pain. You should think of other diagnoses when you have a radial delay, atherosclerosis, Takayasus, again aortic dissection. It can also come as a complication of angiography. The radial pulse may be absent once the patient has one or twice angiograms because of radial artery thrombosis. Now this was an 85-year-old male with chest pain since 1 hour. Loading was given. And this was the initial ECG. If you can appreciate the ECG, you can see diffuse ST depressions in 1 AVL, V3, V4, V5, V6. Again, ST elevation AVR. We call this the triple vessel disease pattern, TVD pattern, or LMCA pattern. So these patients are considered to be high risk. However, the next ECG was normal. Immediately after the loading, patient was not willing for further evaluation. Patient was anyway admitted as unstable angina. The tropi was negative. However, on the 4th day of heparin, the patient went for VT heart failure and became intubated sick. So we are forced, even though the patient was 86-year-old, we were forced to take an angiogram. Here you can see that the left main coronary artery ostium is 99% occluded. So this was the cause of the initial unstable angina. And we had to proceed with angioplasty, and you can see that it was fixed. We put a stent in the left main ostium, and the patient became fine. So the message is that unstable angina does not mean low risk ACS. It is just that the patient has not progressed into myocardial infarction. You should look at the other clinical aspects of the patient, the ECG, and correlate. And if possible, if the patient is healthy enough, always complete the workup with an angiogram, because this patient may actually get treatment and go home and die with heart failure. So unless this is treated, the patient won't be surviving. So unstable angina does not mean low risk chest pain. Patient 6 is a patient with diabetes, hypertension, and had again ST elevation MI, but the cardiogenic shock and pulmonary edema was not improving with any forms of medical therapy initially. The echo showed a good LV and the diagnosis was inferior wall MI, and there was no evidence of RV involvement in the ECG. So, so we did this was a screening echo from the casualty. Once the patient was shifted, then since the BP was not coming above 50, we went for a detailed echo. Here we can see that the ventricle is completely torn off, ventricular septum is torn off in the middle, in this part. So this is a mechanical complication of chest pain or ST elevation MI, and patients with severe shock may be having these dangerous diagnosis, that is ventricular septal rupture, free wall rupture. These are very important to document because it is important to explain to the bystanders and to make a final diagnosis, and these patients seldom survive without a definitive surgery or a complicated catheter-based intervention. This is a 63-year-old male with chest pain, atypical chest pain, and there was one episode of syncope. I'm just putting up this slide again to show the diversities of how a chest pain can go around. Again, this you can see that there is ST elevation V1, V2, V3, V4. It is an anterior wall MI. Initially, the rhythm was missed from the casualty because the patient had a stable heart rate. The ECG rhythm was not properly checked, and that was an error. However, later on, the patient was not willing for a primary angioplasty. Patient went on with heparinization, but within a few hours, the patient had a sudden cardiac arrest, and even despite prolonged CPR, the patient went into death. So, what is the reason? Can you identify the rhythm in this patient with anterior wall MI? You can see there is a clear AV dissociation. So, this is a patient with anterior wall MI and complete heart block. So once the patient has CHB, these patients are seldom likely to improve with medical therapy. Either you have to go for a primary angioplasty and relieve the primary pathology, or at least you have to put a temporary pacemaker to prevent the patient from progressing to the complete heart block. So you should also think of the electrical complications of chest MI, that is CHB, ventricular fibrillation, ventricular tachycardia, etc. Now this is a 28-year-old female with who was postpartum and had sudden chest pain. There was diffuse T inversions in V2 to V6, TROPI was positive. There was a good LV, and the patient was diagnosed as STEMI and heparinized. However, the patient had normal coronaries, and since the patient had normal coronaries, it is most likely a case of myocarditis. Postpartum myocarditis is not an uncommon diagnosis. The patient had a history of fever also. The re-echo showed moderate pericardial effusion, probably because heparin was used. So you should be careful when you give heparin in a patient with pericarditis and pericardial effusion. There is a chance of this progressing into moderate and massive pericardial effusion. So this case of myocarditis masquerading as myocardial infarction. Again, a postpartum lady who was 21-year-old had severe chest pain for 4 hours. The ECG was actually suggestive of anterior wall MI, and there was a suspected middle lady occlusion because there was also Q waves in 2-3 AVF taken up for primary PCA. You can see that the left anterior descending artery, there was some thrombus, but once the thrombus was aspirated, there was a long line of dissection. So this is not an uncommon diagnosis in postpartum period. Spontaneous coronary artery dissection of the LAD is reported in the peripartum period, and it is dangerous to thrombolyze these young patients, and because the treatment of such dissections is not thrombolysis. Once you get a flow, if possible, you should try and stent the lesion to open it up. Coming to patient 10, this is an 82-year-old male who had troponin positive. You can see that there is LVH with a strain pattern, ST elevations in V1 and V2, AVR ST elevation and deep ST depressions in V4, V6. It's actually an LVH with strain pattern. It was initially diagnosed as evolved anterior wall MI, and the patient again was not willing for primary, was given IV retiplase and referred. Patient again had severe GI bleed because of the thrombolysis and collapsed. So we did the echo once the patient was stable next day. You can see that the aortic valve is severely calcified. This was actually a case of severe calcific aortic stenosis. The ECG pattern that we saw initially was an LVH with strain pattern and not an anterior wall MI. The coronaries were normal. So this patient had severe calcific AS with probably Haydes syndrome. Haydes syndrome is angiodysplasia of the large intestine because of severe calcific AS. So once we thrombolyze a patient with angiodysplasia, he is definitely going to bleed. So again, the importance of doing a thrombolysis, especially in the current era. So severe AS with secondary ischemia can again masquerade as anterior wall MI. So how could you have avoided doing a thrombolysis? By just auscultating the patient. You will definitely have heard a loud ejection systolic murmur. So a patient with myocardial infarction murmur, you should think of aortic stenosis as a bystander, maybe severe MR, and probably VSR. There are different clinical criteria to differentiate all these, and you should think of all these diagnoses in patient with MI, with murmur. So this is my final patient. Again, just to tell you another exotic diagnosis, this patient had come 10 years ago, and Sajeevan sir might be knowing this patient because we had published this 10 years ago. So this is a 27-year-old male who was a manual laborer who came with chest pain, dyspnea or 8 hours, initially diagnosed as ACS from a private sector and referred to us for primary PTCA. Later on evaluation, the patient had severe tachypnea, tachycardia, the BP was 90/60, and there was significant hypoxia with a short systolic murmur in the tricuspid area and fine basal Krebs also. The tropi was not that high, but the D-dimer was elevated. Our primary diagnosis was pulmonary embolism because everything was pointing towards that. So since the patient had already come in the daytime, we took up the patient for an emergency pulmonary angiogram. And you can see that the right atrium and right ventricle is markedly dilated, and there is severe tricuspid regurgitation. This is the RA and RV. So probably pulmonary embolism is the most likely diagnosis. But however, when we went ahead with the pulmonary angiogram, it was completely neat. No occlusion in any of the vessels, neither the left or the right. And this was the IVC. IVC was also not having any thrombus. So pulmonary embolism was out of the picture. Patient was still symptomatic. So then we did a proper chest X-ray again, and we found a very interesting finding. This is called the continuous diaphragm sign, where you can see a continuous black line under the border of the heart and between the heart border and the diaphragmatic border. And an HRCT was done. It was found that the patient had diffuse ground glassing and central lobular nodules, and there was bilateral lung involvement, and there was a pneumomediastinum. This was the cause of chest pain with partial compression of the right ventricle. That was the cause of the troponin positivity, and this can cause acute cor-pulmonale, just like pulmonary embolism. So that was the diagnosis. The radiological features were suggestive of hypersensitivity pneumonitis. Again, we took a retrograde history taking. This patient then told that he had been taking the employee's PGN since the last 1 to 2 months. It was a case of bird fanciers lung, and the further workup and evaluation was all in the right direction. At 6 months of abstinence from these PGNs, the patient improved without any treatment, and the CT was also better. So the final diagnosis was hypersensitive pneumonitis with secondary spontaneous pneumomediastinum presenting as acute cor-pulmonale. So the learning point from this is that even though pulmonary embolism is the most common, we should think of other possibilities. And once, if you had taken a proper history before thinking that this could be a chest pain, myocardial infarction, you could have found out that the patient had probably had a hypersensitive pneumonitis due to PGN exposure. And a proper X-ray, the initial X-ray was not properly filmed, and we had to take an X-ray only after the angiogram was done, and then get back to the diagnosis. So always think of possible differentials in any patient with chest pain. It could be acute coronary syndrome. You should rule it out definitely, and there is a protocol for it. You should follow the protocol that was elaborated earlier. Then you should think of others also: myocarditis, pericarditis, pulmonary embolism, aortic dissection, and then the non-coronary causes: pneumothorax, esophageal rupture, gastritis, esophagitis, and the less riskier variants of costochondritis, cervical angina, etc. And it all depends on the practice that you do in your daily patient seeing, and that how you evaluate the patient. Always never miss out on the history and the examination, and then always never miss out on the basic evaluation, especially the ECG and the troponin. Thank you.
Thank you, Dr. Sandeep, for the nice illustrative cases. I think he has told about all the causes, including cardiac, non-cardiac, all causes. Because chest pain, if you take 100 patients attending emergency department, maybe less than 20 will have something related to cardiac, and maybe less than 5 will have something related to which is seriously cardiac. So if you ask me, the main analysis will be history, physical examination, ECG and troponin. If you still ask me which is important, it is still the history which is important. Because if an young patient comes with a severe chest pain, even if it is 21 years, you should look for a cause, because don't let him go as the first case maybe. And if it is, assess the clinical scenario. If an elderly patient who is diabetic or some hypertension or dyslipidemia comes with a vague chest discomfort also, then also you should be very careful, because that patient is also likely to have some cardiac problem. Then regarding one more point regarding the troponins, because nowadays everybody is doing HS troponin. Because you should remember that troponin is not equivalent to myocardial infarction. Troponin rise is not equivalent to myocardial infarction, because troponin can rise in so many conditions, and you should correlate clinically. And because nowadays, because of this HS troponin is creating a lot of problems. So I think this has, Sandeep has illustrated the cases well. Thank you.
Thank you, sir.
Thank you, Dr. Sandeep, for the wonderful session. I invite Dr. Sajeev sir to please present the momentum to Dr. Sandeep. I invite Dr. Madhav Das sir to please present the momentum to Dr. Sajeev sir. Now we'll move on to the last session. Common gynecological issues in general practice. I invite Dr. Sheba T. Joseph, consultant in OBG Health Services, Kerala. And I also invite Dr. Chandini R., Professor of Medicine and HOD, Emergency Medicine, Calicut Medical College, to chair the session. I also invite Dr. Sandhya Kurup, Consultant Physician, Health Services, Kerala, to chair the session.
Today's program is already in the YouTube. You can click onto the YouTube of IMA Kozhikode and you will get the entire program.
A very good evening. Now we are having an important topic, that is common gynecological issues in common practice. This will dealt with around Dr. Sheba T. Joseph. She is a consultant obstetrician in health service, and she is a multi-talent personality. She is a very active gynecologist. She is both academically, and she is very active in all platforms, that is IMA and all gynecological platforms. Then now she is the Joint Secretary of COX, and she is the Joint Secretary of Calicut Menopausal Society, and she is the District Coordinator of KFOG Onco Committee. I'm sure she will be giving us an excellent talk. Over to you, Dr. Sheba, for the excellent presentation.
Thank you, Dr. Sandhya, for those really nice words. A note of thanks to the organizers for this invite, and it's indeed an honor to be involved in this academic feast. Good evening, ladies and gentlemen. And in the next half an hour, I'll be taking you through a beautiful journey, and indeed an inevitable one, as far as the general practitioners are concerned. The common gynecological problems. And I'll be touching upon these milestones as I move along. The menstrual disorders, vaginal discharge, pelvic pain, lower abdominal mass, and dyspareunia. So now Dr. Ranjit has warned me that you better stick to the basics. So I'll keep my word and I'll be making it as simple as possible. No one else sees it. No one else wants to. Only she can see the beauty in her blood, and that's menstruation. The essence of womanhood depends on the hypothalamo-pituitary-ovarian axis. The regulating hormones from the hypothalamus, the FSH and LH from the pituitary, the estrogen and progesterone from the ovary acting upon the endometrium. You have the estrogenic effect on the endometrium as the proliferative phase, and the mid-cycle, you have the LH surge, which causes ovulation, and later on, the progesterone, which acts on an estrogen-primed endometrium to give the secretory changes and the progesterone withdrawal around the 21st day, which gives rise to a withdrawal of progesterone and the menstruation. There is always a thin line of difference between the normal and the abnormal. So you say that it's a 28-day cycle as a normal, but a 1 week over and below can be treated as normal. And normally a woman has got a 2 to 8 days duration of flow, with the first 2 days a bit lesser in amount and third and the fourth day a bit more. She loses around 15 to 80 ml of blood per menses, and normal of 3 to 6 pads are to be changed per day. Terminologies are always old wine in new bottle. So now the menorrhagia is being replaced by the heavy menstrual bleeding, and the term DUB has been abandoned and it has been replaced by abnormal uterine bleeding. Females are the most beautiful, gorgeous creatures in the whole world, and I think that we are gorgeous no matter what size we are. They are different. So are their periods. So let's take one by one. You have the heavy menstrual bleeding, where the cycle is irregular, but it might be heavy bleeding or prolonged one. Irregular bleeding when there is a difference in the cycle length. The intermenstrual bleeding when you have small bits of bleeding in between the cycles. Amenorrhea and menopause is the absence of menstruation for 1 year or more in a woman in the perimenopausal age group. We start off with the abnormal uterine bleeding, which is one of the commonest complaints, gynec complaints that you encounter in the general practice. And it's any bleeding from the genital tract that is deviation from the normal in frequency, the cyclicity, the duration, or the quantity. It's more common in the adolescent age group and in the perimenopausal age group. Regarding the causes of abnormal uterine bleeding, you have the palm coin classification, where the P stands for the polyp, A for adenomyosis, L for leiomyoma or fibroid, the malignancy, hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. We'll be taking one by one. The endometrial polyps are the localized overgrowth of endometrial tissue, and it's commonly found in the reproductive age group. It's due to estrogen stimulation, and usually they are benign, and if they are symptomatic, that can be removed by an operative procedure, especially hysteroscopy. Adenomyosis or AUBA is the presence of endometrial glands and stroma in the uterine myometrium, and multiparity is said to be one of the most important risk factors. It can be due to any other causes which cause a damage to the endometrial layer, example, dilatation and curettage, the cesarean delivery and spontaneous abortions. An ultrasound is diagnostic. You get an uniformly enlarged uterus of less than 12 weeks. And the most important symptom what the patient presents is with profound congestive dysmenorrhea. And the treatment of adenomyosis has been changed. Now we have got excellent treatment modalities like the progesterone, that is Dynagist, and the LNG IUS, which I'll be coming to later. leiomyoma fibroid, all of us are so familiar with that. They are benign tumors of the uterine myometrium. And you have the intracavitary, intramural, and subserous fibroids, and the presentation depends upon the position of these fibroids. You have the revolutionary management of fibroids with mifepristone and ulipristal, or you could have a surgical management which includes myomectomy or hysterectomy if needed. AUBM, or the malignancy, the one thing that you have to rule out is the cancer cervix, the endometrium, vulva, vagina, and the adnexa. Most characteristically, the cervical malignancy presents with post-contact bleeding or intermenstrual bleeding. And in any case where you suspect a hyperestrogenic state, which can cause an atypical hyperplasia like chronic anovulation, PCOS, obesity, nulliparum, all these things can lead to endometrial cancers. There's an entity called Lynch syndrome or hereditary non-polyposis colorectal cancer, which has got a strong link to the risk of endometrial cancers. The coagulopathy, like von Willebrand's disease and ITP, are to be thought of, especially in adolescent age group, and where you have an heavy menstrual bleeding at menarche. So in adults, the screening for coagulopathy is done only when they are symptomatic, like with epistaxis or ecchymosis. AUBO, this is one of the commonest causes of abnormal uterine bleeding, and these are due to the alterations in the neuroendocrine system. And there is a continuous estradiol production, so oligoanovulation of menstrual irregularity, where you have 2 or 3 months of amenorrhea followed by heavy menstrual bleeding. And hyperandrogenism, which is manifested as acne, hirsutism, alopecia, and a PCO picture on ultrasound. The one thing that you have to keep in mind is just by getting an ultrasound picture of PCO, it doesn't mean that the woman has got an PCOD. Because almost 20% of normal women can have a PCO picture on an ultrasound. There will be an insulin resistance, and it can lead to obesity, acanthosis nigricans, which are dark colored striae that are seen on the neck and the axilla. The anovulation can lead to infertility, and if at all she becomes pregnant after ovulation induction, there is high risk for pregnancy losses and, of course, gestational diabetes, which is on the rise. Should the PCOS be treated? So why am I giving such an importance to PCOS? Of course, it should be, because there are long-term consequences of PCOS, like the metabolic syndrome, the type 2 diabetes, the dyslipidemia, coronary artery disease, the endometrial cancer, the breast cancer, and psychological changes like depression and anxiety. So definitely, if a person has got a clinical feature of PCOS, it should be treated. These are the endocrinological abnormalities in PCOS, like an elevated LH and altered LH-FSH ratio, the increase in the androgens, elevated fasting insulin, and abnormal GTT. But for practical purpose, to diagnose PCOS, you can have it by clinical diagnosis. There is no actual need for that, all those PCOS lab investigations. The management of PCOS depends upon the age, the clinical features, and the desire for fertility. For example, an adolescent age group is more concerned about their acne, their obesity, their hirsutism, while a person in the reproductive age group will be concerned about their infertility. So the treatment should be designed according to their needs. But the cornerstone for the treatment is the lifestyle modification, the weight optimization, OC pills if you need the cycle regulation, metformin for obese PCOS, ovulation induction for subfertility, and the help of a dermatologist if needed. The abnormal uterine bleeding, E or the endometrium, is due to an abnormality in the platelet plug formation, a decrease in the prostaglandin F2 alpha, or an increase in the prostacyclins. Now there are certain conditions that we tend to produce, and that is the iatrogenic causes like an IUCD, the LNG IUS, the postmenopausal hormone therapy, and if there is no other cause found, they are classified as not yet classified, and hypothyroidism comes under that. History taking, we should inquire about the age of the menarche, the parity, the cycles, dyspareunia, infertility, vaginal discharge, IUCD, OC pills, and the symptoms of hypothyroidism and bleeding disorders. You tend to have a very meticulous physical examination. The breast and thyroid should be examined, and a good bimanual pelvic examination is a must. A general practitioner should go in for a complete blood count, and the coagulation profile only if needed. A thyroid function test is a must, and ultrasound, preferably a transvaginal one, would clinch the diagnosis. To rule out cervical cancers, you have to have a screening methods, and the HPV DNA is the one that is recommended by the WHO, though it is costly. In Kozhikode, we have started the screening with VIA, or the visual inspection acetic acid, which is feasible in a low resource setting. The endometrial sampling with a PPLA, usually now the DNC is mostly out for the sampling of endometrium. You do it with a PPLA, and that is useful to rule out endometrial hyperplasia. Again, the management depends upon the age, severity of bleeding, and the medical comorbidities. You have to have the general management of anemia. You have to regulate the cycles, and you have to prevent the recurrences. We come to the definitive management of abnormal uterine bleeding. You have the medical and the surgical options. In the surgical option, if you have a polyp, you have to remove it hysteroscopically. Medical management, again, it's divided into non-hormonal and the hormonal. In the non-hormonal treatment, the antifibrinolytics like tranexamic acid is used as the first line of management to stop bleeding. NSAIDs like mefenamic acid can be used alone or in combination with the tranexamic acid, and it is of use especially when the woman has got dysmenorrhea. The capillary fragility inhibitors like ethamsulate are no longer recommended. The hormonal, the treatment can be along either progesterone alone, estrogen progesterone combinations, or estrogen alone. So what are the progesterone which are used orally? We have the medroxyprogesterone acetate, norethindrone, or what we normally known as Primolute N, that's what all of us know, or norethindrone. So for the hemostatic dose of progesterone, oral progesterone, we can use either of the three. And when we are giving a hemostatic dose, it is the higher dose. So when you are giving a Primolute or norethindrone, you can give it as 2-2-2 or 6th hourly, and then for 3 or 4 days, so that the bleeding stops. And next comes the most important thing. Once the bleeding stops, you have to reduce the dose and taper the dose. That is, you give 2 tablets thrice daily to 4 or 5 days, the bleeding stops. Then taper the dose, have it 1 tablet thrice daily for 3 or 4 days, 1 tablet BD for 3 or 4 days, and then you taper it till 21 days. And that's what really the doctors working in the periphery go wrong. Medroxyprogesterone can be used, and norethindrone can also be used with tapering dose. Now, what if the patient's complaint is just irregular cycles, she's not having acute bleeding now? Then you can give norethindrone for the last 10 days, that is 15 to 25 days, you can give norethindrone. The second option, which can be given as intramuscular injections, is medroxyprogesterone acetate depot preparation, and now it's available in the government sector as Anthera. But the side effects, a bit of side effects which can occur is irregular bleeding, later can go in for an amenorrhea, and a temporary change in the bone mineral density. If you ask me which is the best innovation that has made a tremendous impact on the management of abnormal uterine bleeding, I would vouch on LNG IUS. It is a progesterone intrauterine system which contains levonorgestrel. It's somewhat like a copper T, but it contains, instead of copper, it contains hormone levonorgestrel. And it is as effective as endometrial ablation for the treatment of heavy menstrual bleeding. And when should you change it? If you're using it for a contraceptive use, you can use it up to 5 years. But if it is for the bleeding, you have to change it every 3 years. If you need cycle regulation, the best one would be an estrogen-progesterone combination. And the low-dose pills are also available, like Femilon, which can be used. And the low-dose pills are also very good and safe in the perimenopausal age group. Is there a role for estrogens? So estrogens are not commonly used. It is to be used in atrophic endometrium, where you give the estrogens first for the first 5 days, and then you go in for the estrogen-progesterone combination. So now in this, the points to be remembered are, before you go in for a long-term hormonal therapy with the estrogens or progesterones or the combination, you have to have the endometrium sampled to rule out an endometrial carcinoma. And when you're starting the hormones for treatment, always have it in a tapering dose. In a perimenopausal age group, you have to rule out malignancy. We go on to the menstrual cycle irregularities. The menstruation is the culmination of all the pubertal changes. And it usually occurs around 12 to 13 years, but now, for practical purpose, we are seeing it a bit earlier. So when would you investigate a girl if she has not attained a menarche? If she has got secondary sexual characters like the axillary hair, pubic hair, if she has the secondary sexual characters, you can wait up to 16 years to investigate her. But if she doesn't have the secondary sexual characters, you have to have a proper investigations by around 14 years. If the menstruation starts before 9 years, you have to call it as a precocious menarche, and a precocious puberty is when the pubertal changes starts before 8 years. The amenorrhea, primary amenorrhea, depends upon the hypothalamo-pituitary ovarian axis, the hormones, excessive weight loss, obesity, thyroid dysfunctions, and also you have to remember in primary amenorrhea that the imperforate hymen. The secondary amenorrhea is the absence of menstruation for 6 months or more in a regularly menstruating women. And the one thing that is to be ruled out is pregnancy and its related complications. And many times you may get a patient on psychiatric medicines too. Now, how will you manage a secondary amenorrhea? You can give a progesterone challenge test. The progesterones which can be used are medroxyprogesterone, norethisterone, micronized progesterone. So what do? You give them for about 7 to 10 days. But if you are in doubt that she might be pregnant, in that case, go in for a natural progesterone, that is the micronized progesterone. And if there is bleeding, you call it as a positive test. And if she doesn't have a bleeding with progesterone withdrawal, you have to go in for an estrogen progesterone challenge test, because the progesterone acts only on an estrogen primed endometrium. The next common cause is dysmenorrhea. Dysmenorrhea can be of many types. You have a spasmodic dysmenorrhea, which we have in the first or second day of the cycle. It is colic in nature. And the congestive dysmenorrhea, it might start before the onset of periods. It can last throughout the periods and even overshoot the time of the periods. A primary dysmenorrhea means it starts around the time of menarche, and secondary dysmenorrhea starts some years after the onset of menarche. But a secondary dysmenorrhea is usually congestive in nature. The 3 things that you have to rule out clinically when you get a case of secondary dysmenorrhea is, 1 is endometriosis, 2 is adenomyosis, and 3 is chronic PID. How do you treat dysmenorrhea? All of you know it's by NSAID, hormone pills if you want, and cycle regulation, injection DMPA, and long-term LNG IUS. What happens when the vagina leaks? A woman and a soldier who don't defend the first pass will never defend the last. So what is the defensive mechanism of a woman? That is the lactobacillus. The hydrogen peroxide, the lactic acid, all these helps to keep the pH of the vagina by around 4.5. When a woman comes to you with vaginal discharge, can it be normal? Is there something called a physiological or a normal discharge? Yes, you have it. It is periovulatory, premenstrual, and it can occur normally in pregnancy too. The one thing you have to keep in mind, when a child comes with vaginal discharge or pruritus vagina, you have to think about vulvovaginitis. It could be due to the estrogen deficiency. And the worm infestation should also be kept into mind. So how will you differentiate between a normal physiological discharge and a pathological discharge? There are certain questions that you have to ask. One, is there any foul smell? Is it associated with itching? Is there any color change? The nature of the discharge, is it greenish, foul smelling? It means trichomoniasis. And curdy white, it means candidiasis. And blood stained, always rule out malignancy. These are the simple tips, and many other times we can come to a clinical diagnosis. The most important thing to prevent the recurrent infections are the counseling and treatment of partners, use the condoms, and you have to treat the underlying diseases like diabetes. The bacterial vaginosis and trichomonas vaginitis can be treated with metronidazole, candidiasis with fluconazole or itraconazole. Then we have the chlamydia trachomatis, which can be treated with azithromycin and doxyl, and Neisseria with cefixime and azithromycin. The investigations, you can have a wet mount, a KOH preparation where you have a whiff positive or a fishy odor when you add KOH with bacterial vaginosis. A gram stain, you get a diplococci in gonococcal infection. In postmenopausal women, just think about two causes. If you have recurrent urinary tract infection or frequency of micturition or a discharge or a recurrent pruritus of the vulva in a postmenopausal woman, most common one could be due to estrogen deficiency. And the second one, do rule out malignancy. Lower abdominal mass could be from the internal genital organs or from the bowel, bladder, and other organs. In the adolescents, if she has amenorrhea with a cyclical pain, think of the outflow obstruction like an imperforate hymen. And if there is no cyclical pain, it could be from the paraovarian sides or from the ovaries. And in all these cases, an ultrasound and MRI can clinch the diagnosis. In the reproductive age groups, always rule out pregnancy and its related complications. Then it could be fibroids, adenomyosis, endometriosis, and ovarian tumors. In the menopausal women, yes, as I always said, rule out malignancy. And if you have an adnexal cyst greater than 5 centimeters, or it has got solid components, is multiloculated, and you have an abnormal blood flow in Doppler, you should think of a malignant ovarian tumor, and you are supposed to do the tumor markers like CA125 and CEA, and that rules out the epithelial ovarian tumors. We have the acute abdominal, lower abdominal pain. With amenorrhea, always think about pregnancy, and especially think about ectopic pregnancy, because only if you think of pregnancy and ectopic, you will diagnose an ectopic. The non-gynecological causes of acute lower abdominal pain, please think about urinary tract infections and acute appendicitis and all the other causes. Chronic abdominal pain, again, it could be due to adenomyosis, endometriosis, PID, but if a person has got a previous surgery, there are certain things to be thought about. If it could be due to additions. And if she's had a hysterectomy and the ovaries are kept behind, it could be due to a residual ovary. If she has got an oophorectomy, that is, the ovaries are already removed, but a part of the ovary may remain, and it can cause a remnant ovarian syndrome. So dyspareunia, this is one thing that maybe the patient will come and tell you, but you are difficult, it makes you difficult to ask the patient what her complaints are and to ask her to detail on it. So dyspareunia can be either superficial or deep dyspareunia. And vaginismus, which is an involuntary spasm of vaginal muscles and levatorinae, is a form of superficial dyspareunia. Here are the causes for the superficial and the deep dyspareunia, but in deep dyspareunia, you think about endometriosis and chronic pelvic inflammatory diseases. So at the end of this talk, let's have some take-home messages. The causes and treatment of gynec problems depends upon the age group. If you want to do an endometrial sampling for a thickened endometrium, it should be done always premenstrually. That is, if you want to do an Pipele aspiration or a DNC to diagnose the causes for abnormal bleeding in a hypoplastic endometrium, please do it premenstrually. So so that you get a thickened endometrium. If you want to do an ultrasound, evaluate the endometrium, the thickness of the endometrium, do it post-menstrually. So if you're advising an ultrasound, give it post-menstrually. And in a perimenopausal age group, always rule out a malignancy as the cause. And in deep dyspareunia and in congestive dysmenorrhea, always think about the 3 possibilities of adenomyosis, endometriosis, and PID. In a woman of reproductive age group, always ask for the LMP. It's for safe drug prescription and also to rule out pregnancy and its related complications. So ladies and gentlemen, as I come to the fag end of the talk, I'll wrap up my session with a famous quote by one of the best things that ever happened to me is that I'm a woman, and that is the way all females should feel. And this is by the one and only Marilyn Monroe. And don't let their dreams be just dreams. You should take care of themselves as they take care of them. Thank you so much for the patient listening.
Thank you, Shiba, for exhaustively covering all the things over 30 minutes. I think we were supposed to finish today's program by 3:30, but now it's 4:30. But we have most of us remaining in the hall. And most of the time, we always get a question for going some pilgrimage or something like that. Give some, most of the time, WhatsApp. We give you a tablet for postponement of my periods for so many reasons, and it comes as a very genuine request. And what should we be actually doing? Which situation we can prescribe, which situation we should not?
This is one of the commonest things that a woman comes to in the general practice. And so I think I've mentioned the basics in this talk. If you want to prolong the periods, you know that progesterone is the hormone which is used to prolong the periods. So menstruation is caused due to withdrawal of progesterone. So you should be prescribing progesterone. The progesterones which can be prescribed are norethistron, which is commonly we use, or medroxyprogesterone. So norethistron, all of us know, it is primalotin is the commonest trade name that we use. You can give it if you have got time. That is, if the woman comes to around 1 week before her due periods, you can give it 1 HS till the day for which she wants to prolong her period. But if she comes 2 or 3 days before due periods, you have to give it BD. But you should tell them that there can be, if the periods is already due, she can have a bleeding in between. But the one word of caution which I would like to tell is that if you think, ഇപ്പോൾ പലപ്പോഴും വരണം നമ്മുടെ അടുത്ത് വരണം വെച്ച് കഴിഞ്ഞാൽ കുട്ടിക്ക് ചോറൂണാണ്, അല്ലെങ്കിൽ അവിടെ കല്യാണമാണ്, അമ്പലത്തിൽ നിന്നാണ് കല്യാണം. പക്ഷേ അങ്ങനത്തെ കേസിൽ ഇഫ് യു തിങ്ക് ദറ്റ് ഷീ ക്യാൻ കൺസീവ്, അതായത് സ്റ്റെറിലൈസേഷൻ ചെയ്താൽ പോലും കൺസീവ് ചെയ്യില്ലാന്ന് പറയാൻ പറ്റില്ല. പക്ഷേ ഇഫ് യു തിങ്ക് ദറ്റ് ദർ ഈസ് എ പോസിബിലിറ്റി ഓഫ് കൺസീവിങ്, ബി ഓൺ ദ സേഫർ സൈഡ്. ഓൾവേസ് ബി ഓൺ ദ സേഫർ സൈഡ് വെൻ യു ആർ ഡീലിംഗ് വിത്ത് എ വുമൺ, ബിക്കോസ് അവിടെ പ്രഗ്നൻസി നമ്മൾ ആലോചിക്കണം. സോ യു ബി ഓൺ ദ സേഫർ സൈഡ്. യു ഗിവ് the natural progesterone. നമ്മൾ സസ്റ്റൻ എന്നൊക്കെ പറഞ്ഞാൽ നമുക്ക് അവൈലബിൾ ആയിട്ടുള്ള നാച്ചുറൽ മൈക്രോണൈസ്ഡ് പ്രൊജസ്ട്രോൺസ് ഉണ്ട്. യു ക്യാൻ ഗിവ് 300 SR, സസ്റ്റൻ 300 SR, ജസ്റ്റ് ലൈക്ക് യു യൂസ് ഇറ്റ് നോർത്തിസ്ട്രോൺ. അതായത് സ്റ്റാർട്ട് early and then you give it till the day that she wants the due periods are, till the day which she wants to prolong.
Any questions? Otherwise, we will conclude. Thank you so much.
Thank you, ma'am.
I always, when I listen to Shiba, who is a dynamic personality, what is the definition? Dynamic personality is if it's full of energy and full of new and exciting ideas. So I always think you as a dynamic person. Thank you for the good presentation from both of us. Thank you.
Thank you, Shiba Madam, for the wonderful presentation. I invite Dr. Chandini, Professor of Medicine, HOD of Emergency Medicine, Medical College, Calicut, to give away the momentum to Dr. Shiba. So now we are ending our program. We'll assemble again at 7 p.m. for the cultural activities. So see you soon. Thank you.
I request Dr. Sarida to give a memento to our dear Sabina. She has been with us all the day. Please. And I don't think we will go for a proper valedictory function, but thank you so much for being with us till 4:30 p.m. from morning. Thank you so much. Please come. But
പറഞ്ഞിട്ടുണ്ട് 7 മണിക്ക് എന്തായാലും പറഞ്ഞില്ലേ വെള്ളം അല്ലേ AC